everyone is on time.
Hi Divakant.
Hi, boss.
Hi, how are you?
We are live.
So, good morning, everyone, and welcome you to the second day of the AIOS-YOSI Young Ophthalmologist Forum. Today, we have sessions like the residency roundtable, the subspecialty training roundtable, and the practice roundtable as well. So, without wasting much time, we'll move on to the first session, that is acquiring clinical skills during residency. And Dr. Anujit Paul will be moderating. He's an exceptional second-year resident from MGM Pondicherry. Over to you, Dr. Anujit.
Thank you, sir. Thank you very much. It gives me great pleasure to begin the residency roundtable. And we'll be beginning with a very pertinent topic for residents, that is acquiring clinical skills during residency. I will be the moderator for this session. And joining me is a very, very esteemed panel of young ophthalmologists from all over the country. I would first like to introduce them and then dive right into the session. First, I would like to introduce Dr. Gunjan Saluja, who is an MD from AIMS, a DNB, FICO, FAICO, and in pediatric ophthalmology and squint. She is currently a senior resident in squint neuro-ophthalmology and oculoplasty subspecialty at RP Center AIMS with over 30 publications to her name. Our second panelist is Dr. Chintan Desai. He is a vitreoretinal consultant practicing in Vivekananda Netralaya in Dehradun. He completed his DO from RIO Kolkata and his secondary DNB from Shankar Netralaya, following which he underwent his VR training from Shankar Deva Netralaya in Guwahati. He is also an executive committee member at YOSI. Last but not the least, our final panelist is Dr. Saurav Bose. He completed his MBBS from NRS Medical College, Kolkata, and his MS from King George Medical College. And he is currently a comprehensive ophthalmologist practicing at Nayan Jyoti Netralaya Eye Center in Calcutta. So starting off with the session promptly, I would like to direct my first question at Dr. Gunjan Saluja. As residents, I feel starting off with something major. Neuro-ophthalmology is a sore spot for residents, including myself. So in a busy OPD setting, when a resident is faced with a patient coming with a suspected neuro-ophthalmological disorder, ma'am, how would you manage such a case in the OPD?
Thank you, Dr. Anujit, for that question, and a very good morning to everyone present. The question is very hard to answer in 3 minutes, but yes, I have made some pearls. So first thing is that a resident must read. Okay, you have to read because your eyes will see only what your brain knows. So I can suggest you some books like Walsh and Hyatt. Its recent editions by Dr. Prem Subramaniam is a simplified version of the same. Or you can also carry a handbook by Dr. Nancy Newman, which can solve most of the queries in a very easy and simple manner. Secondly, a good history taking is very important in all the neuro-ophthalmology cases. And it is an art which needs to be developed. It's not like whatever the patient is saying has to be correct. Many a times they just blatter off, and then you have to decide what is correct and what is to be believed and what is not to be believed. Remember, whenever you are dealing with any neuro-ophthalmology case, the underlying etiology can either be congenital, it can be either inflammation. Inflammation could be again because of infectious etiology or autoimmune etiology. It could be because of trauma, tumor, like underlying space occupying lesion, toxic because of ATT or because of methyl alcohol or tobacco toxicity. And in old age patients, especially if there is a history of atherosclerosis, hypertension, and above 50 years, you are seeing any patient, most likely cause could be non-arteritic ischemic optic neuropathy. And if you are seeing a patient with more than 80 years, more than 75 years, with having history of jaw claudication, suspect AION with a pallid disc edema will be present in the fundus examination. My third point is regarding the examination. What is very important in a busy OPD, what most residents rush through is to look at the pupil. So pupillary examination is of utmost importance in neuro-ophthalmological examinations. And then if RAPD is present, definitely there has to be some pathology. And because you will be dealing with some amount of patients who are also malingerers, you have to examine this part very carefully. If RAPD is there, definitely there has to be some neuro-ophthalmology cause. And if there is unexplained vision loss, RAPD is also not there, and still patient is having vision loss, and you have ruled out everything, then suspect malingering. That means it has to be at the end. Uh, then extraocular moment examination and then proptosis. These two things are usually missed. Proptosis, mild proptosis could be missed in the OPD setting, and then you might be just searching for the cause of disc edema, but actually it was because of something which was in the orbit causing the compression of the globe, and that had resulted in a disc edema. So that is one of the important reasons. Other important thing which I would like to highlight is that never hesitate in advising any investigation during for a neuro-ophthalmology, because you cannot see in the brain. You cannot see what is there lying behind the optic nerve. So you have to have a MRI, a good MRI, a contrast enhanced MRI, fat suppressed with 2 scans is essential. So never hesitate or never think twice before advising them. Even there have been cases where we were suspecting retrobulbar neuritis, but we advised imaging to just see that there was dense sinusitis, which was reaching up till the orbital apex and was causing compression of the optic nerve. This was giving a picture of RBN. So never hesitate in these things. And most importantly, always rule out infection before starting any type of steroids, because most of the clinicians have that you have to give just steroids. No, but you have to rule out everything else before you are starting steroids. Definitely, there should not be any undue delay because of these, but then do rule out infections before starting steroids. And finally, I would just like to say that if you are seeing a case of bilateral disc edema, you are not finding any space occupying lesion on an imaging, never label it idiopathic immediately. Idiopathic is the diagnosis of exclusion. It is the last thing which one has to say. So rule out other causes like cerebral venous thrombosis, cell venous thrombosis, which can also lead to disc edema. After an MRV can be helpful in those conditions. So you have to rule out first all these things and then label any pathology as idiopathic intracranial hypertension. So these are some of the important curves which I have, accumulated and I have learned in my residency, senior residency. So I think these might be enough for 3 minutes, for 3.5 minutes, I guess.
Yes, ma'am. Thank you so much, ma'am. I think you really summarized a lot in 3 minutes. In fact, the point about bilateral disc edema is a mistake that I have also committed during my residency. Moving on to Dr. Chintan, sir, I'd like to direct a question at you. Fundus examination remains the crux of a complete ophthalmic examination. But as residents, we often fumble in the beginning. There are a lot of first-year residents who are trying to hone their skills. For this, I would like to ask you, what are some pointers to keep in mind? This is all keeping in mind that we are in a busy OPD setting and we are quickly trying to examine the fundus. Also, as residents, we also skip out scleral indentation while doing a fundus examination. So how much are we missing out on exactly?
Absolutely. Thank you so much for this question. So, yes, fundus examination is a very important skill if you want to have a complete ophthalmological examination. A fundus examination is very essential. So, the first tip which I would like to give to every resident is to get over the inhibition of examining a fundus, because that's what happens most of the times in a busy OPD. You tend to leave it for your seniors, you tend to leave it for your superiors, but don't do that. No matter if you are in the first year, if you are taking more time, just seeing the posterior pole is enough. But it is important that every patient that comes across you get over that inhibition and start examining the fundus, because it is all about practice. And the more you see, the more you acquire, the more you learn. And also about seeing a normal fundus. You don't always need to go and examine a case only when someone points out that देख देख इसमें कुछ अच्छा है देखने जैसा. ऐसा नहीं है. You need to examine normal funduses. And I agree it's a busy OPD, but at the same time, the more you see, the faster you become. So from the first year onwards, it is important. Even if on a slit lamp you do a 90D, that's good enough, but you need to see every patient and see the normal things first. For a first year resident, seeing the normal disc, the normal AV ratio, how the blood vessels are, branching out from the disc and the third order vessels and everything. That is what is very important, where the macula is, and see the subtle things first. And then in the second year, and as you progress, you can start seeing the abnormalities. And one more thing which I would like to say is that it is very important to draw a fundus diagram with proper color coding. At times we don't remember the color coding, so you can easily get a printout and download it from anywhere and keep it in your OPD. So whenever you need to refer the color code, you can do that. And as you draw the diagram, try to draw it in the Amsler-Dubois chart as much as possible, not in the OPD. Then every patient that you've admitted, may it be for cataract or for VR surgeries, go in the evening, dilate the patient, and do a thorough fundus examination, draw the fundus diagram. And one more thing is, I've seen a lot of residents who draw the diagram after they see the fundus. Don't do that. You have to draw the diagram while you are seeing the fundus. So trace the vessels, trace how it is reaching up to a break, which area, if it's a case of RD, which area it is attached, which it is detached, and draw it accordingly. So once you do that, the abnormalities will come to you very soon. Seeing a macular hole or a diabetic retinopathy or an ERM or an RD is not that difficult once you know what a normal fundus looks like. So it is all about practice and all about making use of the best time that you have, that is in the evening. Because in the OPD, if you can't, you can definitely go and do it. It is a little bit of extra effort, but you can do it in the evening for the patients who are admitted in the ward. It's very simple, and you can take your time. You can take half an hour per patient. And coming to scleral indentation, again, it is something which you can't do in the morning, but you can do evening in the ward. There are some pointers which I would like to give for scleral indentation, because it is a difficult task. It is not very easy to do. So patient selection initially is very important. Don't select patients who don't have fully dilated pupil, who have deep sockets. So patients who have like large sockets, myopic patients in which the aura is easily visible, you start doing scleral indentation in those patients, and then gradually move on to more difficult and challenging patients, because it is very important to do a thorough scleral indentation. Also, some things that you need to keep in mind is, while doing scleral indentation, especially in the superior area, you have to ask the patient to look inferiorly and then slide the indenter into the superior forehead, not do it the other way around. And other than that, yeah, one thing which the residents usually get confused about is that in an IDO, the image is laterally and superior inferiorly reversed. So what they tend to do is, when they are seeing a break at 6 o'clock, they tend to mark it at 12 o'clock, thinking that the image is reversed. But that is not the case. The image, when you see 6 o'clock, it is 6 o'clock only, but only the 5 and 7 are reversed. And a break, a horseshoe tear, which is pointing towards the aura, might be pointing reverse. That's it. So these are some of the things which you need to keep in mind. And yeah, get over the inhibition, practice as much as possible, and draw diagrams as much as possible with proper color coding. That's about the advice which I would like to give.
Thank you, sir. Thank you, sir. That was some really nice words, especially on scleral indentation, which I feel like would be useful for me a lot. I direct my next question at Dr. Saurabh Bose, sir. Applanation tonometry is a sort of a hit or miss for many residents, and a common problem faced by residents is, and I quote, is that I'm doing everything that I'm supposed to do, that I've read, that my seniors are telling me, but I still don't see the Myers. So where exactly am I going wrong? And what should I keep in mind?
A very good morning to everyone, and thank you, Dr. Anujit, for that question. I myself had faced a lot of problems during applanation during my PG days. So what I gathered from my own experience and faults is that, see, we have to resolve this issue on 3 steps. The first one, we have to read up how the applanation works, and in what cases, what findings are we expecting. Secondly, we need to understand the calibration system of the applanation, because most of the times we see that we don't go into the detail of how to calibrate the prism, how to calibrate the weights, and how to calibrate the pressure system. So this is very important. And the third step is, of course, practice makes perfect. So in this regard, I would like to point out some points that pose to be a problem. The first is, sometimes the cornea itself, more common than expected, the cornea itself is not regular. So in these cases, we tend to get distorted Mayas. So if it is possible, the applanation tonometry has to be cross-checked by a tonopen if it is present, because then we can correlate in a good way. Secondly, what I have seen is in most of the glaucoma patients, since they use anti-glaucoma drugs for a long time, there is a tendency to develop dry eyes. So we often miss this. So whenever we examine a known glaucoma patient, so we should always, and in case we don't get a Maya properly, we should always try to put in a drop of a lubricating drop and then repeat the process. I have seen personally in more than 50% of cases where there was no Maya, just after a drop of lubrication, proper Mayas appear. The third point is explaining to the patient what is to be expected, because most of the patients just freak out at the very idea that something is going to touch their cornea. So we must take at least 30 seconds to explain to the patient that, see, this is going to happen. We are going to touch a thing on the cornea, but it is completely safe, completely painless. And the third, of course, is another point that I've seen is when you're starting with applanation, you should keep a colleague or a friend just beside the patient to see how much the cornea has been touched by the prism. This is very important because the Maya formation depends on the exact area where you're touching the prism, and it is very difficult to see for yourself when you're doing the applanation. So in the first few cases, keep somebody. And the third and the most important point is, once again, I stress, practice makes perfect. So you do your applanation on normal patients, on indoor patients. It takes some time, do it, and eventually at the end of the day, the entire applanation process will take about only 15 to 20 seconds to do. So that's all I have to say.
Thank you, sir. 3 excellent pearls for applanation tonometry. I'd like to move on back to Dr. Gunjan. In a busy OPD setting, again, I bring one more problem to you, ma'am. A patient comes complaining of doubling of vision, and this remains a challenge for all residents to examine. So what are your tips on approaching a patient complaining of diplopia, and can you make this entire part a little lucid for all of us?
Yes, why not? See, if there is diplopia, it could be either because of a comitant squint, or which is manifesting now, or it was because of some incompetency, which has now recently developed. So you can ask the patient simply if the diplopia is exaggerated when he is going out in the sunlight, as in cases of IDS, patient might have diplopia phobia also. Secondly, mostly patients might have paralytic squint, component of paralytic squint. And then the three main causes of these include third nerve, fourth nerve, and sixth nerve palsy. So to begin with, I'll begin with fourth nerve palsy. So fourth nerve palsy patients do not hesitate in asking them the family album tomography, which we say. That means ask them to bring their old pictures. You can see if the patient had a congenital fourth nerve palsy, they'll have a typical head posture which was present since their childhood. Secondly, if the and that fourth nerve palsy has now decompensated and now patient has presented to you. Second thing, in sixth nerve palsy, it's very important to examine everything till the fundus. Look for papilledema because sixth nerve palsy can be many a times a false localizing sign also because of the raised ICP and because of the space occupying lesions. So in that condition, you can advise patient imaging and you can look for any space occupying lesion. In the case of third nerve palsy, look for whether there is pupil involvement present or there is pupil sparing. Pupil involvement suggests that there could be something. Most common cause is aneurysm, and and if there is pupil involved, if there is pupil sparing, then mostly it is because of some causes, vasculopathic causes like diabetes, hypertension. Patients will have such predisposing factors. If not, search for them. But if you are suspecting a pupil involving third nerve palsy, do advise magnetic resonance imaging as well as a magnetic resonance arteriography to look for any aneurysms in the posterior cerebral artery, which are the most common cause for these type of presentation. Once you have ruled out what's the cause, also you have to just observe if you have ruled out that there is no malignant cause, there is no space occupying lesion which is causing this, then you just have to observe the patient for the next 6 months, and you have to but at the same time you have to see that the patient must improve also. For his diplopia, you can give him patching You can advise them cosmetic contact lenses if the patient are which are opaque and they are cosmetically acceptable also. And you have to see in each visit whether the patient is improving or not. If he is not improving, again advise an imaging to look whether you had missed something in the previous imaging. And finally, after 6 months, you can plan for surgery. And during that during when you are following up the patient, advise in each follow up look for his diplopia charting and his chart to look for any improvement.
Thank you so much, ma'am.
We have just 1 more minute left in the session, so you can have two quick pearls from Chintan and Saurav.
Right, sir. I'll quickly go to Dr. Chintan, sir. 90D slit lamp biomicroscopy versus indirect ophthalmoscopy. What should be the choice for a resident? So if you can quickly, briefly give us a few tips.
Okay. So there is no 90D versus indirect ophthalmoscopy. They are not substitutes for each other. Both of them are independently very important. You cannot replace one with the other. So it's criminal to miss peripheral RD by just seeing 90D posterior pole of a patient. Similarly, it is criminal to miss few microaneurysms or a subtle cellophane maculopathy on an IDO of seeing the periphery. So both are equally important and indispensable. You need to do both. And if in a busy OPD, like you said, you don't have time, you do both very quickly, but both are equally important and you need to do both definitely for every resident. There is no if and or between them.
Thank you, sir. Dr. Saurav, one last question before ending the session to you, sir. Gonioscopy is something that residents keep skipping out on. How to get yourself, how should a first year resident initiate themselves with gonioscopy? What prism should they use? Could you please give us a few points on that, sir?
So very briefly, first of all, read up how gonioscopy works. Secondly, always start with a 4-mirror gonioscopy. It is easier, you can indent, it does not require a viscoelastic, and in even small eyes, you can use it. And after using the 4-mirror for a number of times, always confirm your 4-mirror findings via 3-mirror. Because 3 mirrors has certain complications, then again, the patient compliance is low in case of 3-mirror. Since it is larger in size, you need to use viscoelastic and all. But always and always use a 4-mirror first, indent, and then go for a 3-mirror. And another pearl is sometimes in 3-mirror also, even if indentation is not possible, an angle which may apparently look as closed, ask the patient to look towards the mirror. In more than 50% cases, it is often seen that it is actually an open angle, but it was disguised to be a closed one. So ask the patient to look towards the mirror. So your finding will be more accurate. So that's it.
Thank you so much, sir. I feel the driving home point was to read up and to practice for all residents. With that, I end this session. I hand it over to Devakant, sir.
Thank you, Dr. Anujit, and some very excellent points covered. Now I invite Dr. Pranav Saluja to take over the next topic, that is about the surgical skills. And Dr. Pranav is a fellow at Vittoretna fellow at SMC Chitrakoot, and he works with the YouTube team as well. Over to you, Pranav.
Thank you so much, sir. So good morning, everyone. So our session is on the topic acing surgical skills during residency. We have esteemed panelists of young ophthalmologists from all over the country joining us. So I would like to introduce our panelist. First up is Dr. Tushar Agarwal, sir. He has done his MD from RP Center in 2002 and has been a faculty since 2005 and is working as an additional professor of ophthalmology there. He specializes on the cataract, cornea, and refractive surgery department and has been an avid publisher. He has published about various surgical techniques, especially in pediatric age group and lamellar corneal surgeries. He has also been awarded the Young Scientist Medal by Indian National Sciences Academy and Best of Show Award by American Academy. Welcome, sir. Next is Dr. Nikunj Tank. He's a consultant cornea and cataract. He has been working at Sitapur Eye Hospital previously, from where he has done his fellowship also. He also runs a YouTube channel, which is known as VAST, which is directed for the resident and is also a YouTube editor along with me. It has been a pleasure working with you, sir. Then there is Dr. Kushal Teliwala. He is a VR and UVR consultant at Netralya Super Speciality Eye Hospital in Ahmedabad. He is a gold medalist during his residency and has done his fellowship from Shankar Netralya. He has also published various papers in international and national journals. Next up is Dr. Nikhil Gotmare. He is a senior resident in the cataract cornea refractive unit at Guru Nanak Eye Center, and he also runs his own YouTube channel and produces wonderful surgical teaching videos for the residents. So I would like to start with the session. I would like to start with Dr. Tushar sir and how they proceed with the training of residents at their center and how to get the most out of the residency. Tushar sir.
Thank you, Pranav. Good morning, everyone. At RP Center now, there has been a surgical skill lab even when I was a resident, but it was on a much smaller scale. So about 6-7 years back, we upgraded the lab completely. It was made from the ground up. It has 5 wet lab stations, each equipped with a microscope and an infinity machine. And then there is a ISI cataract surgical simulator. And over the last 5-6 years, we developed the wet lab program, and since about 1.5 years now, all residents have mandatorily to undergo the wet lab training at RP Center before they start getting cases in the OT. And they begin with ECC training, which is typically completed in 3 months. And most of you must be aware of the Oscar system of scoring, of grading the surgical skills. So we have adapted it for the wet lab conditions. And after 3 months, or whenever they feel comfortable, they give an exit exam where they do 2 ECC surgeries in the wet lab under our supervision. And once they pass that, then they're trained in phaco in wet lab for another 3 months. Again, once they feel comfortable, or at 3 months, they give the exit exam in the wet lab, and they do 2 cases of phaco basic steps. Once they do that, they get a certificate from our side, and they take it to their respective unit, and then they start getting cases. When they start getting cases, again, they are required to record all their cases as far as possible. Sometimes due to logistical reasons, it's not possible, but most of the times they are. And then every Saturday, I do a video review session with the residents in the wet lab. And during the COVID, we had shifted it to online, so it was not very regular. But on Saturdays, we do this surgical review where I take they submit their videos, and we take them through through my magnifying lens, and just go step by step where they went wrong or where they could have improved. Especially if there has been a complication, then we definitely go through those things, and simultaneously we also try to tell them what is to be done. So it typically runs from anywhere between 1.5 to 2.5 hours. That's done every Saturday. It's yet to resume in this session, but if any of you young ophthalmologists want to join in, we can always invite you there, because now in any case we are holding it online. So that's the basic structure of our phaco training at RP Center.
Thank you, sir. Dr. Nikun sir, like you've been producing lots of online videos and trying to like help the surgical residents deal with the complications. So what is your take on it? Like what are the online resources which the surgical residents can follow? Because during the COVID era, we have a lack of surgical training. So sir, over to you.
Yeah, hello everyone, and good morning. Thank you, Pranav, for the question. I run this YouTube channel. The basic idea I had was to have a platform where I can. I have started recently a series where I'm showing the surgical cases operated by resident themselves, and their mistakes we are analyzing, just like sir has told. They are doing at RP Center, and how to correct that mistakes, that will be the part of that. So there is just one resource. There are multiple online resources for cataract phacoemulsification surgery. There are like n numbers of teachers out there. From India, we have Dr. Saurabh Patwardhan sir, Deepak Magul sir. Internationally, we also have Dr. Uday Devgan, which I used to follow, and he has a tremendous collection of very good surgical cases.
So basically, one thing, the surgical resources are unlimited. You also go through them, and that helps you for to learn your certain basic mistakes which you are making, and you can correct them when you are getting a chance to operate a second case for the residents and fellows I'm talking about. But few things I would like to add here, that before starting, which is generally missed, because I have seen this when I was working at AIOS Sitapur. So many residents have their uncorrected refractive errors, and they start operating, they are not even aware of the refractive errors, and they face difficulty with binocularity on the microscope itself. So I would request all the residents to get their routine ophthalmological evaluation done, including the refractive error if they have, and especially binocularity. If you have a pediatric department with orthoptics, get a complete binocularity if you have or not, and if there is any problem, just get it checked before sitting on a microscope. Then start exploring microscope in the wet lab, and look at how, if you are able to see view from the microscope, basically, because so many residents still struggle initially with the what kind of view they have with the microscope. And when see when while learning the surgeries, all of the residents will have a different kind of problems. So it has to be an one-to-one mentorship. You need to ask questions to your seniors or mentors, whoever is training you and whoever is there to guide you. And the mentors also need to address them individually, because there is not going to be a common problem for all the residents. So just like sir said, that if they are able to record the videos, and that can be meticulously analyzed to see what kind of mistakes they are making, that will be a very helpful way to learn. Another thing which residents sometimes they are not serious about is they don't look at their postdocs. Sometimes it happens in certain institute, it happens, but we make it mandatory to they have to see their postdocs. They sometimes get afraid that if they have made a mistake, they will get a kind of a scolding for that. But that is where you learn, because you need to look at your mistakes, you need to see what outcomes you are having. And even in each and every follow, when the patient that patient comes, you make sure that you coordinate with your colleagues, that if that patient comes, call me to see. It's like that. So that is also necessary, which is missed by the residents. uh, Online resources definitely help to learn, but definitely wet lab practice and one-to-one mentorship in the OT, which will be helpful to improve your surgical skills, as far as I feel. Over to you, Pranav.
Thank you, sir. Dr. Kushal, I would like to ask you about your vitreoretina training during your residency. Like most of the institutes don't give any sort of vitreoretina training. Mostly they are focused on cataract surgery. So, did you have any retina training there, or it was only cataract?
Yeah, Dr. Pranav, your voice was cracking. Could you just tell again?
I would just want to ask you about your training at your residency,
Yeah.
during your residency, about the retina training or even cataract training. How was it? Yes.
Yeah. So, thank you, Dr. Pranav. So I would say that my inclination for the retina specialty started from my PG itself. Thankfully, my mentor was with a retina surgeon. So during first year, what is fascinating is that when we look at the indirect ophthalmoscopy, that was very fascinating for me. But obviously, as a first year resident, you have a lot of other paperwork to look at, and during the evening rounds, we do get certain time for pre-operative admissions, and then we used to look at that. But to get the basics right, I would again emphasize that in order to ace your surgical skills, you have to be thorough with your anatomical landmarks. Because if the anatomical landmarks are missed, you are bound to make mistakes. And especially in the retina subspecialty, where we know that the indirect ophthalmoscopy gives the inverted image. So you have to orient your mind accordingly. And secondly, I would also say that if you are very much compliant with your both the hands, because obviously that practice starts from the residency, because once you enter the retina fellowship, we know that we as surgeons are needed to be ambidextrous for any sort of be it even binocular indirect examination, be it 90D 70D, or be it with the lasers or the surgical steps. So if you try to evolve this your skills over the residency period, that will be great. And secondly, I think we do get a lot of retina patients at our RIO at Ahmedabad. So thankfully, I had few of my postings where I could develop my skills during that. And gradually, the inclination usually starts from the time that you are about to finish your residency. That is number one. And definitely, cataract also were given in significant numbers. But yeah, obviously, there are always limitations in terms of phacoemulsification at our center, because there are a lot of patients, and sometimes we are not able to finish the OTs on time. But that is a part and parcel that can be evolved if you know the basics, right? But again, I would also emphasize that whenever we are approaching any surgery, I think if 2 or 3 cases are posted for us in a day, every case has to be approached separately. I mean, you have to rehearse it mentally in your mind, that what is these steps which we are going to perform in this case. uh, for example, a patient, first patient might be having a fully dilated pupil, second patient might not be having that much dilated pupil. So your steps, though being almost similar, but the approach can differ. So you cannot completely stamp that the first case which I did the similar way I will be going. So you do the first case, then completely clear up your mental thoughts, and just again approach for the second case. So you try to rehearse in your mind that what all steps you are going to approach, and that will also increase your output. And at the end of the day, you can always review that what all you did during that cases, so that it can help you out in the further cases. And also you can discuss the plan prior to the case starting with your mentors or the seniors, who can help you out in easing out your cases. So that was my take during my residency.
Yes, sir. Dr. Nikhil, what about your training during your residency, and how did you go through it? Like, how did you go through the difficulties that you faced?
Am I audible?
Yes, yes.
Good morning, everyone. Thank you so much. At Guru Nanak Eye Center, as we know, it is a part of Loknayak Hospital, which is the largest COVID hospital in New Delhi. So we residents were posted both in COVID wards and also in periphery. So it made acquiring surgical skills all the more difficult. So the tips I follow, and also I ask other residents to follow, is first, always see your patients preoperatively on slit lamp. Do a complete ocular examination, look at the cataract, and with time, this will establish a clinico-surgical correlation. So next time you will be able to better anticipate what to expect during surgery. So this is very important to watch all any surgery which you are going to do. All the cases need to be examined by you on the slit lamp. Second is when you're doing a surgery, any mistake or any difficulty you find during surgery, you need to note it down. And post surgery, you need to correct this mistake or difficulty by either by discussing it with your senior, or going through the literature, or looking at the online resources. So never let a mistake go uncorrected. So this will better give you a better result in next surgery. And also, I would like to add a point regarding assistance. This is something which is really underestimated. When you're assisting a good surgeon, there are a lot of things you imbibe unknowingly. And what you need to do is you need to match your frequency with your surgeon, and you need to anticipate what will be the next step, what will the surgeon do, and pass the instruments accordingly. This will give you a very clear mental picture of what needs to be done during surgery when you're operating.
Thank you. I think that is a very good point that you put, that assisting really helps you in the surgeries. And I think we should always start with assisting our seniors and our mentors. Dr. Tushar sir, most of the residents face difficulties during capsular access. So like, how should they deal with that? Because when it does not go right, most of them have anxiety. And so how do you deal with that? Like, how do you practice capsular access? So you are muted, sir.
Sorry about that. Yeah. So I forgot to mention when you were talking about the residency training. So I take a FECO course also when the new batch joins. So at our place, every 3 months there is a rotation. So I take a course. I spread it over around 7 or 8 classes, each covering one step only. So for me, the Rex's class is about 1.5 to 2 hours. So you are especially for the second and third years who come to my batch, I have to first ask them to unlearn what they have learned till now, if they haven't attended my classes before, because one has to remember that the Rexis was invented before the Rexis forceps was. And the more senior surgeons, they do it with the needle, because when the Rexis was invented, there was nothing like a Utrata forceps. And it requires much more surgical skill and control to do it with the needle than with the forceps. So first thing I tell them is to learn it with the forceps, capsular Rexis forceps. Then of course I've divided the Rexis itself into multiple steps, micro steps, around 10-15 steps. And that is how I teach them. First I show them how it is to be done. Then I pick up their videos at each micro step where they went wrong, and then we try to correct them. A good practice, fortunately, we have both the wet lab and the simulator. Simulator is especially good for learning Rexis amongst all the steps of cataract surgery. Even if you don't have that, it's an expensive machine. I understand. A wet lab, goat's eye or anything, animal eyes are quite good for learning capsular Rexis.
So one question from the audience to you is that if someone wants to make the use of wet lab and simulator at RPC, is it possible, and whom to approach?
Yeah, you can approach. I mean, you can ask. You can send an email to me. We can set up a time. You basically we require some form of identification, where you are working and what is your qualification, and depending on the slots available, we can slot you in. No problem. My email is drtushar@gmail.com or tushar@aims.edu. That's simpler to remember. You can send me an email, and Sister Dolma is the sister in charge of the lab. She runs the entire roster. I coordinate with her, and we have had some people from outside using the lab. You're most welcome to join. It's a public property. Everyone here owns it equally, and everyone is welcome to join. Depending on of course, the availability of the slots. There are many slots available. tushar@aims.edu.
Yes, sir. That would be a real help for people. I think we are over with the time. Thank you so much to all the panelists for joining. I think the takeaway message is that assisting in surgical videos in surgeries is very important, and especially having a very good mentor who teaches you the surgical videos and going through your videos.
I'm sorry
is
to
very
interrupt.
important.
Just sorry to interrupt. If someone is asking about wet lab, I would also encourage that the Saturday video review sessions, they are held in immense amount of detail. That would be even more helpful. And if someone wants to join them, again, we can coordinate. Because in any case, we are holding them on some type of online platform every time, and the link is floating around in RP Center. So on the resident groups, so anyone is welcome to join those sessions.
Thank you.
Usually on Saturdays around 11:30 or near about that time.
Okay, sir. Thank you so much, sir, for joining. Thank you. Over to Diva, sir. Thank you, sir.
Thank you, Pranav, and all the panelists, and especially Tushar sir for taking out time on a Sunday morning. And wonderful opportunity for all residents to make use of the great opportunities at RPC. Now let's move on to the next session, that is about cases to the right way. And I invite Dr. Tanveer Ahmed to take over. He's a resident at Silchar Medical.
A very good morning to all. Today, we have a roundtable discussion on thesis, doing it the right way. So we are honored to have three panelists from our side. Dr. Sabyasachi Sengupta sir, who is a VR surgeon working in Mumbai and the founder of Sengupta Research Academy. He is also the McCarthy Prize winner from the Royal College. And we are also having Dr. Neha Goyal ma'am, who is working VR consultant at Max Hospital, Delhi. And she is the winner of AIOS Best Thesis Award 2011. And we have got our very own VR consultant, Jay Seth sir, who is the head research at Surya Eye Institute and also clinical research head at the Chaitanya Eye Hospital and Research Center. So today we have got this topic, thesis doing it the right way. So this is one of the very tricky thing that we face a lot. uh, there are lots of questions, but we'll stick to the very few questions. Like the first question I would like to ask Sabyasachi sir, like how to choose the topic of the thesis. Well, we only have 1 or 2 months to decide the topic of the thesis. We are floating on the sea. So sir, can you please elaborate a little bit on how to choose the topic of the thesis?
Thanks, Tanveer, and thanks, Yosi, for this opportunity. I think first of all, I wanted to start by saying that why we want to do a good thesis, because a lot of students actually try and overlook that in and pay more attention to the surgical training and other things. But I think it's important for us to understand that all these all these nuances of research and thesis helps us to unlearn and relearn a lot of things as we go along in our careers, because what we're learning today will be irrelevant, say 5 years later. So how do you decide what you want to unlearn and then relearn, and how do you relearn that? It is by making sense of the papers which are being published. So unless you do your own thesis and learn these nuances, it's going to be very difficult for you to do that. So I think thesis deserves as much importance as any other part of your training. Now, some prerequisites before you think about your thesis topic is who's your guide and what is the specialty of your guide. So it is advisable that you stick to that specialty if at all. If somebody with a glaucoma specialty is your guide and you're taking a retina topic to them, then it possibly is a misfit. The second is need to choose a thesis topic which is novel. That is, it has really not been done enough in the past, and this will also help you have an eye out for publication later. And then lastly, before, these are all prerequisites, right? So before you start, you need to think about what are the pathologies which constitute majority of patients in your OPD, right? So if you have a lot of corneal ulcer patients, you need to think about what has not been done in corneal ulcers. Or if you have a lot of vitreoretinal or diabetic retinopathy or any other, you need to think about what has not been done in that specialty and try and concentrate your thesis on that. Once you have these in mind, you already have your thesis guide, and then say a lot of POAG patients, and you are already focused on that, then you need to do a PubMed search to find out what has not been done, right? So we are looking at what has been done, but try and keep an eye out on what has not been done. And how you can do that is by reading full text articles, because most of the the best papers in the top journals, they will end with saying what can be done in the future. So once you start reading full text articles, that will give you a lot of good ideas. Then you can also make PubMed work for you, where you can tell PubMed that, okay, this is the topic that I'm interested in, and which are being published over the next, every week you will get a list of from PubMed. So you can make PubMed work for you. Then you can subscribe to e-table of contents of these major journals, right? So you will have their, the whole thing which is being published in the journal in your email box. That will help you, look at newer, and ideas can come from the clinics. You can discuss with your seniors. And I think it's also a good idea to have journal clubs in your institution, so that you can, think about these more and more. So one journal club every month is possibly a good idea. I think these are some of the points I wanted to convey, as to how you can choose your thesis topic.
Thank you, sir. Now,
Tanveer, back.
question to Jay sir. Sir, actually, once we choose the topic of the thesis, then we are like quite reluctant. Okay, our topic has been chosen. So then we get a little bit late while starting the thesis, and again that hush at the last time. So how do you advise? What do you advise? When to start writing the thesis? When to start working with it? And how to proceed with after choosing the topic of our thesis, sir? I think, sir, you're muted.
Hi, yeah. Thanks, Tanveer, for the question, and thanks to Yosi for giving this opportunity. So I think this is a very relevant question, and I think the most important thing is to start writing as early as possible. Because I think within the first 3 months, we usually are ready with our protocol. And because see, in the first year, we usually get a lot of free time around. And as we go into the second year, third year, the clinical work increases, the surgical work increases. We would get more of on calls, we would get more of independent duties. So, and of course, in the third year, there'll be a lot of pressure to study for the both the theory as well as the practical exam. So, my advice is start early. Try to write at least the introduction and the methodology in the first year itself. Because that is what I did actually. By the end of first year, I was ready with my intro, the literature review, and the methodology, because that is not going to change. The methodology that you develop, because all these are prospective studies, so that is not going to change. So just finish writing that part, do a detailed literature review. That is also not going to change. And in case some newer studies get added up within the next 6 months to 12 months, that can anyways be added onto that. And because see, writing is a difficult task for everyone, so it is not that your first draft is going to be your final draft. There are going to be at least 5 to 10 times we will redraft it, and we will send it to our mentors, the head of the department. So they will go through the drafts. They will be giving their own suggestions. So getting the feedback and then modifying it again. So that is a little long drawn process. So ideally, you should try to finish off your thesis by the early part of your third year itself. So it will give you sufficient time, and if you're able to finish your thesis and everything on time, you can actually submit it earlier to the NBE or for the MS this thing, and then once you get the acceptance letter, so that's a very psychological boost that at least your one third part of your clearing of your DNB is done once your thesis gets this thing. It's a major boost for your theory and your practical exams also. And nowadays, see, fellowships and all are very important. So uh, the criteria what they use in fellowships is recommendations from your departmental chair and from your mentors, as well as they'll see if you have any kind of publications. So if you get your work done early on your thesis, you can make a part of your thesis into few papers and everything also. And if you are quite early, you would definitely get good recommendations from your mentors also. So that will help you a very long way in in getting fellowships at very good institutes also. So my bottom line is to start early, prepare the first draft, get it edited and all.
Okay, thank you so much,
Yes,
sir.
sir. Yeah.
So my next question goes to Neha ma'am. Good morning, ma'am. First of all, this is kind of my question also, like, ma'am, how to take your thesis? I'm done with my thesis. I'm finally resident. So how to take the thesis to the next level, just the way you have taken it to the AIOS best thesis paper award. So how to take it to the next level of national level conferences and to the publication level once we finish it.
Okay, thank you, Dr. Tanveer, for moderating this, and thank you to Yosi for allowing me to share some of my thoughts. So I agree with what Dr. Sunny said. You know, the importance of the thesis. It's actually your first interaction to research. Coming to your question, what to do with it, in that I'll also like to kind of continue on what Dr. Jay said. I completely agree that if your time period is 2 years, then you shouldn't do. In MS, it's actually 2 years for completion of thesis, not 3 years. So in 2 years, you should not wait for the 2 years for your thesis to complete. So your kind of uplifting the thesis starts from day one. Okay, so once your topic is decided, methodology set apart, you start your clinical groundwork. And let's say your sample size is 30 patients or 40 patients, but maybe within just 2 or 3 months you're able to get data of 15 patients or 20 patients. So you can already start writing a preliminary paper at that stage. And rather than just writing a paper, I would suggest to put up your data as a poster or as a paper in your state conference, in your national conference, and possibly even in your international conference. Now, what the advantage is that once you present in front of esteemed seniors, you will get more feedback for your thesis. and that you can still at this point use to alter the course of your thesis, right? So say you present your preliminary data of 15 patients as a poster or as a paper, and then the judges or the panelists, discussants might give you some more tips or pointers, which will even better your thesis even at this stage. So you don't have to wait till you have written it, because then how will you incorporate these changes or modifications? You can start right away, even with your part of your data. The second thing is, of course, you always have to take help of your guide or mentor, and you are lucky if that is somebody who is enterprising in this regard, because you can even start with the international presentations, just a part of your data. Publication, I would suggest to wait, okay, to wait till your entire thesis is complete, and then we can work on that. But the presentations, you can do as many as possible till then. uh, that's what I feel. And I mean, the earlier you start, the better it is. Sometimes what happens that even in your thesis, you come across a patient, even a single patient who has, responded in a different way. Say you were using a new drug and he developed an unknown side effect to the drug. So that you can just present as a case report also. Or if you see a trend in 2 or 3 patients who had a particular disorder, who are responding in a particular way, then you can even start an offshoot of your thesis and concentrate on that case series as well. So to be involved in your thesis from day one, to interact with your patients, meet them as much as possible, read about them, that's very important. Another point I'd like to say is, like Dr. J was saying, that you be updated of the publications. So what you can do, you can set up alerts in PubMed. So whenever, say you've done your literature search and created a body, what if there's a new article which is published 2 weeks after that? So you miss it. That actually happened with me, and I presented my thesis somewhere and they said, no, but this has been published, and I felt quite embarrassed and foolish. So if you set up alerts, even after you have done your ROL, PubMed will send you the articles which are related, which are published at a later date, so that you don't miss out on your NUMA presentations.
Okay, ma'am. Now, to Sabyasachi sir, sir, once we choose the topic of our thesis, so it's kind of like when we have a biostatistical part of the thesis, like the p-value and all. How to approach that part particular? Do we learn it and do it ourselves, or we take the help from community medicine people? So can you please enlighten us on this note, the biostatistic parts particularly?
Right. Thanks, Tanvir, for that question. So, I feel that statistics is a very integral part of your entire thesis process. And if your novelty cannot come from a topic, based on your limitations, say I'm doing similar topic on telegym surgery, which is done many times. The novelty can be brought about in the way it is analyzed, so that analysis can make the thesis publishable or novel. Now, coming to your question of how we can do it, so you can either do it yourself, and there is a statistical program online which is called R. Just the letter R. You can just Google R statistics software and you can download that. It's free to use, and you can do some online courses on Coursera or Udemy, and then you can learn actually how to do it. But it is a bit tedious. But what is most important is that you understand the whole concept first. So what is the type of variable? What is the type of tables and figures that I want? What is the best way to display my whole data? And it's a good idea to make dummy tables or say blank tables and send it to a statistician and tell him, this is what I want. So the first column is all the variables that you want to compare, and then say there are 2 groups. So you make a dummy table or 3 or 4 tables and you send it to a statistician, and you communicate with the statistician properly in the language that they understand, because remember, they are not clinicians, right? So uh, I think the crux of the whole thing is that you need to sort of learn a little bit of this, and it's relatively easy nowadays with a lot of online resources for you to learn. So learn the very basics of statistics and communicate with your statistician, and get it done from there.
So my question to Jay sir, how to avoid the plagiarism? At times it is involuntary too. Like we don't copy, but again, when we check in the online format, we see that, okay, wow, there is a 60% plagiarism. So how to avoid that, sir?
I think one of the most important is avoid intentional plagiarism. That is most important. See, unintentional may happen, so it is very important to read at least 10 to 15 articles, and very important to read a minimum of 5 review articles on your topic. or if your topic is very new, just look for very related topics and read a lot of review articles. See how things are written down in that. And paraphrasing is important. So if you're taking a reference, if you're taking a line or something from a particular article, so try to paraphrase in your own word. Read the article, understand it, and then paraphrase it or summarize it accordingly. Avoid direct quotations as far as possible, and giving proper citations is most important. And in case if you have any doubt whether this thing needs to be cited or it shouldn't be cited, it's better to err on the side of just citing that thing. Then there are online tools to check for plagiarism, like Turnitin or plagiarism.com, and also just put your thesis, put your document in that, and just check for it. Get it proofread from your mentors, from your seniors, and also from your colleagues who have done work in that area, so they may also provide valuable feedbacks regarding whether it is very similar looking to some other article or not. And whenever you are reading the articles and all, make proper notes, because that is very important. If you make notes, then you will start thinking in your own words, and then you'll be able to start writing in your own words.
Okay.
And keep a proper reference citation manager, because by the end of the say 1.5 years, then you'll lose all your references from where have you taken a particular line and everything. So have a proper reference manager is very important.
Okay. So one question to all respected panelists from the chat box itself. Namrata Sharma ma'am is asking. So this COVID time, everything is almost related to the COVID time, the COVID thing these days. So all the theses are like stuck at particular point. Patient load is also less. Then we are also busy with our COVID duties after 3-4 cycles and all. So this has become a speed breaker in our proceeding with the thesis part. So can you please give your opinion on this, or what do you think about it, that how to restart or like accelerate our way of doing the thesis once we are kind of done with the COVID and all those vaccination and things? Over to the house.
Tanveer, can I answer this? All those people who are doing their thesis right now and
Good morning, ma'am.
Good morning, are about to complete. Please approach your ethics committee. That is what we've done for our students, and I think your guides can do that to decrease the follow-up or to decrease the numbers in the COVID times. And most ethics committee would comply to it. All those students who are about to start their thesis, please take topics which are doable, preferably just analysis. You can't do too many surgical cases or surgical topics because that kind of load will not be there. So I think that is what is required in the COVID times. So very important to write to ethics committee if your follow-up was 6 months truncated to 1 month. If your numbers were large, like we've given thesis on keratoplasties and we are not getting tissues, so truncate the numbers to whatever has already been done. Okay, so that is just what I wanted to clarify.
Thank you, ma'am. Thank you so much.
If I can add.
Yes, sir. Sure, sir.
If I can add quickly, yeah. So from a statistical point of view, what you can actually do is, calculate the power of the study, because, your original sample size, like ma'am said, relatively large numbers, but now you have smaller numbers. So you can actually go back and report the power of your study, that it is now relatively underpowered from what we intended to do, but then, this is what it is. And the other thing is that, say some people missed some follow-ups in between because of these COVID times. You can actually generate some values based on some statistical software. So that can also be done based on what their other values are over a period of time. So
yes,
that can also be done.
Thank you, sir.
Yes,
So
I was just going to say that for those who were just about to complete, you can take the help of a statistician to fill in the missing data. That is absolutely valid and legal. I mean, it's not as if all the patients don't have the last follow-up. If say a percentage don't have, then that is a valid, I mean, don't make up values, first of all, but then refer to a statistician. And I'm sure Dr. Sunny would know better, but there are those NANs which they can fill in for the follow-ups in between. So that I mean, if you're in the last year of your thesis or last 6 months, that would be a better option, so that your power and the the impact of your study doesn't get affected.
So we are almost coming towards the end of our session. So before we conclude, let us let us finish with views from everyone, like with a very basic question. So why this thesis? What is the purpose of this thesis? Like doing some research work during this particular thing. Is it only because of the academic things, or getting in closer with our clinical part? So one opinion from your side, every panelist I would like to request. What is the purpose of thesis?
Like I said before we start, that you need to unlearn and relearn literature as it is evolving. So doing thesis will help you understand a lot of those as you go along in your career, a lot more than surgical skills as well. So I think this is very important from a longer time point of view.
I feel academics is a very important part along with learning clinical and surgical skills, and it definitely gives you the X factor to progress in life or to get increase of fellowship opportunities. It gives a good platform to speak on in different national and international forums, and also it's a good groundwork.
So yes, of course, I agree. But I also think if you look at each step of the thesis, it has something to teach you. When you think of the topic, you actually learn how to interact with your mentor and any mentor in the future. You know how to do the work they give you, how to get back. And sometimes they may say something which you feel is wrong, how to interact with your mentor. Secondly, how to do a review of literature. That's very important. Even if you're not into academics, I mean, if you're just in a webinar giving a talk, if your review of literature is not good, or for that matter, even if you're sitting with a patient and the patient comes up with something on Google and you don't know what it is, so doing a review of literature is the second thing that a thesis teaches you. Third is the methodology, the results, the statistics. That I feel forms the basics of your ethics for life. Again, whether you are into academics or not into academics, how you handle, how that part of your personality shapes. Like we were just talking about, okay, you were supposed to do 20 but they are only 18, what will you do with those two? That is something which your thesis will, like the sorting hat in Hogwarts, it will ask you what you want to do and take it forward. Then even further, like Dr. Jay and Dr. Sunny said, how you present it, how, whether it gives you that kick publishing it and all. And then fifth and most important, I feel, with the patients, like if you have a longitudinal study, the way you convince them, the way you rather beg them to come for follow-up. Okay, like I gave a thesis of CSR to one of my DNB students, and she was like, ma'am, they don't want to come at 6 months. I said, that's your skill. You have to convince them how they are part of the thesis, how it will help us and all that. So a large part of your patient communication and skills also you learn if you have that kind of a thesis. So every step, everything you do in it is, I think it will teach you. If it's a surgical thesis, just standing by each and every of those 20 surgeries which are done in a specialty, that will teach you much more than you realize. So enough said.
Thank you, ma'am. Thank you so much. Thank you to all the panelists, also to Dr. Namrata ma'am for her valuable inputs. Over to you, Divakan sir.
Thank you, Tanveer, for managing the session so well, and thanks to all the panelists and, of course, Namrata ma'am for her pertinent input. Next, we have Dr. Pranesh. He'll be taking care of the exam session, and he is a medical officer at Arvind, Coimbatore. Over to you, Pranesh.
Thank you, sir. If I'm audible, yes. So we are coming to the most, in fact, arguably the most important part is going to be the exams. It's something which scares all of us. Till date, exams scare me. So the panelists for this discussion is going to be, we have 3 gold medalists, Dr. Harini, Dr. Shashwanti, and Dr. Sonal. So Harini got a gold medal in DO exams, and she's a university gold medalist. And Shashwanti won DNB gold medal, and Sonal ma'am won MS gold medal. So we have different levels of, different types of degrees and different levels of expertise and experiences we have with us. So what we'll do is we'll just kind of split into 3 5-minute sessions. First 5 minutes, I'll focus on Harini and her on the pre-exam preparation, what to do before we attend the exams. And the next 5 minutes, we'll focus on Shashwanti's exam part alone, how to answer questions, how to answer in Viva. And last 5 minutes, we have Dr. Sonal ma'am kind of consolidating everything and putting it together. So over to Dr. Harini.
Good morning. Thanks to YOSI for the opportunity. Sir, I would like to start with the first year. So basically, I feel first year is the honeymoon period. So we tend to have a lot of time and we are more relaxed and we are not asked much questions. But I always feel that the first year is the time we need to utilize for studying because you have ample amount of time and spending 1 hour per day would make a lot of difference. So the time spent right from the first year would help you to save a lot of time when you're preparing for your exams. So I made it a point to study for 1 hour or 1.5 hours every day, and then slightly it became a routine, and then I couldn't stop myself from studying every day. If there is a library facility in the institutes, then I think a library is the best place where you can find a lot of books and you can get very much motivated when you see other people studying. So right from the first year, seeing patients and coming back home and just reading what you have seen would make a lot of difference, because I truly believe that the I see what the mind knows. So only if you study, you can be more confident in clinics, and it makes you feel better while preparing for the exams. And in the second year, I think because I'd already gone to the library every day in the first year, it was just a cakewalk for me because I just had to increase the timings. So from 1 hour, I made it 2 hours or 2.5 hours in the library. And it made me brush up all my theory part. And I had prepared a lot of notes. So by the time the exam arrived, I had notes for almost all the topics in all the subjects. So Dr. Pranesh wanted me to speak about the notes. A lot of people ask me if making notes is a waste of time, but I feel the other way. The time spent in taking notes is the time saved later. So my notes is like, the first part of my notes is a printout of the question bank of the particular specialty. The second part is the handwritten notes. I have a base textbook, which could be a Kansky or Payment, and then I add points from standard textbooks. So the second part of my notes is handwritten notes, and the third part is printouts of the articles which I studied from. It could be DOS articles and other articles, and I also refer to AIOS CME series for a lot of topics. So the third part of my notes would be printouts of those articles. So during my exam preparation, I did not have the hassle of looking into multiple textbooks. I had everything organized into one book, and I had a separate book for each specialty. So just before the exams, I had a perfect plan. And because I'd started studying very early, I had time to do even 2 or 3 revisions. And as in our institute, we had a study leave of just 15 days before the exams. So I had written model exams, one test every day. So I wrote 15 tests before the exams. So it helped me a lot to give my university exams. And for most of us, it would have been a long time since we wrote an actual 3-hour exam, at least 2-3 years since we have written an exam. So it helped a lot for the confidence and for writing smoothly for 3 hours.
So regarding what books you would suggest, actually, specialty books?
Yeah, so as I already mentioned, you should always select a base book. It could be Kansky or Payment. In my case, it was Kansky. But for every specialty, I had I always refer to standard textbooks. Like it looks scary. The books look big. The words are difficult. But I think once we start studying, it gave me a lot of confidence. When I quote from standard textbooks, it made me look different. I think that makes the difference in exams. Like the content you give is a little different from the others. I think it makes a lot of difference. So for example, for retina, I read Ryan's. For glaucoma, I read Shields, and so on. So I think it's not wrong to get into standard textbooks and higher textbooks. You can have the base as Kansky or Payment, but then you can always add points from standard textbooks.
Great. So how do you manage the busy OPD? Because we all know how Aravind is and other centers, institutes, especially like given the patient volume, how do you manage busy OPD with thesis, surgeries, and academics? How do you balance everything?
Yes, as I already mentioned, see, our OPD is till 6 p.m. So the time you have after 6 p.m. is like probably a 2 or 3 hours. 9, you need to go home. So how to manage these 3 hours? So from first year, if you make time for studying, like as I already mentioned, I took it slow and steady. Immediately from first year, if I start studying for 2 or 3 hours, I think I would not be able to maintain it. So initially, I made it 1 hour, and then 1.5 hours, then 2 hours, then 3 hours. So the time I have, 6 to 9, I managed it beautifully. And I have to give another tip is that if we go home immediately, or if we go to the room immediately after OPD, after 6, I think it's very difficult to come back and study. So I used to go to the library directly from the OPD. That made a lot of difference. So when I immediately go to the library, I get an ample time to study. So I think residents should take it slow and steady, start with 1 hour a day, and then slowly increase it up to 3 hours a day. And then if with this continues for all the 3 years, I think exams would be a cakewalk.
Great, great. So start slow and start steady and pedal up by the end of the residency. So that's the message what Harini gives. Now to Sashwanti. So how do you actually approach the exams? Like when you enter like into the examination hall, what should be your mindset with regards? And can you give us tips on how to approach Viva, how to approach OSCE exams as well?
Okay, so thank you, Yosi, for the opportunity, and thank you, Pranesh. And Harini has covered the pre-exam preparation really well. So let me talk about the practical exam first. So I think the main thing is to be calm. It's the day of the exam, you probably know everything that you should know. So you don't have to keep rethinking about anything. You just have to go with a very calm mind. And it's also very necessary, depending upon where your examination center is, to carry all the necessary stuff: pens, pencils, erasers, color pencils, lenses, torchlight, fluorescent strips, paracane, everything, because you don't know if the center is going to have it or not. So it's always better to take everything along with you instead of wasting time trying to find it over there. So, and once you go to the examination center and you receive whatever case you're receiving, right now the pattern is OSCE, but we can talk about Viva and case presentation first. So obviously they're going to look at your basic slit lamp examination skills or usage of indirect ophthalmoscope. So these should be very strong, at least for a residency level. And you should already have like simple case pro formas, which you have for common cases. So for example, if you're seeing a case of corneal ulcer, you should know exactly what history to ask, what examination findings to look at. So all these should already be pre-planned so that you can just immediately put them down and start writing them down as you go. And so they'll all cover everything essentially. Then they might ask you to demonstrate. Clinical skill demonstration was one of the stations, I think, at the previous exam. So it's very important to have thorough pupillary, how to check for pupillary reactions, including RAPD, confrontation test, extraocular muscle movements, cover and uncover test, ptosis measurements, orbit examination. All these should be, you should have done this many times before in OPD or presented to your consultants, and these should just be replicated during your examination. And you should not miss the simple things. For example, in a cornea patient, you always have to stain with fluorescent strip before you comment on the corneal epithelium. For glaucoma cases, you should do a gonioscopy unless said otherwise, unless you don't want you to do contact procedures. You should not forget angle grading. For retina, you have to do a scleral depression, and you have to examine the macula with a 90D or 70D before commenting on it. And for squint cases, you'll have to do extraocular muscle movements and all the necessary tests and gradings. And it's also important to draw diagrams wherever necessary, like cornea diagrams, fundus diagrams, all these should also be done. And they're all separated. There'll be refraction cases. So refraction is separate marks. So you'll have to do that separately. And you'll the Viva will consist of visual fields, which is a separate counter altogether, at least in DNB exams. So they'll ask you between neurological and glaucoma fields. So you'll have to go through the different, the straightforward field patterns that you always come across. These are the ones which will be usually given to you in the exam. So you should know what are the causes for those field patterns in neurological fields. And you need to know the optics of different instruments and basic investigations like pentacam, OCT, FFA, ICG, HES chart, MRI, CT. All these can be given to you, and you'll have to talk about B-scan. You'll have to talk about it in a particular order. So all these need to be prepared beforehand. And drugs and surgeries can also be asked, as well as thesis and logbook discussion. So all these should be covered in the practical exam, but you should make sure you do not miss the simple findings and go for a complicated thing instead. So the basics should be really strong, and you should not get confused by the diagnosis. Sometimes you'll already know the diagnosis is. Somebody would have already told you in the exam, this is the patient of diabetic retinopathy. But do not get confused. Just go by what the diagnosed findings you have. For example, in my exam, I had a patient who they said was ptosis, but she also had aphakia, and she also had like there were other findings. So you cannot just talk only about the ptosis and forget the findings that you're actually seeing in the patient. So, and do not hurry to answers. If a question is asked, you can take a few seconds, formulate the answer in your head, and then go ahead and answer. And do not panic when you do not know the right answer, because it's impossible to know everything. And so it's unnecessary to make up an answer and just keep going. You can just tell them that you don't know the answer, and that's also fine. So it's better to do that instead of sitting and making up stuff. So I think this is what you need to follow in a Viva exam. AIOS-YOSI, of course, is a completely new pattern. It's a hit or miss. You either know the answer, or you don't know the answer. It's already what you studied in theory and practicals. And instead of giving long answers, you should just answer to the point, exactly to the question. And actually, that's much easier because the playing field is equal everywhere. So, so these are the things that you should follow for a practical exam.
Awesome. Regarding theory, what would be your suggestion? How to write an answer precisely?
Yeah, the theory exam, I think the biggest thing is time management. So in the DNB exam, you have 10 questions in 3 hours. That gives you around, you should probably give around 15 to 16 minutes for each question. And the first thing to do is read the entire paper. Go through all the 10 questions very carefully and decide which ones you don't know well, which ones you do know well. And you have to make sure they're in order. In DNB, it's very important that you don't write question number 1 and then question number 3. It has to be 1, 2, 3, 4, 5, 6. So you have to make up your mind about which question you're going to spend a little bit extra time on because you know them better, versus which ones you probably do not know enough to write that much about. Always start a question on a new page, and the number of the questions should be named correctly. There's no point in writing extremely good answers and naming it as the 4th question, and it turns out to be the 3rd question. So that's completely going to give you 0 marks for the same question. And for each question, irrespective of how much you know, do not write more than 3 to 4 pages. And always, drawing is better than writing. Drawing, flow charts, labeling is always better than writing. Even if you're not a good, even if you're not good at diagrams, labeling that whatever diagram that you have made should be sufficient. And flow charts and tables wherever necessary. And you should always have a pre-planned idea for common and repeated questions. The last 10-year papers that you're talking about, how the flow should be, like definition, etiology, symptoms, signs. It should go on one particular flow so that you don't miss anything that you should have mentioned in the paper. So it's very unlikely that the examiner will reach each and every word that you've written. So you have to draw his attention to what are the important points by underlining and highlighting them. It's very important to underline or use different colors to highlight these questions or these answers, whatever you want to point out in the answer and whatever you're very sure of. And for anatomy and physiology questions, I would suggest to always give one clinical significance after you finish talking about the anatomy, and not just finish off with just the anatomy or physiology. You can always give one clinical significance, why that anatomy is important or why the physiology is important. So basically, you have to divide the question paper into 3 parts. The ones you know very well, you would like to spend more time, but you shouldn't. There should be it should be done in 10 to 12 minutes. You already know how to write it because you know the question very well. So it should be done in 12 minutes, 12 to 13 minutes. The ones you have to spend a little time, you need to kind of formulate your answer. You have to take about 30 seconds to think about how you want to write it, and then you go ahead and write it. And then the ones you don't know at all, there are some which you'll not know at all. For example, in my paper, there was modular OR and I had no clue about it whatsoever. So these are more than 95% of the students will not know this answer. So you cannot sit and break your head and spend half an hour thinking about this answer. There is no use in that. But do not leave the question blank. That is one of the biggest reasons for failing in a DNB exam, leaving the question blank. You write whatever comes to your mind and do not waste too much time on it. That's it. Just 10 minutes spent on it, write something, fill up 2 to 3 pages, put some flow charts, put something, whatever you know, close to that subject, and then move on to the next question. So I think these are the points that you should think about in a theory exam.
Perfect. Thank you. We have a couple of more minutes. Dr. Sonal, ma'am, can you just consolidate and give from your perspective on how to tackle?
Thank you so much, Pranesh, for including me in this session. And I'm extremely happy to hear these extremely good suggestions from Dr. Shashwanti and Dr. Harini both. They have covered most of the points. I just have a few small things to add. So first thing, I would say that all 3 years before your OT, it pays to be well read before the OT. What I mean is that generally an OT list in an educational institution is posted 1 day prior, and it really is helpful helpful if you study those cases, study the techniques, have a look at the various videos that are available. Now everywhere there are multiple videos that are available of the particular, complicated cases, and that really helps you and puts you, in a mental space in which, you will notice more. So what the mind doesn't see, what the eyes don't see, what the mind doesn't know. So if you are in the OR and you are not aware what is happening, so even an excellent surgery you are assisting, and you will not notice what is happening. And there are a lot of complicated cases, but after a while those same cases will keep repeating. So next time you will be reading 3 more techniques. So keeping some time apart for studying for the OT cases is something which really helped me all throughout the years in my residency, particularly in the second year and third year. Then the one important pearl for the exam preparation for notes is also that having had a look at the previous year's question papers, if possible divide them topic wise, so they are given on many websites also. But when you are making your own notes, they should be in a format in which you can read, retain, revise and reproduce. So what I mean by that is there are some people who don't want to make extensive notes, right? I made extensive notes, but I had a friend who did not. So what she used to do, she made a base book and she would add points from the other books on that in pages that she would attach to the main base book that she had made. It's up to you. Ultimately, what is important is that one night before the exam or one night before the viva, you should be able to revise and then have it in a format where you can reproduce it, whether it is a theory or it is the viva that you are going to attempt. Also, when you are seated across from the examiner, I think it is best to be as honest as possible. If you have done a particular test on the patient, you should say that. You have done it in a particular manner, you should say that. If you have not done a test, do not say that you have done it, because if they start asking you questions about that, they have 20 years of experience more than you obviously, and will see through a lie. And also saying I don't know is much better than saying things which are partially correct, or just making guesses, wild guesses during the exam. It really puts off examiners. And also just about your own case. Suppose you get case which is very simple. Once you've got a case which is very simple in the exam, at that point of time, do expect that they might ask you questions regarding the latest research on that topic as well. The more complicated the case, the viva would be beginning from more basic point of view. But the more simple the case is, you should not become overjoyed, because then they go into the subtle nuances of each and every new paper that has also come up on those things. They can ask you in detail, like congenital cataract will come in the exam. They will ask you about all the latest papers or something which is pertaining to your subject. It may not be something which you might think that okay, they will just ask me this. Then at that point of time, you need to be knowing the research related to that particular topic as well. So lastly, regarding the years of your 3 years of the PG, so it is a time in our lives when we are around 25 to, some people would be doing it post 30 as well. So 25 to 35 are the years which are sort of challenging in terms of your personal life also. A lot of changes keep happening on the personal front. So there should be a way in which you can prioritize your time. You should not let others dictate your agenda in life. That is very important. And you should set aside time, whatever is going on. Setting aside time for your own studies and your own timetable is very important. Compartmentalizing, like people are getting married, people are going through hardships, and all sorts of things are going on. But if you will not keep a regular schedule, it will really be very hard just in the days coming up to the exam. So these are a few pearls that I thought have not been covered before. Over to you, Pranesh.
Thank you so much, ma'am. Thank you all the panelists. Hope the discussion was useful. Thank you, Divakant sir.
Thank you so much, Pranesh, for this wonderful session and great insight we had, and I'm sure it will be very useful for the residents. So next, we'll be talking about publication at an early stage, publication and research during residency. So I invite Dr. Krati to take over the session, and she is a cornea and refractive fellow at Narayan Nethralaya and founder of iLearn.in.
Thank you, Devakan sir, for that kind introduction. A very good morning to everyone. At the outset, I would like to thank the AIOS-YOSI Forum, Dr. Devakan Mishra and Dr. Karan Bhatia for making me a part of the residency roundtable session. In the next 20 minutes, our aim will be to give you an insight so as to how you can start and plan your research journey during your residency. We will take questions in the last 5 minutes of the session, so please feel free to type in all your queries in the chat box. Let me begin by introducing our esteemed panelists. We have Dr. Saurabh Deshmukh, a young dynamic ophthalmologist, founder and editor of the website ilearn.in. He's currently pursuing his long-term vitreoretina fellowship at the Sri Shankar Dev Netralaya, Guwahati. He has published extensively in journals like the JAMA Ophthalmology, European Journal of Ophthalmology, the IJO, to name a few. He has won many national and international awards, including the AAO iWiki International Ophthalmologist Award, Star of India Award by the AIOS, and the Young Researcher Award by TNAO. Next, we have Dr. Bharat Gurnani, Consultant Cornea and Refractive Services at the Arvind Eye Hospital, Pondicherry. Dr. Bharat has close to 60 plus publications to his credit in various peer-reviewed and indexed journals. Next, we have Dr. Sahil Bhandari, Consultant Ophthalmologist and Vitreoretina Surgeon at the Guru Hasti Chikitsalaya, Paper City. He has 18 publications in various journals like the Retina Cases and Briefs and the Indian Journal of Ophthalmology. Moving on to the questions. My first question will be to Dr. Saurabh Deshmukh. How do I start my research journey? The start is the most difficult part. So over to you, Dr. Saurabh.
Thank you, Dr. Krati, for the kind introduction. So first, when a student joins the residency program, he's actually very motivated and he aspires to acquire the academic as well as the surgical skills. But as soon as he starts and ventures into the world of research and he comes across the big articles, he gets intimidated by the sheer amount of size and the effort which goes into writing these articles. And sometimes he might think to himself whether he will be able to write such articles or not. And he might get scared. So even I faced the same dilemma when I joined my residency. And I still remember what my mentors told me, and I quote, "No research is big or small. It is all about contributing to the development of science." So the first question is, how do I start? So you can always start small in the form of publishing small articles, that is the ophthalmic images, photo essays, case reports, and case series, and also letter to the editor. The easiest of these all are the ophthalmic. So these are the ophthalmic images are the easiest article to write and publish. They require good quality images of unique cases and a small manuscript of about 100 to 150 words. And this type of article usually does not require an abstract. As nowadays we all have camera enabled smartphones, it becomes quite easy to capture the photographs in our OPDs. So you can either capture a slit lamp photograph, external photograph, or even the fundus photograph using your smartphones. And an added benefit is that if your photographs are really good, they might even feature on the cover page of the journal. Like the same thing happens with the Indian Journal of Ophthalmology as well. So if you have a very good image, they might even publish it on the cover page. The second type of article which you can target are the photo essays. So photo essay is an article which is actually in between ophthalmic images and the case report. It also requires good quality images and a manuscript which is a little larger than the ophthalmic images, that is about 300 to 500 words, and it usually requires an unstructured abstract. So you can also target a photo essay. The third article type is the case report, which is more structured as compared to the ophthalmic images and the photo essays. So as you become more proficient with the research and you have published a few ophthalmic images and the photo essays, you can target publishing a case report. So what is a case report? A case report usually involves excellent documentation of a unique and a rare entity, or describe a new finding or a unique management strategy. And it is a more structured manuscript. That is, it requires an abstract. The manuscript involves an introduction, a case description, and a discussion part. And if you have multiple cases, for example, if you have 3 to 10 cases, you can club them together and create a case series as well. And lastly, you can write a letter to the editor. So what are these? These are short letters relating to the articles which have been recently published in the journal, that is in the past 6 to 9 months. So you can target that also. So in the end, I would like to say that persistence here is the key. So if you submit an article, the article comes back either with a rejection or the reviewer comments. If you get reviewer comments, you can go ahead, read about it and reply to the comments. completely and nicely. And if you get a rejection, don't be disheartened. It just means that you have to find a different journal which is more apt for your article. Thank you so much.
Thank you, Dr. Saurabh, for comprehensively covering that. So moving on to my next question, that is to Dr. Bharat, sir. How do I plan and undertake an original research or a prospective large sample study during my residency? Over to you, Dr. Bharat.
Thank you, Kriti. Good morning, everyone. At the outset, I'd like to thank AIOS and YOSI for giving me this opportunity. For publishing original research, I'll share my thoughts step by step. Initially, when we join as a resident or a fellow, most of us we have not published our thesis. So the original paper available with us is our own thesis. So thesis is the one thing which we should not forget, and most of it already done it. So just we have to give it to a perfect shape to come into a journal. Another important thing while publishing original articles during residency or fellowship, we should look up to some mentor or a guide so that they can guide us regarding our how to go about collecting data, writing an Excel sheet, literature review, how to target journals, how to write a good manuscript, because during our undergraduate days we have not been taught all these things. So I think the most important guide or a mentor is your thesis guide. He has a lot of things to teach you, and you should treat him like a god. So once so the original, for example, our first original paper came with Dr. Sahil sir. He was there with us, and he was the perfect mentor for us. And we started writing the original paper, and it came out. It was our first publication, and that same paper we presented in All India Ophthalmic Society 2017, and then again we went to present it into APCRS 2000. So your original paper can have a huge impact in your career. So you should have to look for some good mentor or guide who can train you, because we are not initially trained. So another important thing I would like to highlight, that it may look odd to some people, but when we join as a resident during the first year, we should target some small things like some images or a photo essay or a case report, because once we publish that, it will give us a good boost. Because directly going into original paper in first year, we have just joined, so our opthal basics are not that good, and we have not established as a resident during the first year. So first year, you should target a small thing. Once you are through that, second year is, I think, the perfect time to give your full dedication to a original paper. So how a original paper start, you have to have a research question or a good hypothesis, and that comes in discussion with your mentor or a colleagues whoever are working with you, and a good literature review has already been highlighted during the thesis discussion by Dr. Sengupta sir and Dr. Neha ma'am. Then next step is collecting data, we are targeting a prospective study or a retrospective study. Then going into writing an Excel. So we have unluckily or luckily we're not taught like that. So writing a good Excel is also a challenge. That is, again, your mentor plays a big role. Once this is done, you have written a good Excel that has gone through some checks, around 60% of your work is done. Then once the Excel is ready, you can send it to your biostatistician. Most of the tertiary care institutes or good medical colleges have a biostatistician attached. You can send them, and they will go and give you the results quickly. So biostatistics is another one branch. If you're really interested, you can go into the depth. Dr. Sengupta Academy offers a very good course that you can always log into and take some guidance from there. Once the results are available, then the real game starts, choosing a journal and writing a paper. So most of as per my experience, 90% of the researchers follow the method. Initially they start writing the methodology, then go on to the results. Then once this is done, they write the discussion, and in the end they go for introduction and the abstract. Abstract, since it's a concise form of the original manuscript, so it's written in the end. But everyone has their own way. You can follow your own way that you have to design when you are writing a paper. I usually start from basic scratch, from introduction and all. So in a nutshell, it takes around 1 month to 1.5 months to write a good paper. Then once, you should never feel dejected, how to write this big paper. Never. You have to start writing, write something, then approach your mentors. They will guide you, what are the fallacies, what are the pitfalls, how can we improve it. Once it has gone through multiple checks, so the basic manuscript is ready. And then again, the next step comes choosing a journal. You can choose a journal in the beginning, then design your paper accordingly. In the end, also, we can modify the paper. So choosing a journal is another one such a separate area of discussion that it takes a lot of time. Then just to conclude, before just to finish off, like there are two things. So like once you have published the original paper or a small image or an article, it becomes an addiction. You want to do more and more. So giving a kick at the first year or second year is very important. And like we at our institute have a new session like write-a-thon, where we sit for 24 hours and write a whole paper in one day, or maybe a image, and then we try to put it into a journal in 24 hours. And then once you see that name, then it becomes seriously infection or addiction kind of. And another important things, rejections are a part of game. Don't like feel dejected when my manuscript is rejected. Like if the reviewers, like already Saurav has highlighted, if the reviewers have given you comments, try to improve the manuscript and try to put it in 3-4 days or 1 week quickly into another journal, so that you don't feel and don't think about that. So maybe 3-4 journals may give you good comments and the 5th journal will take it. So this is how we should approach in a nutshell from my side. Over to you, Dr. Kriti.
Thank you, Dr. Bharat. That was very extensively covered and very well conducted talk. My next question is to Dr. Sahil, sir. Apart from the index journal, are there any other means of digital publication, and how do I utilize digital learning to my advantage for my research benefits?
Good afternoon, everyone, and thank you, YOSI, AIOS, and the whole team for giving me this opportunity over here. Well, the part two questions. The first thing is the digital publication. See, technically, all the publications are going to go digital, because online you have papers, you have open source, and obviously you have restricted access sources. Yes, but there are few areas like Digital Journal of Ophthalmology where case reports are there. You have many times small surgical video can be presented on YouTube channel. You can make your own YouTube channel. YOSI, our young ophthalmologist group, also has YouTube. So that is also kind of digital publication only, which will give you kind of outlook and your the wings of the your publication, your surgical video, or anything will expand. And another thing, see, digital learning, second thing part, which is digital learning. Well, digital learning is obviously a very vast area, and the knowledge available online in has both the aspect, true and false, both the aspects are there. So, and you cannot always pull everything from the digital world, because nowadays many times we have many of us, we have an habit of directly pulling up. We have a question, we directly go into the open source of the Google, start searching whether it is clinical question regarding a case report or regarding a finding or anything. It is an habit that we go and directly search it off on the Google and probably extract the knowledge out of it. So I think that should not be the base. You should have an idea that what you are searching for. So the first and foremost thing is, when you want to utilize digital learning, you need to understand that what is my target question. That okay, I need to search for this particular thing. So it may be a broad category, it may be a subtopic, it may be just a rare finding, it may be a confusing finding, it may be a side effect, anything could be there. So what actually it is you need to just first think about it. You will, okay, what I need to search. Then you need to divide it into two things. That do I need to search it for my knowledge base, or do I need to search it to make it up and convert it into a research question or go ahead with the research thing? Because many times we will think, okay, let's something comes into our mind and we may think, oh, it is a good thing, it is a good point, that okay, let's start and think for all publication kind of thing, or go for research. But then when you go for the literature search, you'll get to know that, oh, this has been published so many times and almost everything is there on table. So you may get demotivated. So that is very important. So when you start searching, you need to understand that what you are searching for and where do you need to search it for. Not everything goes on to open source, not everything goes into PubMed only, not everything goes into journals only. You have also e-book problems. So it is very important that many times when you are searching for a particular topic, you may have to go into your base textbook, based ebooks, so that you get to expand your knowledge first, and then you pull out the question, your hypothesis, you question your lacunae from it, and then convert it into research, because that is the base of the research. When how do you want to go into a research, you will obviously have to find a lacunae. So to find the lacunae, you need to have a good literature search. To do a good literature search, you need to understand that where do you want to search from the beginning, from the first part. So that is also very important. And then you can divide it. Like if you want to search for a case, rare case, then it is very difficult to go into books, textbooks, ebooks, it is better to go on to the case report publications, case reports, journals who are publishing only case reports. Or there you will find a rare case presentation, or you will search the PubMed, there you'll find a rare case presentation. So that is one another thing. One textbook knowledge is another thing. So this is the thing, main important. You just divide it off, and then you go ahead and divide it into two parts. So that whether you want to expand your base knowledge or your research knowledge. Also, when you are searching all these things, make sure that you archive your knowledge, archive your digital knowledge, because when you have searched it, where are you going to store it? So you need to understand that everything cannot be you just search and keep it on written paper or somewhere, and then you may probably forget it also, or you may not be able to follow it or also. As one of our panelists mentioned, that you need to have a very good reference manager, so that end of the session or end of the year, you may not get confused. So same thing is for the digital learning. You should archive it probably on the basis of your own knowledge, folders, pointers, Word document, or an Excel sheet, as Dr. Sengupta sir used to maintain during his residency. I think probably now also you maintain an Excel. When you want, you have subtopics like, okay, you are searching for this particular topic. This is a good source. This is a second source. This is third source, and I've completed this thing. So that Excel will help you in long run, even for your exams, even for your thesis, even for your references. That okay, I've searched from this part to this part. So digital learning is a vast area. You need to prioritize everything. You cannot just start everything like this. Okay, ये भाई आज कुछ ढूंढना है, I need to search something, and just I open up everything and then I go variably, because it will obviously utilize your time also, which is obviously a constraint during your residency, during your fellowship, or even when you are clinical practitioner. Every time the time is always a constraint. So try to prioritize your topic of search, target of question, and source of your digital learning, which could be anything. Even your social media, even your WhatsApp, Facebook, anything, especially moderated websites, surgical videos. So everything has a base. So everything has a kind of subcategory. You cannot keep pulling everything for every one point from every other source, but you need to prioritize that digital learning also. So that will probably help you in a long run, and at least give you a good result in a constrained time. That would be my point of thoughts. Thank you.
Thank you, sir, for that extensive insight. We have one question in the chat box. Dr. Saurabh, would you like to take it? The question is by Dr. Chitranjan Mishra. How to publish cover image? What are the journals that accept it?
Okay, so the cover images are usually the images which are taken from the articles which are published in that edition of that journal. And some journals usually they ask for cover images, like the I journal, which is there. They have a separate section on the website where they ask for a cover image. So there you can submit it separately as well.
Okay, and another question for Dr. Saurabh Deshmukh is, how do we publish multidisciplinary publications in various other subspecialties like you've done for Indian Journal of Pharmacology?
So if you get a case which is crossover between two different specialties, like we had a case who developed adverse drug reaction after perivulvar lignocaine anesthesia. So we thought of publishing it in the Indian Journal of Pharmacology, and we submitted it and it got accepted as well. So if you have another case, like we tried to publish as a uveitis in a case of psoriatic arthropathy, so that you can try in a dermatology journal as well, also in ophthalmology journal. So like that, you can cross over in both the journals, you can try.
We would like Dr. Sabyasachi sir to give his comment, please.
Yes, thanks, Kathy. I think I wanted to make a very quick comment is, let's publish meaningful papers, which will actually impact practice and, help improve treatments and other things. And also let's, think about publishing ethically and responsibly. I think all of these words are really important. And, in my work as an associate editor, I see a lot of, unethical work, sometimes plagiarism being done. So, I think it's important to inculcate these basic ideas right from the beginning as well, not necessarily quickly, but, responsibly and ethically as well. That's what I wanted to make. Thank you.
Thank you, sir. Thank you, everyone, for the wonderful session. Over to you, Dr. Devakant, sir, for the next session. Thank you.
Thank you, Krati, and thank you to all the panelists and all the comments by Sabyasachi and Namrata madam. So next we have the session on innovations and again, how to go about during residency or at an earlier age. Dr. Nilesh will be taking care of this session, and he is a young innovator and is quite interested in smartphone innovations. Over to you, Nilesh.
Thank you so much, sir, for this opportunity. Good morning, everyone who have tuned in on this Sunday morning. Thanks, Yosi, for giving us this platform for the innovations. I'd like to introduce today's panelist. Dr. Amar Pujari, sir, is assistant professor in RP Center AIMS. He has 124 PubMed Index publication, and he has won various awards, including AIOS Sante Vision Award 2020, and he has been invited on multiple international podium to give his talks. Dr. Ashish Ahuja sir is a vitreoretinal consultant at Sadhu Kamal Eye Hospital, Mumbai, and he is also advisor to AIOS-YOSI Healthcare Technology, healthcare startup providing artificial intelligence platform for diabetic retinopathy screening, and he has more than 20 publications and various patents that are pending. Dr. Prakhat Rup is senior resident in cornea, cataract, and refractive services at RP Center AIMS, and his academic interest lies in IOL technology, and he has won over 5 awards in innovation session. So residency in the majority of our country is a low resource program. Residents do not get too much of access to cutting edge technology. That deficiency is the most fertile ground for frugal innovations. All the residents keep getting various ideas to counteract the difficulties they face due to the lack of resources. Now, getting ideas is one thing, but to persist with it, to make it into a thing, be it a technique, a product, or anything else, and then to take it to a level where everyone can appreciate, it requires a path and a guide. Dr. Amar sir has validated many such ideas in clinical settings and has been publishing regularly. So let's hear from him how to validate your idea into a clinical setting.
Thank you, Dr. Nilesh. Good morning, Namrata ma'am, and hi, Dr. Devakant. As Dr. Nilesh has taken a very key topic for the discussion. So being innovative is important from clinical examination point of view and your like surgical point of view and even with respect to publications. So with respect to clinical examination, when I was junior resident at RP Center in 2014, I made a spectacle mounted indirect orthoscopy for 400 rupees. So that was my first innovation. So after that, so many people told me to pursue till patent or something, but I didn't do that one. I published it, and after that one, I made the Bowman's probe, which did not have any numbering. So I made it a calibrated Bowman's probe. I published it in IJO. So again, I didn't pursue for any of this thing. So when I became SR in RP Center, so I went on to doing some innovations in smartphone. So we described more than 10 different techniques with respect to anterior segment imaging, glaucoma imaging, optic nerve head imaging, retinal imaging. So ultimately, we were able to gather so many publications. At the same time, we were able to write good reviews on graph page ophthalmology, survey ophthalmology. So this is with respect to our clinical examination tools or techniques. So at the same time, being innovative with respect to our surgical skills. So with respect to that one, I have discussed so many techniques in oculoplasty because I was doing oculoplasty as a senior assistant. So in addition, in wet lab also, I discussed so many techniques. And with respect to publications, as Dr. Sapyasachi was saying, so it's very important to do or think in an innovative way. So being innovative, we want to contribute something to the literature positively because we don't want to just publish it and if nobody is reading, nobody is following that one, if it is not helping clinically, it's of no use. So in the same manner, if like particularly if I take one topic, I want to work continuously on that one. So for example, I was interested in like knowing what is the posterior polar posterior capsular status behind the posterior polar opacity. So I published till 3 papers till now. So fourth paper is under preparation. So in the same way, I have done one of the another study on accommodation, so which is under review in RO journal. So what I mean to say is like you need to be innovative from all perspective, and you need to think in such a way that some people are going to say in North Indian language it's going to be jugaad. So, but if you like say to the Western people, they will call it as an innovation. So you need to think which is going to reach so many people. Why phacoemulsification is more famous? Because many people are able to replicate. If you take some extreme ideas, if you are able to do something on that one and people are not able to replicate that one, it won't reach a larger audience. So we need to think which are disturbing majority of the people. We need to take innovative solution out of that, and so we can present in front of people and we can give something positive to the literature as well as ultimately we need a like appreciation from peers. That's it. So no technique is being used by the patient. So ultimately, our colleagues are going to use our thoughts and ideas. So it is better to think comprehensively how we are going to help our colleagues first. So that will make us a better innovators. Thank you.
Thank you so much, sir. I think the most important point you made is to get an idea that can be used by everybody. So how to make that validated clinical idea into a prototype that may go for a commercial production or a patent is the next level in innovation. Dr. Ashish Ahuja sir is someone who does most of the prototyping of his ideas himself. So let's hear from him about how to develop a prototype.
Hello. I thank the UC Forum for, first of all, giving me this opportunity to discuss and share ideas on innovations. So nowadays we are in a very digital era where we have access to technologies like 3D printing and rapid prototyping. So it is much easier compared to what things were 15, 20 years back. Like if we have to make any model or an instrument, it is very easy to go to the nearest 3D printing facility, discuss with the team over there. You can share, I have shared hand drawings with the team and they make a prototype on the computer. They make a CAD model and the entire process would cost about 10 to 15,000 rupees, even in a private center. So you can design this and they can print a model where you can tweak the design, you can add some customized components. So it is difficult to approach the big companies with your ideas because they will not be able to develop it in the traditional way. Our normal stainless steel or titanium instruments, no, they require injection molding to develop. So each mold cost about 1.5 lakh. So that is a very long process which can't be used to make individual prototypes. So 3D printing is one way where we can tap into.
Thank you so much, sir. So that is the main thing. The R&D, it takes a lot of financial resources to make. So try to go for a 3D printing, get an idea, and then either try to patent it or to go for a commercial production. You can approach the companies. So once you have a prototype, it needs to go commercial so that others can benefit from it. That is the ultimate goal of any innovation, to be used by everyone in a very effortless manner. That is what my mentor, Dr. Ashish Sharma, has told me repeatedly during my journey. Dr. Prakhyat sir has two commercial products, a negative dysphotopsia ring and edgeless diffractive multifocal lens. So let's hear him out how to take that last step.
Thank you, Dr. Nilesh, and thank you, AIOS-YOSI Forum, Dr. Devakant, for including me in this discussion. As Dr. Nilesh said, I've had an experience of dealing with the commercialization of a product recently. One correction, I do not have two products yet. We just have one product, which is the negative dysphotopsia ring. But my experience with the industry has been very, very different if you come to an Indian company versus a giant like a multinational such as Alcon or J&J. So to realize the commercial value of your product, the most important thing is there are two aspects. First, you yourself have to realize the value, which you will do when you see its benefits clinically in the clinical setting. You discuss it with your peers and you realize that this thing is a problem that is faced by many patients and many surgeons are looking for a solution. The other thing is making the industry realize its value so that they take it further in their production and collaborate with you. So the first aspect is knowing the true need. If you have a product that is actually addressing a need that is felt by the patients already, then that has commercial value. Secondly, the need has to be addressed very easily and precisely. For example, the negative dysphotopsia ring, people keep on asking me that there have been so many interventions that have been described to treat negative dysphotopsia. Why this ring? The answer is that it is efficacious to an extent that no other device or implant or intervention has ever been. Patients are increasingly becoming more demanding, especially after they get a premium IOL implanted, because they are those kind of people who have those kind of needs and those kind of perceptions that they are symptomatic. So with the time progressing, I realized that there are going to be a lot of patients and there are a lot of surgeons who would like negative dysphotopsia addressed, and there is no device that is as easy to implant and gives as efficacious a result close to 100% as this device. That is why I approached an industry person to get this product manufactured and commercialized. The other aspect is patenting. As Dr. Amar pointed out very precisely, there are many good innovations that are going to impact clinical practice, as Amar sir has done, and I myself have learned a few things from him and have been using them while doing our cases. For example, in posterior polar cataracts, we now do AIOS-OCT, know much better and are prepared much better in our OT. Doesn't necessarily mean that the innovations are going to be patentable, but that doesn't mean that you should stop innovating, because the thing is that today the innovation might not be patentable. Tomorrow you might get an idea that is worth patenting. So to realize the commercial value and then get it patented is important, because if you are going to approach the industry, then you have to have that protection of the patent. Otherwise you are not going to be entertained by anyone in the industry. Thirdly, it is important to get associated with someone who listens to you completely, who is approachable, and who can work fast. For example, I associated with Care Group, and they were very proactive in making the prototypes and giving it to us so that we could use and test them and confirm the efficacy. If you go to another big industry giant, first to get their ear is a bit of a task, because to find the right person itself takes about 8 to 10 months, and then when you find the right person, their processes in the corporate world are so long trodden that an innovator or a person like us who is fast and thinking on the tips cannot really keep up with it. So I think these are the few aspects that one should look at if they are thinking of commercializing.
Thank you so much, sir. And anyone, all the residents, I would like to inform them that each state now in India has an innovator. At least one prominent innovator is coming from each state. So any one of you, if you get an idea and you think that your institute do not have any innovator who can guide you how to take the path, you can contact any of us, Dr. Prakhyat sir, Dr. Amar sir, Ashish sir, or anybody for that matter. There are many innovators. You can just check on the AIOC editor proceeding. Almost like 20 to 30 innovators each year are presenting their innovation. So you can contact any of them, and I am pretty sure everybody is going to help you. And they are not into commercial production, so they won't be stealing your ideas, I think. So you can just go and ask them. They will surely help, and you can take that path. Don't you just have to take that first step, take the first plunge, and then you can swim across the river. It's very easy once you take that first step. Thank you, Devakant sir, for this opportunity. And just before signing off, I would like to invite everybody to submit their publication to your slides. Thank you.
Thank you so much, Nilesh, and all the panelists for the wonderful inputs. And it was really an eye-opening session. So next we move on to the fellowship section, a very important and pertinent topic as well. And I invite Dr. Sagnik Sen, who is a fellow at Arvind Eye Hospital, Madurai, in the VR department, to take care of the session.
Yeah. Hi, good morning, Dr. Devakant. This is Sagnik. So we heard some beautiful talks on how to maximize your benefits during residency training in ophthalmology in India. So now the next session that we are going to target is the fellowship training. So for every ophthalmologist, fellowship training is actually a subspecialty training after your broad general ophthalmology training, and it gives you an idea on how you're going to tackle your branch in future. So I will be handling the retina fellowship since I'm a retina fellow myself. I'm in the final year of my retina fellowship training, and
Hello? We lost connection, right?
I think he'll take some time to get back. Maybe Dr. Rohit, Dr. Apurv, Dr. Divyansh, you can carry the discussion in the meanwhile. I'll just call him up and check on him.
Yeah. Thanks, Divikant, for inviting us to the panel. So we'll be...
During my residency, I had got a one-year exposure in retina, but I have seen. Can you hear me? Can you hear me? Yeah.
Yeah.
So
yeah.
I'd like to welcome Dr. Apurv Grover. He is the current VR consultant in Vision Eye Center, New Delhi. And I'd like to know from you, sir, why did you choose the Vitro Retina Fellowship and why did you choose a retina career? And you also have a special interest in ROP. So I'd like to hear also about that, about the other subspecialties of retina.
Yeah. Thanks, Sagnik, for the question. Are you able to hear me well?
Yes, sir. Yes, sir. Please go ahead.
Yeah. So, firstly, why VR? I think it's the most important thing is whether you your own interest. If you you should enjoy looking at the retina. You should enjoy the long surgeries. You should enjoy bending your back to find that extra break. So once you have the interest, that's the main thing, I think. And then when it comes to demand, I think our VR branch will be the most in demand over the coming few years. This is there's primarily because of the you can see how the diabetic patients that we see in the clinic are increasing every day. There's an increase in lifestyle related disorders, diabetes, hypertension. And if you look at the numbers of diabetics in India, it's just shooting up, and it's 77 million now, and it's projected to double over the next 20-25 years. So people are exercising less. There's more packaged food, processed food, unfortunately. So I think diabetic retinopathy is something that will keep all of us busy in the future. And then besides that, you have people who are living longer because of advances in medicine. So people are now average life expectancy in India is like 70 years. So with the with this will come rise in wet ARMD, because a lot of patients are coming to us with wet ARMD, and people are living up to 70 to 80 years. So you will need more and more retina specialists to be able to follow up these patients regularly. They will need periodic injections, follow up. And besides that, as you talked about ROP, now we have tier 2, tier 3 cities coming up with NICUs, and babies are actually, these premature babies are surviving. So there should be a special emphasis on, training young retina specialists to be able to diagnose and treat retinopathy of prematurity and other pediatric retinal disorders. So there will be, so that, these babies are able to maintain a good vision during their lifetime. It's very unfortunate to see a young baby go blind from a treatable disorder. So I think there is a lot of demand. We should that's the reason we should take up a VR fellowship besides our own interest. Yeah. And then there's a lot of research in hereditary retinal disorders, gene therapies coming up. So there is a bright future prospect for upcoming VR specialists.
Yeah, thank you, Dr. Apurv. Very nice insights. So as we can see that in contrast to cataracts, which is the bread and butter for ophthalmologists, retina as a specialty, it ranges from age groups like right from the newborn to more than 70-year-olds. So there's a wide variety of diseases that we need to be aware of and train ourselves. So I'd like to invite Dr. Divyansh Mishra next. Dr. Divyansh was a fellow in Shankaraya Hospital, Bangalore, and he has continued to work there as a VR consultant. And he also has a special interest in ocular oncology. So I'd like to know from Dr. Divyansh that how is the training in VR in general in India? And since there are so many aspects of retina specialty, like ranging from medical retina to surgical retina, there are lasers in different age groups, like ROP laser is especially, it's a completely different training. So how do you go about training in retina in India?
Yeah, good morning to all, and thank you, Sagnik, for this opportunity. Thank you, Yosi. Thank you, Divikant.
So there is an enormous options which are available presently for VR fellowships in India. Choosing a right fit for ourselves needs a lot of introspection. What we want to do, whether we want to aim at medical retina, surgical retina, or academics, research, or we have to only think of doing surgeries, multiple surgeries. So for having a largest piece of a pie of that particular specialty which you want, you may be required to either dedicate your additional years, not only 2 years, it may require 3 years or sometimes 4 years also. Either we have to work longer as a fellow or probably work additionally after our fellowships for research. And as what Einstein said, if a person masters the fundamentals of its subject, what exactly VR is and basics of it, and has learned to think and work independently, he would surely find his way. So it's the will where there is a way. It's not that the institute is not good or institute is the best. It's where we fit the best or we find the best in that particular institute or the place. So in a vitreoretina subspecialty fellowship, it is challenging, but yes, rewarding in a long term because it takes time, because it has a steep learning curve to learn via surgeries per se. Fellowship is a period of transition from residency to clinic, and it aims to transform a general ophthalmologist into a safe and independent VR surgeon. There is no straightforward rule to maximize an output from a VR fellowship, which gives us a maximum output. But yes, I must say that hard work, sincerity, dedication, and persistence are the pillar for getting the best out of your training program wherever you are. In today's era of social media, word is a limit. While we are in our training phase, we need to expand our contacts beyond our alma mater, either nationally or internationally, to give us opportunities to collaborate with various out means other fellows outside your department or your institute. Regarding the ocular oncology, the specialty which I'm very interested, that's the basic motto was the push or the understanding which we had from our mentor, Dr. Mahesh Shanmugam. So we have been seeing many things in ocular oncology like lasers, cryo, TTT or a transpupillary thermotherapy or intravitreal chemotherapy or assisting supraselective intra-arterial chemotherapy, a localized brachytherapy, which one of our centers is a referral center for, diagnostic and therapeutic vitrectomies for challenging cases, excisional or incisional biopsies, and most important, endoresections or exoresections like PLSU, something which is called as partial lamellar sclerouvectomy, and yes, in certain cases, enucleation. But last but not the least, the managing of radiation retinopathy. And yes, doing ocular oncology gives us an additional horizon, not only managing our routine cases of vitreoretina, but also masquerades and the most sinister ones like eye cancer. Thank you.
Thank you, Dr. Divyansh. And since you said that the fellowship gives you an insight into what you may expect in the real world, like since you have a retina surgeon will have at least 40 to 50 years of career lying in ahead of your training. So you might need additional training in suppose in ocular oncology or in ROP, or especially if somebody is interested in medical retina research. So looking at career perspectives, I'd like to invite Dr. Rohit Modi. Dr. Rohit was a fellow in vitreoretina in LV Prasad Eye Institute, and currently, after gaining experience, he has joined private practice currently, and he also has a special interest in UVA. So I'd like to ask Dr. Rohit, what has your life been as a VR consultant post-fellowship, and how do you see a retina consultant practicing in an institution and in a private practice, and how is your practice relevant in the community as a whole?
Yeah, thanks, Sagnik, for the question, and I would like to thank Yosi and Divakant for giving me the opportunity to be a part of this session. First, my experience well in the private practice has been amazing, and I feel it is pretty rewarding. It is quite different than an institutional practice because in an institution, you are taken care of with respect to your diagnostics, the surgical setup, and the patient flow. In private practice, it is like setting up your own factory, I would say. It's your own startup, so you have to look in for your setup with respect to your diagnostics and surgical setup. So the economics also plays a huge role. And I went really slowly on the setup part. I bought one instrument every 6 months depending upon the patient flow. But I believe that we can start big and succeed. There is a huge demand for VR. And also another thing which I've learned over a period of time is it is better to start with a charitable hospital also. It gives you good number of cases. It keeps your hand moving. Also, it gets you in touch with a lot of anterior segment surgeons, where those people can also start becoming a referral base later on. And when you're setting up your practice, an important decision you have to make is whether you want to do a subspecialty practice exclusively or do a comprehensive practice. Now, if you're doing a comprehensive practice, it's okay and acceptable in a city like Mumbai. It may not be acceptable in cities probably like Surat or Ahmedabad. So that's a call you may want to take, because retina pays well, but cataract is also easy money. So it also funds your buying of equipments. As for uveitis, yeah, it's like a soul thing. I love uvea. Another advantage uveitis has given me is that quite a few retina specialists are not well trained to treat complicated uveitis patients. So if you manage them well, a lot of anterior segment surgeons start also sending their complicated retina patients to you. So you can gain confidence of a lot of referring surgeons by treating the uveitis patients well. So that was another advantage with getting trained in uveitis.
Thank you, Dr. Rohit. So as I understand, being a final year fellow, there's a lot more years of training left for me. It may be in the form of a job as a consultant somewhere, post fellowship experience. I need to gain in various different small subspecialties of retina again, and it might take 4 to 5 years to get established in your niche area in the retina subspecialty as well. So I'd
Yeah,
like
I
to
think
give over to Dr.
Sagnik,
Divakant.
yeah, I think
Yeah.
even working as a consultant for 1 or 2 years after your fellowship, in a good institution under a good mentor really helps you gain surgical confidence, and even in clinical situations. I think that is very useful.
Right. So yeah, thank you so much, everybody. I'd like to give over to Dr. Divakant to carry on with the next session. Thank you, everyone.
Thank you so much, Sagnik, and great inputs. I'm sure it will help residents to take up this specialty and how to take it forward in a more constructive way. Next, we have the cornea session, and I invite Dr. Aparna to take over the session. Are you there, Dr. Aparna?
Yes, sir. Am I audible?
Yes, Aparna. So she is presently working as a cornea consultant at Prasad Nethralaya, Mangalore, and she had done her cornea reps fellowship from Shankaraya Hospital, Guntur. Over to you, Aparna.
Thank you, Dr. Divakant, sir, for giving me this opportunity. Also, thank you, Team YOSI and AIOS, for giving me this opportunity to moderate this session. So I'll be sharing my screen. So is my screen visible?
Yes, please go.
Yeah, so I'll be introducing the 3 panelists for today. We have Dr. Aditya, who has done his fellowship from Disha Eye Hospital, Kolkata, and he's presently working as a consultant in cornea and external diseases. He was also a research fellow at LVP Hyderabad, and his special interests are in infective keratitis, allergic eye disease, corneal transplantation, dry eye disease, and corneal tattooing. Our second panelist is Dr. Jyoti Mitra. She has done a fellowship in cornea from Priyamvada Birla Arvind Eye Hospital, Kolkata, and she's presently working in the same hospital as a cornea consultant. She has done her MBBS from SSKM Hospital and her DNB from Rotary Narayan Nethralaya. She's an avid reader and has a keen interest on corneal diagnostic. Our third panelist for today is Dr. Sagnik. He has finished his fellowship in cornea from Sushruth Eye Hospital, Kolkata, and is presently working there. He has done his MBBS from KMC Manipal and he has done his MS from Salem, Tamil Nadu. So we'll be starting the session. So choosing the right fellowship at the right place goes a long way in helping us carve out a successful career. This is going to be an informal discussion, so the audience can feel free to ask their queries. So we'll be discussing few basic things here. So the first question I would like to ask Dr. Jyoti, why cornea refractive surgery? What made you choose this subspecialty? Dr. Jyoti?
Good morning, Namrata madam. Good morning, Divakant.
Thank you, AIOS-YOSI, to give me this platform to share my experience and why I had asked myself this question 5 years back, that why I wanted to take up cornea. Probably the first issue which we get to see in a slit lamp, the more in the anterior segment, is cornea. And this is a tissue which tries to speak to you about its disease, about its condition. You just have to be read, like you just have to know what you're trying to see in the tissue. You don't have to search anything in the tissue. The tissue is right in front of your eyes and it's trying to speak to you. And probably I have done my DNB from an institute where I was lucky enough to have an exposure in the cornea transplant surgery and the post-op patients, where I was lucky enough and I was very much intrigued to see the perfectly central clear graft. And probably I thought I wanted to be a part of this surgery in the future. And most importantly, what actually shaped my career to be a corneal surgeon is that early in my ophthalmic career, I was lucky enough to have a mentor in the state of West Bengal, Dr. Jayanshu Sengupta, who has been a very patient mentor, and his willingness and his wisdom to guide each of his fellows with time and patience has really helped us to be what we know and what we are trying to learn and what we are actually pursuing currently in our hospital. And overall, the way he actually sees the subject, and he has actually helped us to shape the concepts with relating to corneal diseases, is really important. So probably to finding a correct mentor and practicing surgical techniques and emphasizing mainly on suturing in your post-graduation days probably helps us to just carry the procedures and the diagnostics and the treatment portion of the tissue structure itself. So yes, that is from my side.
Dr. Aditya, any inputs from your side on this?
See, basically, it is all about finding the passion in your post-graduation days. There will be always be one part or structure of the eye towards which you develop a keen interest for whatever reason. Either your mentor is from that same department and has left a profound influence on you. So basically, your formative years in the post-graduation part will lead you towards your fellowship. So if you see a keen interest in that part and you wish to pursue it further, I would definitely encourage everybody to take up fellowship, because it definitely sets you apart from the crowd, and you have a special edge, be it in your usual talks or invitations or surgeries or whatever presentations. Being in a part of a fellowship definitely helps, but passion rather than economic interest would dictate the same, as according to me. That why cornea, why not retina, or why not plasty, it all depends on whether you are passionate enough to see yourself on that platform maybe 5 or 10 years down the line, and not just the fellowship part.
Thank you, Dr. Jyoti and Dr. Aditya. So my next question would be to Dr. Sagnik. What was your experience during your fellowship, and how did you get the maximum out of it? Dr. Sagnik?
Yes, good morning, everybody. Am I audible?
Yeah.
Yeah. Okay. Thank you, Team AIOS and Team YOSI, for including me in this discussion. Actually, fellowship, I did a fellowship because, very frankly, my surgical exposure in residency was less. So to become more confident in surgical procedures, I had to do a fellowship. And what I would suggest is, I wanted to become a complete anterior segment surgeon. So the cornea appealed to me because not only you deal with the entire anterior segment as such. So you do in any cornea fellowship, most of the cornea fellowships, cornea and cataract both are included. So for any traumatic cases also you can manage. You can do a cornea transplants also. You can do complicated cataracts also. You can do combined procedures also. So that helped me initially go towards this cornea fellowship. And my experience in fellowship was pretty good, like I did in Shushrutai Foundation, Calcutta. So here we received a lot of hands-on, and uh, mostly I would suggest, like, my the how to maximize your fellowship thing. I would suggest everybody get a very good initial tissue handling experience that will help you gain confidence in cornea procedures. Cornea as such is a very delicate and fine surgical field. So before you approach cornea, my advice to everybody would be have a good, um, as I said, tissue handling from a SICS point of view, from a surgical manipulation point of view, and then observe as many procedures you can. If you have a good mentor or consultant in your fellowship, that has an immense help. And clinics are also very important, because most of the times cornea has a lot of uh, diseases which we need to diagnose. And because so many, as a resident or just after residency also, if we haven't had much exposure in cornea, everything looks the same. Like, oh, these are just white spots, and I'm unable to figure out whether this is a dystrophy or degeneration, or sometimes even like peripheral corneal ulcers can look like something else. So clinics, we have to pay a lot of attention to the clinics. Suturing is very important, and we need a lot of time to be good at suturing. So if you have a wet lab in your hospital, in your fellowship center, or institute, please keep on going there at your spare time, and keep on practicing suturing. That will give you confidence also. Um, and during, I would say, that a lot of institutes, there are a lot of institutes in India which offer so many fellowships. Every institute has its pros and cons, of course. So that we have to decide. It's like initially it's like a hit and trial thing. What is which institute will work for you, which procedures will work for you, which protocol will work for you. I used to try to do as many cornea repairs possible. That also gives you a confidence. And then initially during fellowship, you might not learn all the procedures. What we learn, what we see that, oh, cornea has a lot of procedures. But during fellowship, when we are starting out, so initially we might start with corneal tear repairs, then cross-linking, then therapeutic penetrating keratoplasties, which are one of the most common things and these are the ones which are given to the fellows initially of the initial period of fellowship. So if you're lucky enough, if you're very lucky enough, that you might get some optical PKs also. And I feel post fellowship also, you need to stay at, if you stay at the place of your fellowship for 1 to 2 years after fellowship, then it actually helps, because people know you, so you get more hands on, you get to do the better procedures like DSEC and refractive. So we have to stick on, we have to keep on. Lot of patience is required during fellowship, so we have to have that patience. Yeah, that's all.
Okay, thank you, Dr. Sagnik. So, can Dr. Jyoti share her experience too?
Yeah, so initial days in the first years of my fellowship, we had theoretical discussions. We used to have our fellow classes in the morning hours. Following that, OPD hours would start, where we would be trained actually initial days to do the epic drawings of the cornea, which is very important. Okay, we need to learn how to make those diagrams, and they would actually help, in understanding the progress or the worsening of a disease. So diagrammatic representation in corneal diseases is very important. Second, having a rapport with the patient, because mainly the patients are long-term follow-up. So how to build a rapport with the patients, this was what we were taught in the fellowship. Then thirdly would be, yes, coming to cataract, we would start with the SICS, skip on to phaco, and after phaco surgery and the cataract, we would go to the eye bank collect the tissues that was not suitable for surgery, and we would keep trying with the suturing, which is a very, very important aspect of cornea fellowship. Following suturing, when you think your sutures are correct, radial, with proper tension, we would get cases like as discussed by Sagnik, like the simple corneal tear repairs, the complex corneal tears, and gradually we would get our hands into therapeutic. And if you're very lucky, you will have a brief stint with a refractive surgery like PTK or PRK or LASIK. I was lucky enough to get experience with refractive procedure in my fellowship days. So yeah, that's all, Aparna, from my side.
Okay, thank you, Dr. Jyoti. I think that's how the transition goes from tears, cross-linking, and in the end, it's like we might get refractive. So that's how it goes. So next question, any of you can share their experience on life as a cornea surgeon and what is the future in our country? Dr. Aditya?
Yeah, so uh, the past year has been quite difficult for I think everybody of us, especially corneal surgeons, because tissue availability was a huge issue. Before that, the situation was quite stable. If you were talking about something about 10 or 15 years ago, doing cornea practice outside an institution was almost impossible because there were a lot of paperwork involved, and more so having access to a good eye bank was difficult. But that situation changed with the centralized distribution system. There were some other players which entered into the market, and tissues were suddenly available to each and everyone. Also, the training opportunities beyond your own institute and your fellowship programs are also on the rise. So you could just visit a particular mentor in a city and learn the finer nuances of keratoplasty and have access to the tissue as well. But 2020, the pandemic struck and then everything went for a toss. But now I think we are now slowly moving back to normal. The keratoplasty numbers are also going up at our institute. So the future is definitely looking bright. But one piece of advice is that even that all of us are YOSIs and we are like young and eager to do the surgical part of it. I firmly believe that the medical part of cornea practice is extremely challenging, and there are innumerable conditions which we can, as cornea specialists, manage medically beautifully with great outcomes without having to resort to complex surgical procedures. But that is the place where most of us go for a toss, and differentiating and diagnosing the lesions becomes difficult. So the objective, like Dr. Divyansh also in his retina fellowship said, that the fellowship is not be all and end all. It is a lifelong learning process, and you have to stick it out even after your fellowship. It doesn't stop at 2 years or 3 years. You have to keep at it and become a more efficient physician, so to say, rather than a surgeon. The same skill which you pick up in your clinics and diagnosing will lead to a better thought process, a better algorithmic approach, so to say, in your thoughts, so that you can take the appropriate surgical decision if and when needed. So even if surgical skills are definitely needed to improve in your residency or your yeah, the medical part is extremely important. That is, I think, most of us falter. Yeah, I think Dr. Madam wants to say a few words. Dr. Namrata, yes.
Yeah, thank you, Aditya and Aparna and Joyita. I think, as well as all the others who've put in their, thoughts. I just want to say that in fellowship, whatever fellowship is a stamp. Of course, you have to learn your skills, etc. But what you become in life is what you do much later. And like Aditya said, it actually is also destined. Like I never wanted to do cornea, I wanted to do retina because at that time retina was the thing, which was where a lot of new things were coming. But it so happened that there was no seat, so I had to shift to cornea. So it is also, some things are also destined. And one advice that I will give to all the youngsters is that whenever you go for any conferences, you tie up either 2 days before or 2 days later with some center, you know, in which has a topic of your interest, or attend, a couple of clinics, or attend their ORs, because it's a different atmosphere completely, and it gives you a different kind of culture, and it gives you a different way of looking at things. So, and I also would advise that even if it is a short term fellowship, if you can do one fellowship outside internationally, then it makes a lot of difference. So if you have time and if you have opportunity, please do it, because it gives you another kind of confidence, and it gives you another kind of it enables you to learn things differently. So a short fellowship, maybe it is 3 months. And of course, if you can't do a fellowship, then always when you do international conferences, do tie up with some centers so that you can visit those centers by just going 2 days before or 2 days later. So that will really help you in any fellowship, not only in Konya, but in any fellowship. So thank you. I think great program.
Thank you, Namrata ma'am.
Congratulations to YOSI, for doing this. Good.
I have one last question. So can Dr. Aditya suggest some top institutes to get into the Konya Fellowship for a young ophthalmologist?
Actually, yeah, fortunately in India, we have a lot of good centers for learning cornea. So the choice would be determined by like maybe proximity to your residence or for whatever reasons. Maybe it's family or you don't want to stay far away. So you can definitely look around. Both the AIOS website and the YOSI Fellowship Help Desk have enough information on the different institutes which offer fellowship programs, including the details how to apply, what is the stipend. But rather than naming any institute, the more important thing is what are you looking for from your fellowship? Because like Sagnik was saying, they had cataract exposure in their fellowship. I didn't. So, but this was made clear at the outset. So it is very useful to be frank when you're speaking with the fellowship director or the in charge of that institute. That what can I be expected to receive in the form of training, hands-on training in this fellowship, so that there is no conflict of interest or anything mishaps later on. So be sure in what you are getting into and what you expect, and whether it matches your life goals, that whether you want to focus on refractive, whether you want to focus purely on cornea, or you want a mixture of both cornea and cataract as well. But be sure whether before getting into any program that and apart from the online resources which I've mentioned, the other resources are your colleagues and your seniors who are already doing or completed their fellowships from the institute you are planning to join. So the best feedback is always from them regarding the academics, the faculty, the hands-on training. So it's always useful to communicate. Nowadays in this era of electronic communication, it's not so difficult. So you just a phone call or a WhatsApp message away, and you can get all the information before you take the plunge.
Thank you, Dr. Aditya. So I'll be sharing the screen. Yeah, so I would like to end this session. So I just want to tell you that we have a fellowship help desk, AIOS-YOSI help desk. So you can always put on your queries, and we are happy to help you anytime. So I would like to end this session. Thank you all panelists for your participation. So over to Dr. Divakant sir.
Thank you so much, Aparna. And yes, as Dr. Aditya rightly pointed out, we have this YOSI Fellowship Help Desk, and the email address was there, and you can mail us any of your queries, and all of us who are present here will be very happy to help you through email or a phone call or whichever way convenient. So now next, and thank you all the panelists for great inputs. Now we move on to the next session. That's about cataract training. Now that is probably the most sought after if we look at it. And Dr. Aditi Tripathi will be taking care of the session. She is a cataract and refractive surgeon in Baroda, and she did her short-term cataract training at Shankar Netralaya and a refractive fellowship under Dr. Rupal Shah. Over to you, Dr. Aditi.
Very good morning to all of you. Am I audible? Okay. Very good morning to all of you. Thank you, Dr. Devakant, for this opportunity. And I would also like to thank AIOS and YOSI for giving me this opportunity to contribute and moderate this session. As we already discussed, cataract is the most sought after training program in the country. Also because we have a lot of options available when it comes to cataract, may it be short-term, long-term, cataract refractive and comprehensive fellowships. Why the need for cataract training? As we all know that residency is a very bad destination for doing cataract surgery. We always have this ideology, as we're not given enough number of surgeries during residency, that bahar jaake kar lenge, kind of a thing. Also, on a very serious note, the art of tissue handling that a cataract surgery teaches you is the most comprehensive form of teaching in ophthalmology. Before going for any subspecialty fellowship or as a comprehensive ophthalmologist, cataract training becomes very, very necessary. As a young resident, when he finishes his residency, he's in a dilemma so as to go for a short-term fellowship, long-term fellowship. Kidhar jaun? How will I process all this information? Today we have 3 panelists with us, very dynamic cataract surgeons who will help us and guide us through this dilemma. We have with us Dr. Saurabh Patwardhan, who is the director of Nandadeep Eye Hospital in Sangli, Kolhapur, Maharashtra. He's also the head of and HIPFACO training head at the hospital. He has close to 30,000 surgeries in his kitty. Also, we have Dr. Abhinav Biala, who is a consultant at the LV Prasad cataract and refractive surgery consultant at LV Prasad Hyderabad campus. After finishing his residency from Belgaum, he finished his comprehensive ophthalmology training at LV Prasad Eye Institute. Thirdly, we have Dr. Sneha Batra, who is currently working at Trinetralaya, Kolkata and BBI Hospital, Kolkata. She finished her cataract, refractive and medical retina training under Dr. Partha Biswas at BBI Hospital, Kolkata. I would like to welcome all the panelists and we can start our session. Can we have Dr. Saurabh Patwardhan? Is he here?
He's there. He's
yeah,
already...
hi, I'm there. Yeah.
Yes. Very good morning, sir. When once a youngster is out of his residency, he's always in a dilemma as to go for a short-term fellowship or to go for a long-term fellowship. Sir, which one is for whom? Can you throw some light on this, sir?
Yeah, thank you so much. And first of all, congratulations to YOSI, Dr. Divakant. I think all your team, amazing way you do so many meetings, and these are really helpful for youngsters. And now back to the question. I think this is very commonly asked question. In fact, as a fellowship program director, I get many applications. First applied for short term, then the same fellow applies for long term. So definitely there is some amount of confusion, like what to go for. So I think from a youngster's point of view, as you rightly said, Aditi, unfortunately in India, not many institutes really give good training during their MS program or even DNB program. Of course, barring a few which are really good. And not just surgical training. I think another thing which I think previously also is spoken of is the academic training. That means how you can diagnose things, how you can manage the OPD. So that is also very essential. And these both the things are very important. So during your residency, if you are poor on both sides, like in surgical as well as in academics, I think best way to go for is a long-term fellowship program or a cataract fellowship program. And I would recommend even before any specialty training program, you go for a long-term FECO or the cataract fellowship program, because it's, as rightly said, it gives you immense knowledge about tissue handling, which helps in all other specialties as well. Another important thing, as I mentioned, is that academics. If you are not good in academics during your residency, because you need a lot of time on think about various clinical conditions and come to a diagnosis. If you are not good at that at the end of your residency, if you go for a short-term training, you might become better with surgical, but your academics or your diagnostic skills suffer. And then in private practice, you are going to suffer, because then you never become a good ophthalmologist. You always lack on certain clinical skills. So for those also, you need years to be put into. So that for that also, I think long-term fellowship program is necessary. So in other words, I would suggest that don't consider long-term fellowship as a fellowship, but as an extension of your residency program, if your residency program was lacking with in surgical as well as clinical skill you didn't have training of that. A short-term training program is really useful for those who are already doing some surgeries, who are into practice a bit. They have done few under their belt, but want to fine tune their surgical skills, or want to be supervised and get some additional inputs. For them, it's very useful. And another important thing is that after short-term training, you should have opportunity to start the surgeries also immediately. For example, you are into a hospital where you are going to get opportunities to do at least 5 to 10 surgeries in a month. Then the short-term training is useful. Otherwise, what happens? Many youngsters undergo short-term training and then they join a job or they join a private practice where for months they will not get any hands-on. And then after a year, again, they are into the same trap that they don't have the confidence to go ahead with the surgery. So think about short-term training. If you already have few surgeries under your belt and you just want, a mentor to just guide you and fine tune that, it is like a step up procedure. So if there are 3-4 steps up, short term will just get you one step ahead. But if you are go for a long term, you are going 2-3 steps ahead. Okay, that is how it has to be looked into. Short term is another useful thing after doing another specialty training. I think that is also useful because if you have done already a retina fellowship, you are good with your surgical skills, with the tissue handling and everything. Then learning cataract surgery is easier as compared to those who have not done a fellowship. For them also, I think short term training works well because they don't have to spend that much of time again. Okay, so I think these two things are very important. I think our medical career point of view, I think put whatever amount of time you want in training before you start your private practice. Because once you start private practice, you are stuck. So your surgical skills or even academic skills grow at a very slow pace once you are in private. Okay. So I think whatever you want to spend 2 years, 3 years, 4 years, of course, there are a lot of people with financial constraints, which we agree. But still, I think put more years in training before you start your private practice. Another trap many times we get into many practice, I have seen that because of financial constraint, they join a job, and in job many times we do not get that much of surgical hands-on if you are not good at initially. That means if you are already trained, then you get surgeries. But if you are not good at, then nobody is going to take extra efforts to train you because it is a private job. They want you to serve the patients that they are which are coming to the. So before joining any job, I think get through your training completely and then join a job or join private practice. I think that will be my message to all the youngsters.
Sir, also, do you think that employment opportunities as a cataract or refractive surgeon after a long-term fellowship are better compared to a short-term fellowship?
Yeah, definitely. Because long term, apart from, as I said, apart from the academics, which are additional, in long term, you get to know how to manage complication in a much better manner. Not just because you are allowed or you get the opportunity to manage it yourself, because over a period of time, you also see your mentors or your senior surgeons manage it. So you are in a better place. You can manage your complications well. And if you can manage your complications well, then you yourself are a confident surgeon. So even in job, I think that confidence shows. If you're not good in managing your complications, when you go for a job interview, apply for a job, first thing that will be asked is how confident you are in your surgery. And if you say that I can do this, but I cannot manage these complicated cases, then of course you may not get the priority for the job interview.
So what is your eligibility criteria if somebody wants to apply for a long-term fellowship? Because now everybody has some sort of process for a long-term fellowship, either through an interview or through a MCQ exam. Because now cataract and refractive is a subspecialty, they consider it as a subspecialty. So what is your eligibility criteria if somebody wants to join your institute?
Yeah, so actually because of the COVID, there was a lot of issue. I think most suffered are the youngsters who were in training because there were a lot of centers where surgery training could not be given. So there are a lot of applications. I think every institute will have its own process of selecting from the applicants. I do not have any specific process. So whoever is ready to join and has eligible degrees, so we generally take either diploma or degree holders, preferably, and we just give it to only allopathic practitioners, not to any non-allopathic practitioners. So those are my criteria. But most important criteria is eagerness to learn and to understand that every fellowship program is a customized program. So though we give a tenure, say 1 year, 1.5 years to a particular surgeon, but every surgeon has a different learning curve. So if we hasten or if we try to to hurry up into the learning curve, many times they get into more problems. So for every surgeon, it is important to understand that they have to learn with their own pace over a period of years. And uh, I think rightly said, cataract should be considered as a specialty and not just as a general category, because nowadays with the patients also demand very precise surgery, very quick recovery. So I think what should be done by the fellows is not to be shy of taking a long-term fellowship over a period of years. I think comprehensive fellowship or 2 to 3 years is a better idea. I think Dr. Abhinav has experienced that, he can tell better, because more years you put into, better you get. In fact, by the time you finish your long-term fellowship, that is the time where in fact you should extend and do more cases, because that is the time when you can fine tune very quickly.
Right. Thank you so much, sir. Can we have Dr. Abhinav? Thank you, sir.
Hi, good afternoon. I'm here.
Hi, good afternoon. Sir, we would like to know your experience regarding the comprehensive fellowship after which you finished your cataract and refractive fellowship at LBPI.
Right. So thanks, Dr. Tripathi. And at the outset, I would like to thank Dr. Mishra and Team YOSI for giving me this opportunity to be here at this platform. So coming directly to the question, I think quite a few of the points have been covered by Dr. Patwardhan himself, that considering the option of a comprehensive fellowship over a subspecialty fellowship, or say a short-term fellowship over a long-term fellowship, is much more beneficial. And that's the same that I experienced during my fellowship. So I joined as a comprehensive, like a fellowship in comprehensive ophthalmology, which I pursued for 2 years. So which consists of 1 year of comprehensive rotation in all the subspecialties, the 5 subspecialties that we have at LBPI, and followed by in the second year, it's a 1 year rotation in one of the secondary centers. So that I feel is one of the best part of the fellowship, because that gives you quite a lot of freedom to act as a lead ophthalmologist in one of the centers. So there, the starting from the housekeeping worker all the way up till the administrator of this of the particular center, you work as a team, as a single unit, in order to make that center run, make the center profitable, try to give the best to the patients that are there. And more importantly, since you are alone at that center, it gives you that independence and also the confidence of managing all the types of whatever type of cases come. It's not that, okay, this case has come, so now this is not, I mean, obviously there is an option to refer that to the higher center, but then like suppose if you are under supervision, you would think that, okay, yes, maybe I could give this case to my senior and observe him do it. But yes, once you have that kind of confidence that, okay, yes, I'm alone at this center and whatever happens, I only have to manage the complication. So that probably was one of the USPs of this fellowship, which I would say, because I don't think any other fellowship gives that experience. That 1 year of the experience at the secondary center probably was quite good and quite a life-changing event for me per se. And then after these 2 years, I went on and I did my cataract and refractive surgery fellowship at the Hyderabad campus, where again, so the basic cataracts I had learned during the first 2 years. And then I went on to polish my skills on cataract surgery, how to give the best visual outcome based on placing your incisions on the steep axis, or say wherever, say 45. So now the thing is that you, in the cataract surgery fellowship,
people come, it's a good idea to come with little bit of experience in cataract surgery and not per se to learn cataract surgery. But then, just contrary to that, we have a new training program where all the fellowships have been combined with a comprehensive fellowship, and which gives an opportunity for even a very novice surgeon to come and take benefit of this fellowship, because all the fellowships have this 1 year of secondary center training along with 9 months of initial comprehensive ophthalmology posting, followed by the final year with 15 months of subspecialty posting in whatever fellowship they've opted for. So probably, I think it's a good idea to go for a comprehensive, as Dr. Patwardhan had mentioned previously. And most importantly, I would like to stress upon that I think cataract surgery is one surgery which every ophthalmology person needs to know. And I think it's been mentioned in this forum, I think a few minutes back, that cataract is the bread and butter of ophthalmologists. So I think that point needs to be taken into consideration. And yes, as again it was pointed out, that it improves the tissue handling capabilities before going on for a further subspecialty fellowship.
Thank you, sir. Sir, as a FACO trainer yourself, since you are the head of one of the head of the training at the Hyderabad campus, do you see a difference in any methodology of training after you finished your training at the Hyderabad campus?
Yes. So what used to happen previously was that the trainees, say they used to be posted for a like normally we have a FACO and SICS training for a month. So then what used to happen was people who were good, they used to continue for a month in the same way as the people who were not that good, like the fellows or the trainees who were not that good. So the changes what we as a team who look after the cataract training at CAR campus Hyderabad, what we did was we started fast tracking people. So we thought that, okay, the number of cases that we have are limited. The number of time that we have is 1 month. All those are limited resources. But then we said that, okay, now say a trainee X is doing good SICS. So we can quickly, rather than making him go through 1 month of SICS training, we like promoted him to the FACO training, maybe say after 2 weeks of surgery.
Right.
So now we had that 2-week slot available for us in the SICS training session, where we can take another trainee who's about to start training. And this way we try to better utilize the limited resources that we have, especially in the pandemic time, because again, training was hit at all the fellowship programs. So, but we had the number of trainees that we have were the same. I mean, that we didn't decrease that. So we had to come up with a way to counteract this adverse time, and to maintain our cataract surgery training at the possibly, if possible, at the same level as we had in the pre-COVID times. So that was one thing. And second, like people who were doing good phaco emulsification, again we were fast tracking them we have a concept of a fellow operating room in our hospital, where we have 1 hour dedicated to the fellows where they operate independently. And then on the other hand, people who are not doing that great, we extended their 1 month to say 45 days or even up to 2 months, because we had these extra slots by fast tracking the other people, so as to ensure that they have a much more better experience at the areas, especially the problematic areas where they think they are getting stuck in surgery, and more hand holding for them as compared to people who are good at surgeries, rather than sticking to the conventional plan where everyone goes through one month of training. So that's probably one change that we incorporated.
Okay, thank you, sir. And do you still have a bond at LVPI? After 3 months, it was questionable. Like
no. So right now, since all the fellowships are long-term fellowships, we don't have any short-term. All fellowships are for 3 years, so we don't have any bond which is there.
Okay, sir. Thank you so much. Dr. Sneha. Thank you, sir. Dr. Sneha, what is your experience? Sneha, Dr. Sneha
Yes.
here? Yes.
Yes, thank you.
Yes. What is your experience or training of fellowship at BBI Institute? regarding since it is a private hospital compared to an institution. Can you throw some light on that, sir, ma'am?
Yes, thank you so much, Aditi. First of all, I'd like to thank Dr. Devakant for giving me this opportunity. And this is a topic which is very close to my heart because just before I answer your question, Aditi, there's actually a huge gap which exists between the residents who are doing their MS or diploma, and we've already all talked about it. And I really hope that in 5 to 10 years' time, we do not have this gap and we can do something to bridge that gap. Because when I joined my fellowship from the part of the world that I come in, most of the students are pass outs of RIO Kolkata, where they get as many as 50 to 100 phaco-emulsifications during their residency. So they are able to choose a subspecialty directly. But from the place that I came in, I had an MS degree in my hand and I had not even done a single SICS. And that's not because I was a very bad student or something like that. But this is something that happens to a lot of people. And at that point, you're thinking that before you go in for a subspecialty fellowship, as everyone says that cataract surgery is the bread and butter, it's the orientation to the microscope or just the fact that you've done the basic surgeries before you move on to the next step. So looking back retrospectively, probably it was not such a bad thing because once you go in for a cataract fellowship, you get to learn cataract surgery from the best. So there are actually a lot of people who are teaching cataract surgeries now, not just SICS, but phaco-emulsification as well. And it hardly takes 1.5 years to catch up with those people who have already done a number of surgeries in their residency as well. Now, coming to your question, why I chose a private institute. So again, this is a completely something which is a choice for different people. But probably the most important thing in selecting your institute or where you're going to do your fellowship is the mentor that you're going to get, because that is the single most important person who is going to teach you the surgery. I was very lucky to get Dr. Partha Viswas, and that's why I did not think of a second option of going to another institute. And even though ours is a private institute, we do have a charity wing as well, where we get these patients every week to, and that is solely for the fellows to perform surgeries. And not just my mentor, but my seniors who had completed their fellowship or were in their second year of fellowship, they were there to, guide and be there scrubbed in for each and every surgery that we were performing every week and tell us exactly where we were going wrong. So we talk a lot about the number of surgeries or the hands-on that you get, whether it's 800 or 1000 or 2000, but really it's not about the quantity of the surgeries, but the quality. And if you're getting to do surgeries every week with someone sitting scrubbed in beside you, seeing through the observer's microscope, and not just coming in after you've created a complication to manage the case, but sitting there beside you and telling you before the complication has occurred that, this is where you're holding the instrument wrong, or maybe you can choose a different instrument or do it another way, try it this way. So that is what gives you a lot of confidence, even if the number of surgeries is not so much. The second thing that I think my mentors have always told me is to record your surgeries. That is a very, very important thing. So that it's just like when a batsman is getting out, it's when you see your replays, you understand how you got out. So you can go back home or you can discuss it with your mentor just after your fellowship, just after your surgery has completed, and learn through those small, simple steps. And that's how you learn and grow, basically.
Can you also suggest various fellowships in the East, because that are still currently on during the pandemic time that people can go through?
Yes, so there are actually a good number of institutes which are offering fellowships across all subspecialties, not just cataract in the East now. Earlier, it used to be that everyone had to go down south, but the trend is really changing now. From Kolkata, we have a good number of institutes. There's BBI Foundation, from which I did my fellowship. Then there's Shankar Nethralaya, there's Disha Eye Hospitals, there's Sushrut, there's Priyambada Birla Arvind Eye Hospital. And even an SR-ship from RIO is actually not a very bad option. And then, of course, we have some legendary institutes like Sri Shankadev Nethralaya from Guwahati and LVPI Bhubaneswar in Odisha. So there's quite a wide variety of institutes which are there for people to choose from.
Thank you so much for your insight. Over to Dr. Devakant. Thank you, ma'am, for your insight. Over to Dr. Devakant.
Thank you so much, Aditi, and thank you to all the panelists for a wonderful discussion. And let's move on to the next session. That's the oculoplasty session. And I would like to invite Dr. Ankita Aishwarya, who is oculoplasty fellow with Dr. Santosh Uravar at CFS Hyderabad. And has also received the best paper in AO 2020. Over to you, Ankita. Please unmute yourself.
Yeah. Am I audible also?
Yeah, please.
Okay. So thank you so much, sir. A very good afternoon, everyone. Heading towards oculoplasty training roundtable. Our first panelist is Dr. Anuradha Iyer, who did her fellowship in oculoplasty from L.V. Prasad, Hyderabad. She is currently practicing oculoplasty and aesthetics at Thane. Welcome, ma'am. Our second panelist is Dr. Saurav Kamal, who did his oculoplasty fellowship from L.V. Prasad and is currently practicing the same in Faridabad. Welcome, sir. Our third panelist is Dr. Pallavi Singh, who did her oculoplasty, oncology, and squint training from RP Center AIMS. She's currently practicing in Ahmedabad. Welcome, ma'am. So let's begin the session. So my first question is to Dr. Anuradha. Can you please tell why you choose oculoplasty?
Hi, Ankita. Devakant, thank you so much for having me on board here. Am I audible?
Yes, ma'am.
Yes. So why oculoplasty is an important question. I think for choosing oculoplasty, you need to have an inherent passion for plastic surgery. I wanted to be a neurosurgeon or a plastic surgeon as a child. So after becoming an ophthalmologist, I did my DNB in Arvind Eye Hospital with a great exposure to cataract surgery. But it felt very incomplete. Getting out of the OT with zero blood on your gloves felt to me as it was inadequate for me. So that's the reason I took up oculoplasty, and I was quite lucky to be chosen in LVP. But of course, after entering LVP, I realized that oculoplasty is not just one thing. You have trauma, you have ocular oncology, aesthetics, you have reconstructive surgery, you have opportunities to collaborate with maxillofacial surgeons, neurosurgeons, plastic surgeons. So the scope of the field was enormous. But of course, the amount of learning that you have to do is equally enormous and gigantic, I would say, in those 2 years. So oculoplasty is more of a calling, is what I say. Otherwise, you're not going to be very happy in this field. Yes, Ankita, I hope that answers your question.
Yes, ma'am. So Dr. Pallavi, what's your view?
I think all oculoplastic surgeons will agree with what Dr. Anuradha said. I mean, at every point in our lives, we've wanted to either be plastic surgeons or, have some sort of exposure to general surgery. I completely identify with what she said. The feeling of having blood on your gloves when you walk out of the OT, that's just something I think all oculoplastic surgeons crave. So even as an MBBS student, I was interested in plastic surgery, and this was probably the easiest and a very simple way to, sort of get in touch with what you've liked as a, younger medical student. One of the other reasons why I got into oculoplasty, which might sound silly at this point, is so at AIMS, we rotate through all of these units, which are subspecialty units. And so the oculoplasty unit at AIMS is just fantastic. I mean, I had the most fun there. So as a resident, I just enjoyed it the most. So it was sort of an obvious choice for me. And the other things, as Dr. Iyer mentioned already, it's a niche branch. So you have to like it, because that's what everyone tells you when you're trying to go for a fellowship in oculoplastics, that there are not as many patients, and it's going to be a referral branch, so it's very specific. But if you like it and if you make a niche for yourself and you do good work, I think it's an excellent choice.
Okay. Dr. Saurav, your view?
Yeah, thank you, Ankita, and thank you, AIOS and YOSI, for inviting me. And it's a wonderful session. So I would like to answer this question as a why I choose oculoplasty, not that way, why one should choose oculoplasty. So as already said by Anuradha, I think it has no boundaries, it is an endless, and it has a very overlapping with other specialties. But we should know that we should now, take back from that super specialty of medicine, which have been practicing that maybe 2 decades or a decade back. Like why a neurosurgeon, doing a thyroid decompression, a general plastic surgeon doing an blepharoplasty, ptosis, or whatever eyelid reconstruction, socket, ENT person doing DCR. So I think we should take back from that other specialties what we have left out, and we should have more hands and as an oculoplastic surgeon all over India. And although also the awareness about this specialty should be there among our, I think, in the ophthalmology colleagues also, and with the other specialty.
Okay, so if I have to conclude, it's the
add
passion.
one thing, Ankita. Yeah,
Yes, ma'am.
just to add to what Dr. Saurabh was saying, I was just looking up the data on the number of aesthetic surgeries that are performed. And in India, and this is data from 2019, this is before the pandemic, just the face and the head and neck, the face and head procedures that were performed, aesthetic procedures, were close to 1,64,000. And if you're just talking about eye and brow procedures, they were around 42,000, which is a huge number. And this is pre-pandemic. And ever since the pandemic has started, this is like the most important region of your face. Everybody is just going to be seeing your eyes.
Obviously.
Like Dr. Saurabh said, we need to take back. We need to take back our specialty from the plastic surgeons, from the ENT surgeons, and and even base of, all of these orbital surgeries that a lot of neurosurgeons are doing. So that makes complete sense.
Yeah, totally agree. And so if you have the passion, oculoplasty is there. So moving on to the next one, Dr. Pallavi, can you please highlight, okay, what are the different training options in India, or the opportunities which you feel that it's available in India for the oculoplastic persons?
So largely there are basically two types of training programs that are available. And because most of us, pass out from medical colleges, so there's the option of senior residency, which is what I did. And and Dr. Saurabh, I think, would be also able to elaborate because he's done both his senior residency and a fellowship. So as a senior resident, I think one of the advantages is that you get to be in touch with other specialties as well. You get to see general patients as well. So your brain is sort of open because you don't develop that tunnel vision, because otherwise what happens is that if you're just seeing one type of cases, just a single type of case every day, day in and day out, you sort of just tend to see only oculoplastic findings. So I think that's important. And if you're doing a senior residency, it's usually in like government colleges. So the ability to have, to be able to liaise with other departments such as neurosurgery and maxillofacial surgeons and ENT. So that is a sort of advantage when you're doing your senior residency. Having said that, fellowships provide excellent training because you're concentrating completely on this one branch. You have directed classes at the anatomy, and you get specific cases. So I guess in terms of just enriching your knowledge when it comes to that branch, fellowships provide a great exposure. And it is this thing, we all know that there are great fellowships at LVPI, there's CFS, and there's Shankar Nethralaya, Arvind, so lots of other, lots of great private institutions that provide these fellowships. And of course, for senior residency, we have all of our government institutions such as RP Center at AIMS, there's PGI, there's GNEC. This is just in the north, and there's like a huge number of institutions in the south. So yeah.
Yeah. So Dr. Anuradha, what's your view on this?
Yes, Ankita, I quite like the points that Dr. Pallavi has mentioned. I would like to add to it to say that if you are really looking for oculoplasty fellowship, just looking at the list on paper or on a computer screen is not enough. In your post-graduation, you would have a decent knowledge of, say, glaucoma or cornea or even retina theoretically. But oculoplasty, we completely ignore oncology. We hardly know anything except for a few pages of retinoblastoma. So oculoplasty, I would say, as a matter of knowledge, when it comes to clinical as well as surgical, the amount of information you need to amass in your fellowship is really vast. And it's important that if you're spending 2 or 3 years in an institute in a fellowship, you don't want to leave that institute and still having to knock on many doors, asking people, teach me, when you're entering out. So it's important that you take your time, do your research. I would say speak to the ex-fellows, but it is also important to go to that institute, visit that place, see the department, talk to the fellows in training, because fellowship programs keep changing their pattern. And also to get a feel of whether you want to be in that place, because you have to understand that those 2 years are going to determine how you are going to be for the next 30 or 40 years. So I would say even if it takes time, make sure that you do a fellowship in a place that is worth your time there. And somebody had mentioned that geographically, if you have any issue, if the place is very far off, do not choose it. I would say do not look at geography. You're talking of 2 years of intense focused training versus decades of practice. So it is worth being away from family, personally is what I feel, worth being away from your comfort zone or your city in order to get trained well so that you can come out confidently and start off your practice in any which way that you want. So visit the place, talk to ex-fellows, talk to current fellows, and then choose. Yeah, Ankita.
Dr. Saurabh, your views, please.
Yeah, I would just like to add one thing that whenever you are looking for any fellowship long term, I think for plastic it should be because it is a surgical branch, so one should have a long term fellowship only because it will help you in learning the more varieties of surgery and also following them up. What I was talking about is when you are choosing any fellowship, it's okay about the institute and surgical volume and what all you will learn there. But I think also important is you should, I think, choose your mentor or whoever so person is, you will get trained under. And also it should not be about, I think, a single person. It should be a team. If there is a consultants, there are 3 or 4 consultants, 2 or 3 consultants there at that particular fellowship program who will train you. I think that is more important because then you will have different views of doing the same surgery from all the 3 consultants, and you should have the inclination of the specialty, I think, from the residency itself. Then you will have more passion about the learning of that any specialty surgery.
Very nice point actually brought up by all the panelists, and also as Dr. Namrata ma'am also said that before going for ahead, do choose your mentor, do go visit your institute at least some time prior to know what all the things which is going on. Okay, so after moving from this, the next question is how to approach an oculoplasty fellowship, like how it should be done. Dr. Anuradha, your view.
The fellowship program, definitely wherever you choose, will be structured. Now it is up to you to make the most of it. So quite often we do see students fighting behind these many cases I have seen, these many numbers of surgeries I have done. I would say that the amount of introspection that you put into every case you see and every surgery step that you do, that is what makes a difference, and how much you learn from it. Say you have sutured an eyelid wound in a certain way, and how often do you keep a follow-up of that patient? Like Dr. Saurabh had mentioned, follow-up is very important to see the degree of scarring it creates. So in my fellowship days, I used to have a small notebook wherein I would constantly make notes of important or even at times very simple points. Because when you follow a mentor, you actually get more information than you would in any book or journal. There is personal experience of say 10, 15 years that I'll give you a simple example. Dr. Milind Naik, my chief mentor, had given me a simple tip that you always overcorrect the medial doses because the levator fibers are less in that area. This is something I have never read, and I have followed this in every case of mine, and it has worked wonderfully. So those pointers, make a note of it. Always play a surgery in your head before you go to operate, and even after you finish operation, keep on playing that in your head for the next few days, wondering how you could have done that particular step well. Could you have used another instrument there? And in fact, even when you're observing somebody else operating, try to anticipate the next step that person would do. And that will give you an idea of what to do or what not to do or how it could be done better. So this particular notebook, I'm 4-5 years into private practice, and I still have those notebooks right here in my clinical room in my first drawer. So I think observing, analyzing, and introspecting will ensure that you bring out the best in your fellowship in the short duration that is, and prepare you for the world that is out there. Thank you, Ankita.
Yes, ma'am. Very nicely pointed out. Dr. Pallavi, do you have any other view in that?
Yeah, just to add to what Dr. Anuradha was saying, and I mean, because these days technology is, so advanced, so we can supplement those notebooks with pictures. And this is especially very, very important in oculoplastics because everything you do is visible, right? right in front of you. You don't need fundus cameras. You can do it with your regular phone. So I think one of the things that all residents all fellowship aspirants should know, that using your phone in the most optimal manner is one of the easiest tools to have a record of what you're doing. Take pictures of your own cases, take pictures of cases of your mentors, so you see that you have a standard to sort of follow. And don't be lazy about transferring those pictures. I say that because I'm very lazy, and they sort of just pile up in your phone, and then you don't know what to do with like 1,000 pictures. So create folders and have records, and that is just the easiest way to sort of be able to evaluate your work. Secondly, in terms of academics, I think especially in oculoplastics, two things that are very important. One is to have a good knowledge of the anatomy of the face, the orbit, because you're going to be operating, you're going to be dealing with blood vessels, and you don't want to encounter a bleeder on table that you have no idea about. So it's very important to have a good knowledge of the anatomy, spend time on that, spend time on reading about anatomy. Secondly, especially as an oculoplastic person, because we sort of serve as the liaison between ophthalmology and general surgery, know more about general medical conditions and surgical conditions, because ours is the only specialty where the patient might die. We deal with ocular cancers, we deal with mucormycosis, especially in the wake of COVID-19. We've seen so many cases of mucormycosis. A lot of these patients have a very high rate of mortality. So you need to know what these conditions are. You need to broadly be able to manage them in any case where you have a patient that collapses in your hospital or in your clinic. So just a couple of additional things.
Yeah, very nicely said. So Saurav sir, we would like to know, how is your life as an oculoplastic surgeon?
Yeah, I think it has given me, many exciting and rare surgeries to do, both at my clinic, at other places. I think whenever I visit a place, or even if I do a surgery at my center, what feeling it does give me is that I'll tell the entire staff that देख लो ये एक बार देख रहे हो, शायद कभी देखने के बाद दोबारा ना मिले. So that is I think the variety of the surgery and the rarity of that particular case, that I'll tell my team, that this is maybe, I'll be dealing with this case maybe 10 to 20 years later. So because it overlaps so many other specialties around the face, head and neck area, I think that is the thing that it has provided me. And even like after 6 years of my fellowship from LVPI and 8 years of senior residency from GNEC, I think what it has helped me in getting is a peer recognition, especially the locally, because I'm in a private practice, and that helps in referring that case of an oculoplasty. It's all about like how it's not how good you are surgical hand, but also how you project yourself. I think afterwards, for any fellowship, for any specialty, I think that is very important. If you are in your own practice, or if you have if you are visiting at any place. So I had enjoyed a lot. I think I made a right decision of choosing the oculoplasty, and I think it's very good since then.
Okay, sir, thank you. So if I have to conclude from all, oculoplasty is an art, and it's a challenging branch. It is evolving, and it has lot of opportunities in it. So if you have the passion, oculoplasty is there for you. Thank you all the panelists. Over to you, Divakant sir.
Thank you.
Thank you.
Thank you so much, Ankita, and all the panelists for such wonderful inputs. Next, we have the glaucoma session, and we have Dr. Mainak Bhattacharya. He is a glaucoma specialist at IQ Super Specialty Eye Hospital, Gurgaon. Over to you.
Good afternoon, everyone, and thank you, YOSI and AIOS, for giving me this opportunity, and congratulations, Apurva and Divakant, for putting across such a mammoth program in such a short span of time with so many speakers. Okay, so I'd like to start the session by inviting my panelists. We have with us Dr. Tamunash. Dr. Tamunash completed his long-term fellowship in glaucoma from Shankar Nethralaya, Chennai, and is currently working as an associate consultant at Shankar Nethralaya, Kolkata. Next, we have Dr. Sneha Sharma, who did her long-term fellowship from Arvind Eye Hospital, Madurai, and there worked as a consultant at Vasan Eye Care and Center for Sight. And she is the founder director of Megavision Eye Care in Jaipur. And we also have with us Dr. Ashwini, who completed his MD and senior residency from the prestigious RP Center last year. And he is currently working as a consultant at AIOS-YOSI Eye Hospital, Behramore in Orissa. So just like the other subspecialties, we would like to begin by asking each of our panelists individually as to what made you choose glaucoma as a subspecialty over the rest of the subspecialties. So I would like to invite Dr. Tamunash first.
Am I audible?
Yeah, you're audible. Go ahead, please, Dr. Tamunash.
Yeah, thank you, Yosi, for inviting me in this session, and Dr. Divakant sir for making me a part. There are many causes why I chose glaucoma. During my residency, I used to see the disc in 90D. Like in the slit lamp, I had a passion of seeing that with 90D or 78D, and the varied appearance that had made me so interested in this optic disc evaluation, what is glaucoma, what is non-glaucomatous disc. So from that only, I had an interest. I used to sneak to the rooms in AIOS where the glaucoma sessions were going on. I listened with awe to the esteemed panel, the solvers, whoever were presenting. There was so much of knowledge there, and I realized how misdiagnosed, dearth of specialists in glaucoma practice is there in the current scenario in India, and how misdiagnoses are happening. And from that only, I chose glaucoma basically, and from that day onwards, I never regretted a single day that I have chosen glaucoma. I had the best opportunity to get the fellowship under Dr. Linga Vijaya ma'am, Dr. B. Shanta ma'am, Dr. Ronnie George. There's so much things to learn from glaucoma, from them in glaucoma, that is not done in span of residency in that 3 years with other subspecialties. So that's why I chose glaucoma. That disc and IOP, the misdiagnosis of glaucomas, that has given rise a interest in me to choose the glaucoma specialty.
Right.
That's it.
Okay, thank you. Dr. Ashwini, what's your take on that? Dr. Ashwini, are you there? I think there's some problem with his connection.
Hello,
Dr.
hello.
Yeah,
Hello.
yeah,
Yes,
yeah.
yes,
Yeah,
yes,
please
sir.
go ahead, Dr. Ashwini.
I just missed some because some internet issue. I just could not able to join for initial some part.
Okay. We
Can
just
you tell
wanted
me?
to know. Yeah, we just wanted to know that why you chose glaucoma as a subspecialty. What's your take on this?
To be honest, as my specialty includes glaucoma along with strabismus and neuro-ophthalmology, as I am from RP Center.
Right.
There was I have to join one unit where my guide were Professor Amanjit Siota ma'am and Professor Tanuj Dada and Professor Binay Gupta are my mentors for glaucoma. Simultaneously, there was Professor Rohit Saxena for strabismus and neuro-ophthalmology. As such, glaucoma, because what I saw and what my seniors tell, what everybody says, every ophthalmologist treat glaucoma patients and they refer to glaucoma specialist when at the end stage. So, because what is the proper, there are so much to learn, so many simple things to learn, how to take in history to extract some simple history of using steroids. Almost every patient, almost most of the patient use some sort of steroid, but extracting the data, how to take this steroid history or such a prevalent disease. Now I am at Barampur, Odisha. I just met 2 days before one of the biggest practitioner in Barampur, ophthalmologist, who is a 70-year. His son is has glaucoma, advanced glaucoma, and he was not advised properly to put medication. And he himself has advanced PSEG. As an ophthalmologist, he was practicing with BG OPD of 200 per day. And he has glaucoma advanced with left eye RAPD, and he has not done a single PI. Even after I counseled, sir, after 10 days also, he didn't turn up for PI. So, and that's what is needed. As Professor Ramanji Siota ma'am tells always, it is a preventable disease.
Right.
So if with proper awareness, proper teaching, especially when his patient is PSEG, where patient can go blind very fast. So that's why I chose glaucoma, and I always wondered ke glaucoma as such kuch hai nahi, simple surgery most of the people say, but it's not like that. To do a trab, well done trab who survives for patient, actually patient does never understands के what we are doing, because they think के 6 by vision improve अभी नहीं हुआ, क्या कर रहे हैं, अभी ड्रॉप हो गया, अभी बार बार बुला रहे हैं, अभी CD हो गया, but they don't realize to make the patient understand what you are going. For example, the patient comes to us with complaint of just for refraction or some foreign removal. We say you have advanced glaucoma, you have to put a medication every day, twice, 2 medication, 3 medication for lifelong with side effects of the medication, and we tell them so that you will not get blind after 20 years. So it is a very tough thing to convince a patient, okay, you have a glaucoma and start medication. It's a very tough thing. They'll think, okay, we'll not put medication once or twice, because we generally, if I open a artificial tear drop for myself, within 2 days I misplace it. But so the burden of putting medication to explain them, especially, is always necessary. Need a good hand to explain the patient, because most of practitioners, as of they will start on Combigan instead of starting the prostaglandin, 2 medication or 3 medication. So as such, as somebody says, okay, if patient have 14 IOP, they put 3 or 4 medications, IOP is 10. Then what is the need of glaucoma specialist? If not controlled, then do surgery. It does not go like that. So it's necessary. It's an excellent branch with so much innovations coming on this, especially implants, devices, IOP monitoring devices. So new discoveries are going on. So it is a very exciting branch also. Implants, hopefully in near future in India also, there will be some other sort of implants which are must be affording. So let's see what is the future holds for us.
Right. So the methodical and a meticulous approach is definitely lacking when it comes to glaucoma practice among the general practitioners, I would say. Dr. Sneha, any points you would like to add on this?
Yeah, thanks, Dr. Manak, and thank you, Dr. Devakant and Yosi, for the opportunity. So my reason for choosing glaucoma was that, it sounded like an enigma when I was doing residency. Half of the time it was misdiagnosed, half of the time it was overdiagnosed, and there was a apathy linked to it. There were a lot of glaucoma patients, so it's just next to cataract, the second leading cause of blindness is glaucoma. And despite that, most of the time, everyone used to leap seeing the cataract patients, yeah, you'll get to operate. And the glaucoma patients are like, इनका तो कुछ नहीं हो सकता. So, let's just put them on medicines and call them back. So probably batting for the underdog, I did develop a, connection to glaucoma. And yeah, I think as Dr. Basu mentioned, this is, the problem of people not getting adequate treatment for the lack of knowledge. And this is something which is extremely common. So that should not be happening. That was the reason I chose glaucoma, so that, I can do my share of decreasing it further.
Right. So also I would like to ask you, what is the, like during a fellowship training in glaucoma, what are like the must know areas, how to approach the long-term fellowship in glaucoma? So I would like to take like to hear from you as well and from Dr. Tamunash also. So what are the like must know areas, what we should be prepared for while choosing a long-term glaucoma fellowship?
So when you're going for a long-term glaucoma fellowship, you should know what you basically want to do later. So there are people who want to do a corporate practice. There are people who want to work in institutes for research, or just to be working in an institute, or there are people who want to do an independent practice. So it depends where you are headed, and you should choose your glaucoma fellowship accordingly. So most of the fellowships, as you know, are structured well to cover all the details. But I would say if you are trying to make a career in research, or you want to work in an institution, I would advise you to go for an institutional, a top institution like LVPI or Shankara or Arvind, which would give you a great headway into where you are headed. And if you are looking for an independent practice, or if you're going to work in a corporate and you just want, the fellowship as a stamp, which is also needed nowadays for that. So in that case, or if you're looking for an independent practice, you should probably look for those institutes where you can learn that, because the Apex institutes are going to be more research oriented. The knowledge would be everywhere, but the practical pearls are different at different places. So if you're planning to do an independent practice, or if you're planning to do corporate practice, it might make sense to do practice where you can learn, do the fellowship where you can learn all this as well.
Right. And Dr. Tamanash, any points you would like to add on this?
Like I have done from one of the premier institute of in India.
Right.
What I like understand that you have to follow like you can stand idle beside the consultant. You have to see whatever they are doing, how they are managing a case, how they are like seeing the disc, what are the methods, even from putting the paracane drop, like how they are doing it, everything. There is like so much to learn. And you have to be very meticulous. You have to build a personal rapport. You have to go and talk to them. You have to discuss the cases, and then only, because in the busy OPD, they will not be able to clear your doubts always. But you have to go and approach every time. And in for surgeries also, like you have to be a little bit of cataract surgery. You have to know a little bit of cataract surgery, because if you are most of the glaucoma surgery, we have to do it with the cataract surgery. And if you are learning cataract surgery in your fellowship days, that will be a problem. You're like the attention you are giving will be divided. So you have to learn a basic cataract surgery because before starting the glaucoma fellowship. So those things are there. You have to like your channelize your full attention to the glaucoma surgeries and the glaucoma diagnostics and like OPD. So there is so much things to learn in fellowship, and I would suggest everyone to do a fellowship. That like it makes a difference actually.
Okay. Also, like right now, we have a lot of debate on glaucoma, as in it's the same, like we have a long-term versus short-term fellowships in glaucoma and retina. So like, which is like, who are the candidates who are most suitable for the short-term and for the long-term fellowship? Like, what should you go for, like in your particular case, what are the things in mind that you should keep before choosing either a short-term or a long-term fellowship? I would like to know that from you.
So from short-term fellowship in glaucoma, like if you are well acquainted with diagnostics and like the disc evaluation, then you can go ahead and do a short-term fellowship. And you are well acquainted with the nuances of a cataract surgery in small pupil and everything, then you can do a small like short-term cataract surgery. Otherwise, if you have a knack for research, or like if you have a knack for publications, and like if you have a like you, then it's better to have a long-term fellowship. And no, short-term fellowship will not cover all those things, the research and all, and like everything of glaucoma, it will not cover in short-term fellowship. You have to do a long-term fellowship in that. Others may opine like I.
Okay, yeah, Dr. Sneha, any points you would like to add?
Yeah, I would like to add that you know, if you're again going to work as a individual practitioner and you need to do everything by yourself, you're not working in an institute, it's a great idea to go for a 3-month fellowship in glaucoma, learn the basics. So you know, at least you can stop the overdiagnosis, the overtreatment, the misdiagnosis, and the basic lasers, etc., can be done by you. So if you have an individual practice and you are just looking for, you know, adding to your glaucoma skills, a short-term fellowship makes sense. If you're working in an institute, it's not going to make a difference, because you'll always have a glaucoma consultant with you whom you can always refer the patient to. And that's how it's structured in all the hospitals. So yeah, if you're an individual practitioner, you're working in your own center and you have to take care of the glaucoma patients, and you're not very happy with your diagnostic skills currently, I would advise you to go for a short-term fellowship.
Okay. Dr. Ashwini, since you've just completed your senior residency and started your life as a career as a glaucoma surgeon outside, I would like to know that what is the scope for a glaucoma surgeon outside, and how much of work you get, what kind of work you get, and what are the areas where you can do, whether you want to do an institutional practice and whether you want to do a private practice. So what is the scope for a person who's freshly out of fellowship or senior residency? Dr. Ashwini, are you there? I think there's some problem with his connection. So can you, Dr. Sneha, can you elaborate on this?
So scope as a glaucoma surgeon? Is
right.
That
actually, you have had a practice of, you've worked as a glaucoma surgeon in the corporate sector also, and now you've started your own practice. So you can actually compare and give us an insight into both the worlds.
So most of the time, you're the first time glaucoma person, you advise a surgery, they usually go for a multitude of second opinions. and then they finally end up at either a corporate hospital or at a research center to get the surgeries done. As an individual practitioner, unless you are doing a pure glaucoma practice, I don't think you are going to do a large number of surgeries, glaucoma surgeries at least, or congenital glaucoma surgeries, or those kind of rare cases do end up at the institutions. And how rewarding it is definitely rewarding. People who are who are told no from everywhere, they come to you, and you can give them some ray of hope. It's definitely a rewarding thing. But yeah, the if you say the numbers, the quantities, it depends on where you are practicing.
Okay. And Dr. Tamanash, since you're already working with Shankar Netralaya only post completion of your fellowship, so at an institutional setup, what is the scope post your fellowship, and what is the work life of a glaucoma surgeon? So what's your take on this?
I work in Kolkata. I don't work in the main branch. I work here, and there are like huge patient load. Like we get referral from everywhere. There is huge patient load is there, and most of the cases I see are the referred cases. Like some surgery has gone wrong, the IUP is like sky high. They refer to us, or like some other cases, all complicated cases. But at the end of the day, when I am performing a successful surgery, it's gratifying. It's gratifying. Obviously, it's gratifying, and I can't comment on the private sector life, but in the institution, I am happy, like whatever I am practicing.
Any particular advices or tips you would like to give to the young ophthalmologists who are interested in starting a fellowship in glaucoma in the coming times?
Yeah, like follow everything, like follow from the small bits, whatever your consultant or your mentor is doing, and like ask your doubts. You have to open up, otherwise nobody, like in the busy OPD, nobody is going to come forward and teach you like, or spoon fed you. You have to ask your doubts, and you have to tell them your findings also. You can like go ahead and show them your findings. And in surgeries also, I told you before also, basic cataract surgery, if you know a basic cataract surgery, it will be very helpful, because to focus on cataract and glaucoma surgeries, because the glaucoma surgeries has like it's difficult, and we don't get that much of exposure in our residency. Yeah, there is a learning curve, and more like in the post-op like management, that is very important. Not only the surgery is okay, everyone is doing, but how to handle, how to make that trap or like AGV survive. So those things, like we have to learn every small things, what they are doing, when they are removing the releasable sutures, when they are performing the ALS, everything. Like, so you have to blindly follow for those 1.5 years or 2 years, you have to devote yourself for glaucoma. So that is there.
Yeah. And Dr. Sneha, any last words on this?
One important thing in glaucoma, I would say, is follow up your patients very diligently. It's not a short-term thing. You give the patient some sort of medication, and you don't expect immediate results. For everything, you really need to have a very long follow-up with all your patients, and that would give you very great insights into how much your treatment is working, how it's evolving, and what needs to be changed. And that's also a very useful way of forming lifelong bonds with your patients.
Right. Okay. Thank you so much. Yeah.
You have to be very patient, actually. It's not like the cataract surgery, you are getting a 6/6 and 6 vision on the first day itself.
Right.
It's not like that. And the main game starts after the surgery only. So you have to be very patient, and you have to like close follow up, whatever.
Lifelong follow-up is required. Okay. Thank you so much, all the panelists. And over to you, Dr. Devakant, for the next subspecialty.
Thank you so much, Dr. Manak, for handling the session so well and to concluding on time. So next we have Dr. Ajinkya Deshmukh. He is a pediatric ophthalmology fellow at LVPI Hyderabad. Over to you, Dr. Ajinkya.
Thank you so much, Dr. Devakant. And this is last roundtable, but last but not the least, definitely. And why I say that? Well, India houses the largest number of blind and visually impaired children compared to any other country in the world. So yeah, this is last but not the least session. And we have 3 eminent panelists from 3 different Apex institutes who will be joining for this session and guiding us through the pediatric ophthalmology roundtable. I hope my slides are visible. So first we have Dr. Digvijay Singh. He actually doesn't need an introduction. He is President TOC and he is trained at RP Center, New Delhi. He has his own practice at Noble Eye Care in Gurgaon. He is head of ophthalmology department at 2 multi-speciality hospitals, and he specializes in pediatric ophthalmology, strabismus, neuro-ophthalmology, and glaucoma. Welcome, sir. Next, we have Dr. Kirandeep Kaur, who is consultant at Department of Pediatric Ophthalmology and Strabismus at Arvind Eye Hospital, Pondicherry. She has done her residency, followed by Pediatric Ophthalmology and Strabismus Fellowship at Arvind Eye Care System itself. She is very well published and has many awards on her credit. Welcome, ma'am. Then we have Dr. Subhojit Bhattacharya, who is consultant Department of Pediatric and Neuro-Ophthalmology at Sitapur Eye Hospital. He has done his residency from Shankar Netralaya, Chennai, and has done his fellowship from Shankar Netralaya, Kolkata. And above all, he is a very good singer and a musician. Welcome, Dr. Subhojit. So I would like to start the session by first question to Dr. Subhojit. So, Dr. Subhajit, why should one choose pediatric ophthalmology as a career?
Thank you, Dr. Ajinkya, and thank you, Dr. Divakant, for choosing me over here. I think the pediatric ophthalmology, as you just said, Dr. Ajinkya, it's one of the most commonest problems currently in India, and we don't have so many super specialized centers. It's important that we increase the number of training centers over here, and the number of trainees get involved in it. And I think the first step towards choosing your fellowship would be to assess yourself whether you are fit and suitable for kids, because a lot of people would just see kids, crying kids from a distance, and they'll be like, okay, just refer it to the pediatric department. So the first thing is that you understand yourself, whether you're a calm, patient person or not, whether you're observant or not, because a lot of it lies in the clues. You see the kids from a distance, you see the abnormal head postures, and you learn a lot from there. So a lot of the clues to the diagnosis lies in your observation. So apart from that, also, if you have a good exposure in your residency, that helps a lot. So personally, I had done my residency from Shankar Netralaya, Chennai, and I had been posted with very eminent pediatric ophthalmologist, Dr. Meenakshi Swaminathan and Dr. Sumita Agarkar, and I had done my fellowship under Dr. Sujata Guha. So they're all very eminent people, and it got me interested in the subject. And thereafter only you get to decide. Once you're interested, once you have some sort of passion in the subject, then only you get to decide whether you're actually willing to take it up for the rest of your life or not. And lastly, not the last part, I mean, one more thing, you should be very confident with your phaco skills and your cataract skills before taking up a pediatric ophthalmology fellowship, because my mentor used to say, unless you're a good adult cataract surgeon, you won't be able to deal with kids. You won't be able to deal with pediatric cataracts. So I think it's important before deciding to choose you get into pediatrics. I think it's important that you are well aware and well confident with your cataract skills, and then go ahead with the pediatric subspecialty. And I feel for residents, sometimes personally even I was a lot confused which one to take it up for the rest of my life. It's the life that we are talking about. It's not just 1-2 years of our life, of our career. It's the entire life that we're talking about. So I think you should assess yourself, and you should just screen through all the remaining subspecialties, whether they're fit for you or not, like retina, cornea, glaucoma, uvea. And through the rule of exclusion, I think it's important to just exclude yourself from, okay, for me personally, I was not a very good cornea observant. I was not a very good glaucoma. I was not good with gonioscopy. I was not good with personally the retina, overexposure of retina. So I decided to go ahead with peds, because I felt that I was good with kids and had a brilliant exposure. So it's a lot of self-assessment and what you want to do with your career. That's how you get to decide eventually. I think that's about it.
Thank you, Dr. Subhajit. So I think to summarize from your talk, so one should have passion and patience
Definitely
to choose pediatric ophthalmology as their career. Thank you. So my next question is to Dr. Digvijay. Sir, can you please elaborate on various training options and opportunities which are available in India for a pediatric ophthalmology?
Right. So, pediatric ophthalmology, just like retina, does have a learning curve as well. And that's because, you don't get to start working or operating on children from a very early on point in your training. That it takes time before the confidence is there in your mentor to be able to allow you to, start operating on a child. And I think yourself also, there is always that feeling that, the first child you operate. Now, there are a lot of training options in India. And when I say a lot, meaning relative to what we have in other parts of the globe. But compared to other specialties, it's lesser. So I think probably we have about maybe 15 institutes or 18 institutes which are actually having a pediatric ophthalmology fellowship. And most of the places where there is an SR-ship, it's not predominantly focused alone on pediatric ophthalmology and strabismus. And I'm saying pediatric ophthalmology and strabismus because they do go hand in hand together in most of the institutions. So you are looking at adult strabismus as well alongside. And also the number of seats are usually limited because of the kind of infrastructure they would have. They would need to have your GEA facilities. They would need to have appropriate faculty who in themselves are a little limited, and relative to all other fellowships, probably the number of seats in pediatric ophthalmology are lesser. That said, if you are somebody who has a passion, as you said, if you are somebody who is interested in working with children, it's not difficult to get into a pediatric ophthalmology fellowship as long as the people on the other side of the table who are interviewing you can also see that your passion is there in you. We are kind of becoming something like a generalist of all eye specialties within the pediatric age group. So essentially, if you are somebody who wants to look at cornea also and glaucoma, and you want to look at retina and uvea and everything, so you can do all of that. It's like a comprehensive ophthalmologist in a pediatric age group. So you have that advantage, and so you do undergo, you do see a whole spectrum. There is an issue of the Yo Times, the 16th issue, which has come out recently, which is on pediatric ophthalmology. So that does mention a lot of the institutes where this fellowship happens and where the training happens. So you can all look at that and refer to that. Also, the Indian Journal of Ophthalmology carries a list of fellowship positions across the country. You can even look at that. So roughly probably about 30, 35 seats a year is what we are looking at in India currently.
Thank you, Dr. Digvijay. So I would want all the aspirants and the residents to take a note of this 16th YOSI issue. Those who are all interested in taking up pediatric ophthalmology, please go through the issue and you will get a better insight. Thank you, Dr. Digvijay. My next question is to Dr. Kirandeep. Ma'am, can you tell how should one approach a pediatric ophthalmology fellowship, and in specific, during fellowship, the clinics, the surgeries, the research component, and the conferences, how should one approach each one of these components, and how important is each of these component, and how do you rate them? Because you are very well published, you had 59 publications in your fellowship, and you had also won award for best very well published during your fellowship. So we would want to know your insight on this, please.
Thank you, Ajinkya. And thank you, Devakant sir, for giving me this opportunity. So first of all, like pediatric fellowship, like when I decided to go in for pediatric fellowship, first thing what I felt was like it is a very much mentor dependent branch. So the way we will be doing surgeries, the approach we will be having towards the clinical thinking, it will reflect the lineage like of which we are a descendant. So to go in for pediatric ophthalmology, first thing we need to have a good mentor and a good institute which gives us good training. So the basic approach, it should be based on like whether we are going in for a 1 year or a 2-year program. So like our goal should be from the starting, it should be like trying to see the maximum patients so that we acquire good clinical skills. We need to learn to examine patients holistically. So in pediatric ophthalmology, it is not only the eye, it is the full body which we have to evaluate, because we are next step in case we're taking for surgery is going to be a general anesthesia. We need to learn the soft skills to engage patients themselves into the examination. Then we also have to take care of the parents' expectations. We need to anticipate the questions which they will be asking and include them in the counseling part. I think this part is like, it really does wonders. So moreover, like for the academics part, we need to have strong basics. We have books like Von Uden, Rosenbaum. Like Von Uden is one thing like which I just love it. So once we start reading it, the things in OPD will start actually making a sense, and that is when we start loving the branch. So once we start seeing a lot of patients, we come to know what is common and what are the like rare cases. So then we should be having a habit of good going back and doing a good homework. So we need to read books, refer articles using PubMed or Google Scholar. It will be either like we will understand what is happening, or we will realize it is a very rare presentation. So that is how now the next step comes of the research or a paper presentation in a conference. So for pediatric surgeries, like it is actually very different from the normal adult surgeries. It is not only a small eye which we are operating on, but it is more than that. So we have to take care of the general anesthesia risk. Any mistake or any substandard surgeries will mean another anesthesia dose for the patient. So that is a very important thing. And particularly for the strabismus surgeries, like as my mentor always says, like it is very easy to learn. You really need not think about learning squint surgeries. So it hardly takes like few months to learn the skills to do a squint surgery, but few years to learn what to do, and it takes a decades of experience to know when not to do. So one personal like thing what I have been doing is I've been maintaining my strabismus pre-op and post-op albums, which I think is really like doing wonders now once I've joined as a consultant. So the pre-op post-operative photos in the surgical dose, we can make just add small stick-on notes to it. Like we can have it in a PPT format or whatever way like we feel. So this will be helpful like for a lifelong thing. And then moreover, like targeting the conferences part, we have like more a lot of options. Like there is SPOSI, AIOS, like pediatric sessions will be there. Then American Association Pediatric Conferences, World Strabismology conferences. So for that, we need to be actually prepared. Like we need to know deadlines beforehand. We can start asking or thinking of a project once we are in the starting days of our fellowship. So maybe we can start with some case report or a photo essay itself, and then plan for some prospective studies and make use of like our free days in OPD to do some retrospective meta-analysis at the same time.
Thank you so much, Dr. Kiran, for those insights. My next question, and in continuation with this question, actually, I would want to know from all three of you, because you all three have done your fellowships and SRship from three different Apex institutes. Surgically, in specific, how many surgeries is a good enough exposure for a pediatric surgeon for squint and a cap pediatric cataract both?
I think it's probably not the number of surgeries, but what you learn from each surgery that's more important in pediatric ophthalmology. See, we have to understand that this is not a branch where you're looking at mass level of surgeries, or it's not really a branch where numbers are going to come in a way, because there'll always be general anesthesia. There's always a delay. There's only so many you can do in every OT. There are only so many OTs you have. So while you definitely need to be able to have seen most cases, the spectrum of most cases, each surgery you have to observe very carefully in the beginning, and you get to operate only a little later down in the line. But still, I mean, if you were to think about pediatric cataract surgeries, I think as Subhajit correctly said, that you need to be a good adult cataract surgeon already. So you would probably should have some backing when you step right in. It's not, if you haven't really done phaco before, you can't get on doing pediatric lens aspirations from day one. So you need to have that. But again, I don't think there is really a number that one can put and say that these many are enough. It's probably the learning you take from each. However, the more the merrier at the end of the day.
Dr. Subhajit, your take on this?
Yeah, as Vijay sir said, I completely agree with it. And regarding squint surgeries, I mean, I always learned one thing in my fellowship days: ki it's not about the surgery; it's about the planning, which is more important in terms of squint. So you get to see as many number of cases as you want, and that's a big advantage if you are working at a high volume center. You get, especially at a good institution, referral institution. If you get to see a large number of squint, then the surgery automatically follows, because there's not much to a squint surgery. You can learn it, Dr. Kiran just said, you can learn it in 2-3 months of your surgical exposure. But then the planning of the surgery, how much you want to do, I mean, and definitely maintaining your album, surgical, post pre-op and post-op. We have a very good app called 9Gaze app for that. If you go to the app store. So that's how you go ahead. And regarding pediatric cataracts, as long if you're a good adult cataract surgeon, and because pediatric cataracts would not come to you on a regular basis like we have in adult cataracts, they would be hardly, even in great centers, they would be like 4-5 a week for to all the consultants. So I mean, it's important that in your fellowship days you maintain good rapport with all the consultants, so that you start with close to teenage cataracts, 12 years 14 years cataracts. You do just the lens aspiration parts, so that all the consultants call you for the free cases, community cases, and then you gradually decrease the age, and then you gradually go towards the lens aspiration and the PPCs, and then finally you go, and if you are like done with around, I personally feel, I mean, we had a good number of 30 cases in our in Squint in our fellowship days for all the fellows, and about 20 to 30 or number of pediatric cataracts, of which maybe one or two lensectomies is good enough. And if you're like done with around 4-5 lens aspiration and PPCs, it's a good number for your exposure, because you don't get to learn everything in your fellowship days. It's just the starting of your learning process. You get to know the approach, and eventually it's a very good idea to go and start your career at a charitable institution. You get your hands on proper, and before you actually start with your private practice. So it's not exactly the number. You have to get into the approach and gradually work your way up. I think that's about it.
Well, very well put. In interest of time, I would like to go to next question. From both of you, actually, Dr. Digvijay and Dr. Subhojit, can you elaborate on your views about institutional versus private practice for a pediatric ophthalmologist?
Subhojit, you want to go first?
Okay, sure, sir. Yeah. So I guess, I mean, before getting into the private practice, the world of private practice, I think it's, personally, this is what I feel. It's important that if you work in an institution first, I mean, it always helps, because in an institution, you have a world of helps. It's pediatric clinic of yours. It's not just pediatric cataracts which you get. It's a lot of pediatric glaucomas, and you have a lot of retinal diseases, and you have oculoplastics problems. So I mean, if you're working at an institution in the initial part of your career, so you get to you get to your referral helps you get to refer all these cases to your colleagues, and obviously if you're working at an institution initially, you get the advantage of having an automatic GA is a huge headache, by the way, if you're working at a private center. So you get all that. Plus, along with that, I mean, in case you start with your private practice, you are all by yourself. There is not much of learning after you're done with your residency and fellowship. If you're working at a private, there's a saying, it's you get to before earning, you get to do all your learning first. So I feel after your residency, you go and join an institution, maybe a charitable one. You complete all your learning, get confident, and maybe then only you can start with your private practice, because on your private practice world, you're on your own. If sir wants to add anything, sir.
I think you more or less covered it. Essentially, I'm in private practice and I do a specialty pediatric practice. So one thing that I must say that, you must know your pediatric refractions very well. From whatever you'll get at the end of the day, your maximum number of patients will be for refraction, will probably be for eye allergies, will probably be for smaller, problems. While our entire focus sometimes is squint and pediatric cataracts and pediatric glaucoma, in the real world practice, as a pediatric ophthalmologist, your largest chunk will actually be these simple day-to-day issues. And I think you need to be able to learn that well. And sometimes in institutions, our focus is not on that. Our focus is actually on pathologies. While something like a refractive error, amblyopia management, that's what you'll get more in your own private practice.
Thank you so much. One last comment, a quick comment from Dr. Digvijay. Well, it said that jack of all and master of none. A pediatric ophthalmology itself has various subspecialties which are emerging now. So is it really necessary to choose one subspecialty like complex strabismus, nystagmus, or pediatric cataract or neuro-ophthalmology to master, to grow bigger in your career? What's your say on this? A quick comment.
It was in the IGO issue a few years ago where they said, is pediatric ophthalmology really a subspecialty in India? Is it developing? And now we're talking about subspecialties or probably super specialties. And I'm glad that is coming out. I think, you have to be a jack of all trades, no doubt, as a pediatric ophthalmologist, but it does help to become a master of one of these. So, you could be a good squint person, you could become a good pediatric cataract person, and then you develop a name or a rapport in that field in your area. See, at the end, it's going to be a referral practice for a pediatric ophthalmologist. So I think it does help to, kind of start mastering one particular item. That said, probably you can only do that if your institution has got you to a level where you actually have become a jack of all trades. And sometimes you're not even a jack of all trades before we start to become a master of one.
Thank you so much. I think that was a very elaborate discussion, and it should help all the pediatric ophthalmology aspirants and residents to choose our subspecialty for their future career. Thank you so much for the opportunity, Dr. Divakant and the team. Thank you all the panelists for your great input.
Thank you so much. Thank you so much, Dr. Ajit.
Thank you.
Thank you so much, Ajinkya, for managing the session so well, and of course, great inputs. Let's move on to the next session. Before that, if Namrata ma'am is there, we can have a word from her about the FAICO exams. That should be relevant at this position. And in the meantime, I would invite Dr. Vedant. Are you there, Dr. Vedant?
Yeah, very much here, Dr. Devakant.
So Dr. Vedang is a consultant at Rai Foundation, and he is also the chairman of the West Bengal State Chapter of YOSI and executive member of the Central YOSI as well. Over to you, Dr. Vedang.
Thank you, Dr. Digvijay and Dr. Devakant for organizing this UC session. And we have a lot of options and a lot of things to do in our before we start our career as ophthalmology consultants. And the most important thing that I believe once we are about to finish our fellowship or about to finish our post-graduation is the choice between the private practice and a group practice. And to discuss about this, we have who have been in private practice and in group practice. To name a few, we have with us a known name in pediatric ophthalmologist, Dr. Love. Thank you, sir, for joining us. Dr. Love is a senior consultant at the BBI Foundation and the Netralayam in Kolkata, and sir is a pediatric ophthalmologist. We have Dr. Navendu Rai with us, who is a second generation ophthalmologist and has finished his VR fellowship from Aditya Jyot and is now working in UP. There we also have Dr. Siddharth Bose with us. Siddharth Bose is a comprehensive ophthalmologist who is working in West Bengal in a district in Chinchura. We have Dr. Bhupesh Singh. Dr. Bhupesh Singh is also a cornea refractive surgeon at Delhi at the Bharti Eye Hospital. We have Dr. Ronak Solanki with us. Dr. Ronak has just started his private practice after finishing his DNB from Arvind and fellowship from Joshi Cornea and Refractive Services. We have Dr. Aman Khanna with us. Dr. Khanna is also working in Delhi. He's a cornea refractive surgeon at the Khanna Eye Center. And we have Dr. Vibhuti Kashyap, a fourth generation ophthalmologist working in Ranchi at the Kashyap Memorial Eye Hospital. Welcome to all my panelists. I think the choice and the most important thing, as you know, is the difference between the financial satisfaction, the professional satisfaction, the background from where you are coming, whether you're going to be in a well-placed city, in a first tier or a two-tier city, whether you have any background or not. So these are multiple factors that we need to look into place before deciding or jumping into either private practice or a group practice. Let me start with Dr. Love, the senior most consultant here. So Dr. Love, what was it like when you joined or when you started your career after finishing your fellowship?
I finished my fellowship. It's almost 18 years journey now. So I finished in 2004. Then I was sent to Shankar Nethralaya, Calcutta for for setting up the pediatric ophthalmology department. But one advantage what I faced and later on I saw in one of Jack Ma's interview also. It's always better to start in a smaller place where you have interaction with the top management rather than going to a very big place and then you are the junior most consultant there. So when I started, I was the fourth consultant in Shankar Nethralaya, Calcutta. And then 5 years I stayed with Shankar Nethralaya and then moved to my own group practice at BBI Foundation. So next 3 years was spent 5 years at Shankar Nethralaya, then next 3 years spent in setting up my own private practice. That was not owned by us. It was a group practice in which I joined to set up my own practice. So next 3 years was mainly concentrated on that. Then we started our own center, which was called BBI Foundation VIP. So 6 years back or 7 years back, we started that. And now till BBI Foundation VIP, we had a senior colleague with us who was there to guide us. And now after 2004 to 2020, we have started this. So 16 years later, now we have our own center in which we are the senior most. So that was the total journey of my career.
If you had the opportunity of starting the private practice immediately after your fellowship, would you have taken that during your course?
Not have taken, no.
Just because you are from pediatrics, is that so? Or
no.
If you had you been from a cataract? Sorry, sir.
What happens when you are joining an institute, then you get a ready-made base on which you can hone your skills much better. First thing, you will be struggling with the basic base of patients to start with a pediatric or a private practice. When you go directly from fellowship to private practice, especially in bigger cities, I'm talking about Calcutta, you start from zero. But if you have spent some time in an institute, maybe in my case, I spent 5 years, then in 5 years, you have dealt with enough volume and you have some name in the city. And then when you start your practice, then you have some basic base at which you have started, not from zero. And then you can build it from there. So that is, with my experience, I would suggest that few years in a institutional practice helps a lot in many, many ways. Not only honing your skills, it helps in your management of the issues. See, whatever management we are doing now, it was the first 5 years what we learned in Shankar Netralaya, because it was a small setup. So right from first year, I was pulled up into the management system and the decision making, and in the process, there were some conflicts, conflict management, ego management, all these you learn in the initial phases. That will not come. And when you have not been exposed to this and come directly into practice, then learning these things will be much more difficult.
Dr. Navendu, do you have to say on this? You jumped into being a second generation ophthalmologist. You already had a background. Would you like to differ from Dr. Love? Like, what was it like jumping into private practice immediately? And as sir was mentioning, it is always better to work or start working in a 2-tier, 3-tier city. You come from Diori in UP. How is it, and what things were there in your mind when you decided to jump into private practice?
Yeah, Vedant, actually, it has been very well put by Love that you definitely require some time before jumping into practice. And that time depends on your own learning curve. So it is not just your professional skills. When you are going into a private practice, it is not just your professional skills that matter. There are certain more things that are very relevant and very important. You need to see the big people, big shot ophthalmologists, how they speak to the patient, how they counsel the patients. It is not the good, only the good cases that you are going to operate. There will be cases in which complications would occur. So how to manage those complications, especially not only surgically as well as verbally. What do you need to tell those patients at those times? Then how to manage the financing, all these things. Now, AIOS is coming up with very good programs on leadership development. So most of these things are covered in that. We get all those big shots telling us about the financial options. Then all these the problems that I was discussing, all those are discussed very well in those LDP sessions. So people should go and join all those things. I mean, they should go and visit those the webinars right these days they are going on, and the physical conferences also before jumping into a private practice, because it is not just the professional skills, but there is more than that before you start your own practice. Secondly, the number of years and number of cases before jumping into a private practice depends on you. The day you realize that you are able to do these steps properly, and the day you realize that you are able to manage the complications properly, that is the day that you can start your own private practice. Because in your private practice, you are the whole soul responsible for everything, for the good cases also and for the complications also. So these things I would say are very important before jumping into a private practice. And that's it from my side.
Dr. Ronak, you finished your fellowship, you have no background, and you decided to plunge directly into private practice. Both Sir and Navendu have put them that you need to hone your skills, you need to wait. In my opinion, see, ophthalmology is the learning in ophthalmology is never going to end.
Never going to stop.
So it is never going to stop, never. And every 2 years we have new equipments. We have a lot of in order to set up an ophthalmology clinic, you need to invest so much. So with the background and I mean all that, keeping that stuff in mind, what did you think before jumping into private practice immediately?
So ideally, it's first, as you said, it's a personal goal that you have, that whether you want to be financially more independent or you want to just, keep working under a big corporate setup or something. But the most important thing is, as Dr. Lal also said, you get your skill sets right first. Because once you go and once you jump into the practice, there's no going back. You have to have a certain, especially when you're practicing in a very competitive environment as us, you need to be really skillful. Then there are other problems which you will face. Sometimes as surgeons say that in private practice, surgery is the most easy part. It's the financial planning, the clinical skill development, then the administrative work in your own setup, whether it's a solo or a small group practice, and then, balancing your family and then continuously refining your skills, whether you have time to attend seminars or CMEs. Financial planning also has a lot of things which you need to take care of, like, choosing the right place in the city. You may be living in the city, you may be born and brought up in a city, but sometimes you may not be able to afford a place in the centermost location of the city. And then you have to eventually go to another place and open your center where you may not know people, people may not know you. So it becomes a totally new challenge for you altogether. It's slightly easier in a smaller place because the density per clinic or whatever you say is lesser. And as Sir also said, it helps if you have worked in an institute in the city. So what I did was, I was very much confident of my skills post the fellowship, but I decided to work at a premier established center so that at least I know how the functioning is in the city, how private practice works in the city, because you need to know a lot of administrative stuff, the management of your employees, the various licenses you need, how to deal with the companies, what equipments to purchase. And you will only know once, you talk to people and you have used them in smaller practices, how people are managing. Like, you may not need the best of the microscope with the most expensive, like a high-end microscope. You may do with a lower end where you can invest in other diagnostic modalities. So all that you will come to know at the ground level. You will not be learning all this in an institute or a fellowship. It's just post when you start working at places. So and financial thing is the most important thing. It's how you balance it out. So let's see how we discuss about other further points from someone else.
I think finance is one of the key factors young ophthalmologists have in mind, at the back of their mind. So they're going to invest a huge money, whether they'll be able to recover that, whether they'll be able to hold on to the practice. There are so many practices or so many senior ophthalmologists in and around you. So that is something always at the back of the mind. Dr. Aman, starting this private practice, it's been like 1.5 years now. You've been into private practice. What is your take into this?
See, it was, I would say, a little easier for me as I'm a second generation ophthalmologist. So beginning a private practice, yes, comparatively, it was a little easier. But right now I'm practicing in a metropolitan city, Delhi, and there are a lot of things which you have to look in a private practice, because when you are in a private practice, there are a lot of aspects which you need to look at. So somehow while managing this, I feel one thing I have in my mind, yes, if I would given an option to start as a group practice, yes, there are a lot of advantages of a group practice, because I know a lot of my friends who have started in a smaller cities. They have started with group practice. Group practice doesn't mean that you have to have a common center or anything like that. What they have done is they have purchased a LASIK machine. 4 of them have purchased a LASIK machine, and the maintenance and everything is divided between the 4 of them. So it gives a lot of this backup to you. And moreover, one thing is that in a group practice,
your availability. Like sometimes your work becomes a little you become a little relaxed, because in private practice you have to be there for the entire time. You have to be there and you have to manage everything on your own. So that's the little difference between a group practice and a private practice.
Dr. Bibhuti, you are now a fourth generation ophthalmologist in your family. You were doing your residency at AIMS. Did you ever think of uh, joining other center before coming and starting? Because you have to keep up the reputation. You have to have that skills. You have to have that ability, because you will be under a lot of stress, because you have your seniors, you have your parents, you have your grandparents who have been there in the city for a long time. So what was there in your mind before you started your private practice?
Well, thank you, Dr. Vedant, for the question. I think you're absolutely bang on the point. But in my case, I was fortunate because I was at a center which has no dearth of surgeries. During my residency days, I mean, I'll just be blank point honest with you. I was not very much keen on. I mean, publications were a part of my residency training, but more importantly, I was basically focusing on honing my skills as much as possible with respect to the number of surgeries. I mean, I know there's a lot of jazz about the numbers are not required, and it's just the quality and not the quantity, and everything said and done, you need a good number of surgeries to be able to say, okay, I have done so many, I have done these many cases, these were my complications, I was able to manage. And only after repeated reproducibility of your results will you be confident enough. So that was my goal. And so I did not feel like coming back and joining some other center before joining my own center, because all that groundwork and field practice was done at RP Center AIMS, with over 1,000 surgeries of posterior segment done during the residency itself. I was more than confident of my own skills to start up, and because that exactly was the goal. Like, when I have to join back, they won't look at me as I'm just a 30-year-old. They would look at me in my father's shoes, basically, or maybe that the results have to be as good as that, to be able to not have a difference of or clash of patient's choice over to choose me or my father or the other people who are practicing since long in my practice. So the goal was basically to hone the skills to that level, and I think I did reasonably well in RP Center to be able to do that. So I did not join the practice, I mean, a center elsewhere. And the second goal was to basically dish out patients and your results in the field of ophthalmology, which are actually considered complex, and give them results. That is how you will win the confidence, and the people will start looking at you beyond your age. Because trust me, in smaller cities, the age of the doctor also plays a big factor, no matter what your degrees, your qualifications, or your experiences. So the only way to combat that is to dish out those complex cases results, to be able to gain the confidence. So that was my approach, and since past 2 years, I have operated over 600 to 700 vitreoretinal cases of ranging from, of course, simple to the most complex, which were rejected or referred or everything. And it's only after the people have seen the results, have decided trusting us. Trusting me. So that was my plan basically to do.
Thank you, Bibhuti. Dr. Bhupesh, I am going to ask you a little different question. You came in and joined at the Bharati Eye Hospital, which is a well-known hospital at Delhi. Did you plan to have some financial management or a hospital management training? Did you think of something like that before you wanted to join in? So we all know we are all going to learn ophthalmology, but this was something that was there in my mind. I wanted to ask you. What do you think? How important is that as well for a young ophthalmologist?
Very, very good, interesting question, Vedant. So regarding the administration and financial training, I don't think any institute can train you how to deal the finances and everything in your own setup or in your family owned. So primarily when I joined the setup, the main focus was your clinical performance, means your surgical output, your patient care. If you're well in those things, then only you should enter in the administration thing. Okay, so initially first 1 or 2 years, I didn't look at any administration thing or any finances. Just I focus on my clinical work, my surgical thing. Once your staff, your colleagues start accepting you as a good surgeon, then you start doing all the administration work. And best person to learn the administration stuff is not the boss of the institute, but the staff. You can learn each and everything from different staff. Like OT person will train all the OT procurement thing, he knows very well. Like the optometrist will train you all the optometrist stuff, all the machine AMCs and CMCs. So staff trains you very well. So you should have a good rapport with the staff. Then you can take the advice from the boss. So that is the thing to go in the private practice, I think.
Dr. Siddharth, you are working in a area which is a little away from Kolkata, a little away. And what was there in your mind before you decided to jump into private practice? I think immediately after your MS, you did a small fellowship and you decided to work with your father. So what are the responsibilities that you hold now as a young ophthalmologist there?
I straight away started an individual practice after my training. And what I felt was that individual practice is very different from what we learned during our residency and our fellowships. See, if you are in a big city, it is better to be a subspecialist because for a general ophthalmologist, there is a lot of competition in a big city. But in a small town like mine, exclusive subspecialty is not an option. It is always better to be a general ophthalmologist, and it is always very important to master your cataract skills because in a small town you will get a lot of cataract cases. What I feel that when you're doing an individual practice, 3 P's are important. Presentability, grooming yourself basically in front of the patient, being punctual to your practice because nowadays nobody likes to wait. If you give a good quick service, they are very happy. And be persistent in your practice. Persistent meaning keep your promise. Always try to follow through with your plan of management and avoid any change in the plans unless absolutely necessary. Otherwise, the patient will feel that you are shaky in your decision making. What I do is I always keep an assistant with me. What my assistant does is she has a phone and a SIM card with WhatsApp facilities. She addresses most of my patients' petty non-clinical problems over the phone. This communication with your patient is very important. If you don't communicate well with your patient is not going to be satisfied. One thing I want to advise the young practitioners is that do not talk about money with your patient. It gives a very bad impression about you as a doctor. Always ask your counselor or your assistant to talk about the financial part. Now, communication is very important when you have started clinical practice. Give extra chair time to your poor prognosis cases. If you don't want an unhappy patient, be very polite and at least ask 2 non-clinical questions to your patients like, घर में आज क्या खा के आए हो या कैसा है घर वाले कैसे हैं. Be friendly with your patient. They will accept you more. One thing which I generally follow as a rule since I'm a young ophthalmologist, everybody may not agree. I avoid doing poor prognosis surgeries, especially initially in my career. I refer them, but when I do refer them, I refer them in a way that I don't appear incompetent. Like when I'm referring a case of maybe a Marfan syndrome case with a subluxated lens, I'm going to tell the patient and the parents that we don't have such a strong anesthesia department. We don't have cardiac monitoring facilities. So I'm referring you to a bigger hospital, to a super specialty hospital like that. That is how I communicate with the patients. Communication is the key. If you communicate well with your patients, you get to keep your patients. Otherwise, you will lose your patients. And thank you, Dr. Veda.
Yeah, Dr. Love, Siddharth spoke about finances and about the counseling. I think as private practitioners, from what I understand is speaking to the patient is more effective, and speaking to the patient about their financial budget is more important personally than going into a counselor. What is your take on that, number one? And number two, in being in a group practice for such a long time, I think most of us are into private practices. All of us would like to know the financial part of the group practice. Like how is it that the group practice functions?
See, regarding counseling, see, he's also right. Like at my place also, personally, I tell them the package. When they have the doubts, then I tell them whatever suits your budget, you can do it. Like that, we do it and then send them to the counselor. But some doctors at my place only, I've noticed, like I've not discussed this, but I've noticed when they are telling a patient for surgery, as soon as finances come, they tell that the counselor will tell you. Both approaches are correct, whatever you are comfortable with. And regarding the finances in a group practice, see, group practice, again, there are different models. First, we have to identify those models and successful models, I would say. I think the biggest successful model in Eastern India is Disha, Eye Hospital, and Shushruth. But
So
it's a
Disha
group
and
practice.
Sushruth are institutions.
Yeah, but again, they have a variable component also there. And it started as a group practice and then slowly went into, they became so big that then the Disha brand became bigger than anything else. Our is I would say, the genuine group practice, what you are meaning. Like all doctors have their own patient base and then they join at one place, they share the infrastructure, they have a revenue model in which it is to be done. And we have a lot of flexibility in our practice. Like there is nothing common in our own practice except that all of us are of different subspecialties. There are few of us of the same subspecialty also who are practicing together. All of us have our own patient base. All of us have appointment system in which the patients are given appointment. Walk-in patients for the hospital is very few. Very few. Mostly it is patients are coming for the doctors. So what we have done that we have charges for the institution. If there is if a doctor is sharing our OPD space, then the institution charges are fixed and the doctor gets to decide whatever they want to take. But more or less there is a consensus that we stick to the same amount. That is a consensus, not a rule. And in OT, what we do is the OT charges are fixed and then doctor decides his own surgical charges. Institution doesn't decide about regarding the doctor's charges. That the doctor has to decide. We have in the same OPD, suppose I am there as a pediatric ophthalmologist, I'm the only person. But for cataract, if I am there, Dr. Sagar is there, then Dr. Prashant is there, Dr. Ravi is there. All of us are sitting in the same OPD, same day, but our surgical charges are different. And then also patients are not switching from me to another doctor because again, they have come for me. They want to know only my charges. They don't want to know what Sagar is charging, what Prashant is charging. So that is, we have a lot of flexibility in that. Then diagnostics, whatever we refer, major, almost all of the revenue goes to the hospital only. We are going into a system in which if the doctor, suppose if we are doing a laser, the doctor can charge his charges for the laser procedure or reporting of OCT report or a HBF report. If they are reporting it, doctor can have their own charges, but institution, it's 2 o'clock, charges for the diagnostic, and we are doing away with the practice of giving cut and shares based on how much you are. That is mainly unethical. On the ethics part, we are not doing that. These are the three main components, and then apart from that, you have the opticals and pharmacy. So we have outsourced it to a different agency, and we have a profit sharing model with them that goes to the hospital. So revenue of hospital contains these, and doctors have their professional fee as their revenue.
I think well summarized, Love sir. And I think to summarize it overall, what is important is to know where you are going, whether to a two-tier city or a metropolitan city. What is your personal goal, whether you need a personal professional satisfaction or whether it's a financial satisfaction that you're looking at. And also to know the patients or the niche of patients that you are aiming at. I think a lot of things that we have discussed here, and that would help the young ophthalmologist to choose between a private practice and a group practice. Thank you, all the panelists. In view of time, I will have to end the session here. And over to you, Dr. Devakant.
I just want to add one point, Vedant.
Yeah.
When you speak to the patient regarding the charges for the surgery, Siddharth has commented very well. But just one thing I need to want to add is the patient in a private practice has come to the doctor, and he wants the final word from the doctor. And the doctor is the one who decides what should be the package for that patient. Finally, the word should come from the doctor himself. There are some poor prognostic patients which the counselor doesn't know. And if a patient of with ARMD, you ask and your counselor counsel him or her for multifocal IOLs, and later on the patient comes to you that whatever was promised has not been given, then the onus it goes to you. So the final word has to be from the doctor, not the counselor.
Agreed, Dr. Rai. Agreed, Dr. Rai.
Correct.
Everyone has their own practices, and everyone are probably it is variable from person to person. And I would completely agree with you. Probably after explaining the prognosis and explaining the patient about the surgery and the prognosis, the counselor can probably take it from there. Thank you, Dr. Devakant, and thank you all the panelists for joining us for this session. Over to you, Dr. Devakant.
Thank you, Vedant and the panel for that excellent session. So next session is on institute and government practice. I'll introduce our moderator, Dr. Anu Joon, who is an assistant professor in strabismus and glaucoma services at Guru Nanak Eye Center, Maulana Azad Medical College, Delhi. She's an executive member of YOSI and is actively involved in imparting clinical and surgical skills to our young budding ophthalmologists. Over to you, Anu, to take over the program.
Thank you, Dr. Karan, and thank you, Dr. Deva, for this amazing session. And from the private practice, we'll now be moving on to the government and institutional practice. Of course, it's always a big dilemma once we're out of residency or out of fellowships as to what to do. So we've had a good take on the private practices, and now we'll be hearing some experiences from the young esteemed faculty at a few government institutions, as well as the renowned specialty tertiary eye care private institutions. I'd like to welcome our panelists for the afternoon. We have Dr. Samendra Kharkud with us. He's an associate professor at AIMS Bhopal. He is Vitreretina, UVA and ROP trained from PGI and Bayer's Eye Institute, California. We have Dr. Simar Ranjan Singh, who is a research associate at the Advanced Eye Center, PGI. He is again a Vitreretina and UVA trained specialist. We also have specialists from the private centers, or the institutions rather. We have Dr. Tarjini Dave, who is an associate ophthalmologist, ophthalmic plastic surgery services at LVPI. I also welcome Dr. Chitranjan Mishra. He's a medical officer in Vitreretina in Arvind Eye Hospital, Madurai. Next up is Dr. David Shah. He's again a vitreoretinal surgeon, trained from SN Chennai, and he's the head of VR unit and the Department of Research and Academics at Chaitram Nethralaya, Indore. We have Dr. Tanmoy Biswas, who is an associate consultant in the Department of Pediatric Ophthalmology and Neuro-Ophthalmology at Shankara Nethralaya, Kolkata. And last up, we have Dr. Pooja Khamar, who is a consultant in cataract and refractive surgery and a clinical and translational scientist at Narayan Nethralaya, Bangalore. I welcome all the panelists here, and moving ahead to the discussion without wasting much time. Just to avoid any confusion, I'll be referring to all of us as institutional practices, whether it be government or the renowned tertiary eye care institutions. Okay, starting up with Dr. Samendra. Dr. Samendra, what inspired you to join an institutional practice rather than, going for your own private setup? Please unmute yourselves before you speak. I'd request all the panelists.
Thank you, Dr. Anu, and thank you, YOSI, for giving us such a beautiful platform. We keep discussing these small things in small groups in our centers, but here we can benefit with our discussion, the entire YOSI, the young groups. So like you asked me what inspired me, so there was no inspiration as such. I was always convinced about one fact, that I have to do an institutional practice. But of course, I had to decide between a tertiary care charitable institution or a government institution. So when I did my training at PGI Chandigarh, I saw that the most important thing that gave me satisfaction was the liberty and the freedom to do to practice and to treat and manage the patient my way. And I felt that it was only possible for me because I have had some experience at a charitable semi-corporate kind of an institution, and I felt that the only way I can do the work to my satisfaction would be in a government institution. And I would like to stress the fact that I am in a very nice environment, and this environment is given to us by the upcoming AIMS in India. There are so many of them which are coming up. So here there is no established ladder, there is no stratification which exists. It's not like you join as somebody who's right at the bottom, and then for each and everything you have to look up to the senior people. Here you can build up the department, build the specialty, build up your patient base, and of course the recognition that you get out of it, the respect that doctors often seek and sometimes not receive with the hard work they put in. So this is all these things inspired me, or probably made my conviction stronger that I would like to go with the institutional, rather a government institutional practice.
Okay. Dr. Chitranjan, you're also in an institutional practice, but a private one. So what was the motivation behind you joining a private ophthalmic institution?
So first of all, thank you, Dr. Divakant, team UC, and Dr. Anu for including me in this roundtable meeting. And happy to know that Dr. Anu is from the same alma mater where I did my ABC of ophthalmology, you can say, from Guru Nanak Eye Center. So coming to the question, because the question is specific to me, so I will not make it generalized, I will make it specific only. So there are few points I want to tell you. First of all, for the patients, we live for the patients, whatever we do for the patient. So when I completed my VR fellowship, I thought that if I am going to give better justice to the patient, I don't mean that those who are not continuing for some time as a medical officer or in the institute, they do injustice, but I thought it will be better if I continue for some time. So just to divert little further, here it comes with a disclaimer actually. We are all young ophthalmologists. It's not very clear whether we will be continuing in the same institute where we are doing now. We may go for a private practice, we may go abroad, because our age group is kind of very tender. We know the name itself signifies YOSI. So I thought that I should do some more years of practice over here, so that in the fellowship time, you do all the kind of very hard work you do, but to do directly under the guidance of your seniors. For example, the great seniors are over here, under the direct guidance to do the surgeries, the medical cases like daily 50-60 cases you will see in the OPD. That kind of refinement you go, and that directly helps in the doing better justice to the patient. That is for the patient. Number two is for the colleagues or your peer group where you are going to work if you want to move out from the institute. So take for example, I was involved here in some kind of say research. You cannot get a institutional ethics board or IRB or something once you move out of the institute. So if you want to do some research part of that, so you can do it over here. And here, not only the seniors, our juniors also here, they have started taking, in Arvind Hospital Madurai, they have started taking research fellows. Before doing retina fellowship, they do research. So they also help you. So in that way, you can do research, you can be visible. Additionally, involvement with the OC, AIOS and other things, you can do that, or you can be visible among your peer group, among your colleagues and everywhere, so that even if you want to move out, you'll be more appreciated by your employer or say your kind of colleagues over there. And if you want to continue over here also, you'll be better appreciated over here. And we have already seen in the previous sessions, they told that if you want to directly jump into the private practice, so many hardships you have to face. So if you want to continue in the institutional practice, you have all these kind of advantages. Then coming to the third point, that is you yourself, you can decide, or say for example myself, because I am telling over here, I can decide after a few years of institutional practice whether I want to continue over here. Anywhere, somebody can be a senior resident, assistant professor. If they want to continue here also, they will be better appreciated by the existing staff, the nurses, the sisters, the HODs, the colleagues. They will better appreciate because, oh, that guy, he knows about the system, what is the OT, what is the protocol, everything. If you want to move out also with all these advantages, you can do better justice if you move out. Yes, then comes the limitations as well. If you want to move out, if I want to move out, the geographic position where I want to go. If I go better earlier, that is better because somebody else can come and sit down over there. So everything comes with a limitation. So why I gave all of these dichotomous things, because we are in a tender age in this UOC group. So why I joined this institutional practice, the advantages also I told, because we are in a junction where by this we are gathering experience, we are gathering the surgical experience, the research things, the teaching experience, because in the institute you will get students or say fellows or PGs to teach. So all these things will kind of add on to your CV, to your experience, which will help us in the better prosperity in our future and better justice to the society and to the patient. That's why I joined, Dr. Anu.
Thank you, Dr. Ranjan. So most of us here are ones we've done our fellowships or our residencies from these particular institutes, and we've joined back as a faculty here. So what about those who've not had a chance to do their senior residencies or their fellowships from such prestigious institutes? How would they get into such an institution? Dr. Simar, what is your take on that?
Thanks, Dr. Anu, and thanks to Team UOC, Dr. Devakant, for having me here on this panel. So, just like Dr. Samendra, I too belong from PGI. I have done my residency from here, and I'm working at PGI only currently. So, I would best be talking about government institutions. That is what experience I have. So, when we're talking of working in a government institutions, I think we are talking of a faculty position finally.
Yeah.
And the numbers are limited for that. So we all know that. For the first thing, that what do you call as institutions in the government setup is a very limited number in India. You would want to call institutions that provide multi-speciality practice within the same place and not just the simple general ophthalmology. So those institutions are very limited. PGI, AIMS, and few AIMS-like institutions, and a few others. There are not many. So, and then there is a component of reservation into them. So not everybody is eligible for all those seats. So that further limits the number of opportunities that you have. So the best time to get in is your junior residency. There is no better time for a government institution to get in. You get a good base, you get to know the environment, you get to know the people, and more importantly, the people get to know you. So that is the best time. And you can obviously see what excites you, what's good in that institution, what do you want to pursue if you want to stay there. The next point would be the senior residency or the fellowship, as you said. For the government institutions, mostly it's senior residency. And again, you have opportunities there. Every now and then there's going to be a seat that is available that you can compete in and get into that. It's not very tough to get a senior residency, especially at PGI, for an outsider who might not have done a junior residency from here also. Also, now you have opportunities with MCH in vitreoretina and cornea that have come up in PGI for the first time. They are completely impartial and open for everybody to give an exam and get in. The next point of entry, I think, just like you said, that if you have not done a junior residency, not done a senior residency from that would be a research position. Something we tend to discuss when we are going for foreign institutions, but not in India. But research positions are very important positions. You can always directly talk to a faculty, write a project, get into one of these if you are minded towards that. But then you have to be ready for about 3 to 4 years of strict research, a minimal salary in that much time. But then you have to establish your base in that institution. The people from within the institution should want to have you there. Only then you can be there by and large. Right? Direct faculty level entry for a general category entrant is a very tough, because you might call it nepotism, you might call it favoritism, but if it's finally a job that they are offering you, if you are keeping somebody, you would want to know that person. You would want to know what he can offer, what he does, and how he gels with everybody. So a direct faculty level entry without having spent some time in these top government institutions for a general category student would be a little difficult. So that's what I have to offer of all the points where you can gain entry into these institutions.
I think that was very well put, Dr. Simar. A research position would be highly appreciable by the faculty. And if somebody does very well or shows extreme interest in academics and research, that's a way to go for government institutions. What about you, Dr. Tanmay? What is your take on the private institutional practices that way?
Am I audible?
Yes, you are.
Okay. First of all, thank you to the organizers for inviting me for this talk. So, like what I did was that after completing my fellowship, I immediately joined in in my institute. So, in that regard, how I was lucky was that there was a vacancy immediately after I completed my fellowship. So I was able to join. So obviously there has what are the how many seats they have, or how many people faculty they are willing to take the institute, that has to be important. But yes, sometimes the promise that you show, that the ability, that the how much you're working and all, is important to determine whether you will be taken up as a faculty, even if there are no vacancies. So what I have seen is some people during the fellowship, they are so research oriented and they work so well during their fellowship. Even if there is not a vacancy, the institute is sometimes a little bit flexible. Okay, this person works well, so let us take him or her into our institute, because a vacancy might develop in the near future, but we might not get this person, and then he might be employed with some other institute. So what's important is, if the people who want to join an institute when they are doing a fellowship, so they have to work very well in that institute for the employers to get impressed. So that is important. And like in my institute at SN Kolkata, it's mostly the people who have done fellowships from our institute only who get in. But that doesn't mean that people from outside SN they get in. There are people employed in our hospital who have trained at Irvin Madurai, at LVPI Hyderabad. So it's not impossible to get train from outside and get into an institute. But then yes, the recommendation and all has to come from those institute to the seniors of those institutes. But yes, the obviously getting into the institute becomes easier when you work in that institute as a fellow or as a PG, and then do the fellowship, and then.
So I think the take home for all the budding ophthalmologists who want to get in private, your surgical skills are more important, your clinical and surgical skills. But in an institutional practice, your academic interest really matters. And that'll take you a long way in showing appreciation towards the institution and them showing an appreciation in hiring you. Okay, moving on. My next question is directed to Dr. Tarjani. Dr. Tarjani, what do you see as the advantages and also maybe some pitfalls in an institutional practice as compared to a private one?
Right. Thank you so much, Devakant, Karan, as well as Anu, for having me here. So just to keep it brief, because we want to stick to time, I'm only going to tell you advantages of both working in an institute in a structured manner versus developing your own, advantages of working in your own private practice, because I have the you might say good fortune to have experienced both. So I did a couple of years of private practice to realize that I'm probably not cut out for it, and then moved on to an institution where I had trained. So the first and the foremost is, what is it that you want to be seen as? What is it that you desire? What is your passion? For me, academic work, which includes both not only research but teaching, were very high on my list. So for you, you need to have a basic understanding of where you want to be 3 years down the line, what you want to be known as to within your peers, and what is it that you want to achieve. So if you're looking at academic growth, both research as well as education, probably an institute ranks much higher than a private practice in that scenario. The second thing would be, now I am an oculoplastic surgeon, and we have a lot of technology that is developing, say 3D printing, say navigation guided surgery. So now when you're looking at these sort of technology applications, and you want to be there at the cutting edge of clinical work in a field like oculoplasty, navigation guided surgeries are the femtosecond of cataract. So it's an extremely impossible proposition for you to have your own navigation guided machine and then do surgeries. But you will benefit if you want to reach that absolute cutting edge of surgery as a junior surgeon. It would be beneficial to join an institute and to work in an institute. So technology is the second point there. The third is projection. Now, there are exceptions to every rule, but your own personal projection amongst the national and the international community is sort of tipped towards, being better projection when you are in an institute compared to when you are in a private practice. The amount of effort you'd need to put into your own CV sort of comes down when you're working in an institute, because there are so many things that automatically get added. You're on so many papers with so many different people, even if you're not the first author, and things sort of tend to get added. The last point on the institutional practice, one of the advantages would be you actually get to focus on matters that you want to focus on. Say I said that, okay, I want to develop myself as a skull-based surgeon, so I'm learning endoscopy, I'm learning skull-based surgery, because I have the technology to do all of that. I have the option of getting experience in that field. I have the option of collaborating with many more people. Versus that, if I was in my private practice, I'd have to be tackling, okay, this machine is not running today, how do I get the technician to get this machine running? And those sort of things sort of tend to take a lot of time of yours when you're in private practice. Now, versus this, four things that private practice offers you is, when you are in a private practice, you're working by your own rules. You're your own boss. You're not dependent on someone else. That's first and foremost. So you set the guidelines, and everybody else, you're the center point, you're the pivot, and everybody else rotates around you. Finances, obviously, if you are in a private practice, other than your investment part, the return of finances sort of, eventually after an X number of years, you'd be probably better set if you are in your own practice. You have convenience of planning things the way you want. You can plan schedules, the time you want to start, you want to end is all within your reach. You plan for that. And the last thing is, you have a lot of flexibility. When you're working in an institute, you tend to have limitation in the amount of flexibility, because everyone is expected to work in a particular way, even if you like it or you don't like it. So I've highlighted 4 points on either side, Anu, and if there's anything else you'd want me to answer, I'd be happy to do that.
I think another point I'd like to highlight in an institutional practice is that we get to see a lot of cases that are probably explained a highly guarded visual prognosis by the private practitioners, because they don't want to take in those cases as there's not much visual prognosis and the fee or the payments are high. So that way we encounter a lot of complex cases, and which especially need a multidisciplinary approach. So we're lucky that way to see such patients and be able to do something for them.
That's very true, Anu. And also, when patients are coming to an institute, they sort of come prepared that, okay, this is the final point. So if things go wrong, it's much easier to explain when you're in an institute versus when you're in your private practice.
That's true. Okay, moving on. Is Dr. Pooja with us?
Yeah, I'm here, Anu. Hi, how are you?
Hi, I'm well. Pooja, I would like to know, how has an institutional practice helped you grow as a leader? You've been into translational research, clinical research, you're almost in every meeting internationally, nationally. So how has that helped you grow as a leader?
That's a very interesting question. And first of all, I would like to thank you and Divakant for having me here. Your question, I would just like to answer in a different way. Being a leader, it's not just a role of an institution. First of all, you have to have it in you that you want to do something, you want to you want to train people, you want to see other people like what you are. I have a very nice, as all my previous speakers suggested, that yes, there's a very important role of an institution which helps you. If you are in your private practice, I would not say it's a challenge, but this takes a back seat in growing in your academics and other things, because you have to take care of a lot of other things when you're in your private practice. And when you start your private practice, you have to take care of your finances, your practice, how it flows, your patients, and a lot of other things. So institute helps you in that ways, because you don't have to worry about a lot of these things, like your practice management and everything in a nutshell. But if you want to be a leader, you just don't have to be you don't have it. Institute, yes, does have a role, but it has to be in you, that what you want to do. You have to have your clear set goals, that yes, this is what I want to be. You will definitely have challenges. It's not going to be an easy smooth highway journey on this, that everything is going to fall in place. It's going to be like a mountain journey, a bumpy ride, and you have to be ready for all of it. You have to have the courage, you have to have the patience, and a lot of other things. So institute helps you in that ways, because you don't have to worry about a lot of these things when you're in your private practice. And when you start your private practice, I would not say it's a challenge, but and a mindset that yes, I want to do it. And if you have that, then your institution is going to help you in all the ways. So apart from what my other speakers said, this is very important that you have to have it in you to go ahead and be a leader, or what. I would not say I'm a leader, but yes, definitely.
Budding leader.
Yeah, I'm not a leader, but yes, I do have a lot of support. And one day I want to do what you all are doing for others, like Namrata ma'am and all of them, what my mentor Dr. Rohit Shetty does for all of them. Then that's what my goal is. So if you are in institute practice, yes, it will help you. And private practice people, you don't have to worry about that. You cannot be one of them. You can be one of them, but yes, you have to have little bit of patience, and your journey is going to be a little bit different than what others have. So
that was
it's
very
just about goal and mindset.
Very well put, Pooja. Okay, my next question is to Dr. Devit. Dr. Devit, you are the Department of Research and Academics head, and you're also in the chief directorial team of EOFTHA. So all of us had mentors, okay, in our residencies, but now you are sponsoring that role of a mentorship. And how is it to train the next generation of young ophthalmologists? How does that feel like?
Hi, Dr. Anu, and I would like to thank Team YOSI for the inclusion. So I don't want to give any authoritative statements. I'll just tell you a small story. So there was this guy, 35-year-old guy in 1980s. He had trained himself in a certain retina practice, and he wanted to start an institute. So he took money from somewhere, and he started a small center. There was one more young guy who was very eager to join him. So he said, sir, I would like to join you. I would like to operate with you. I would like to see patients with you. He said, yes, but you will have to do what I say. He said, okay. 1 week into his surgical training, the senior guy told that you, my friend, are not made for surgery. So I would want you to stop operating, but I see you are very good at clinical diagnosis and you are good at pathology. So he said, I would want to get trained in pathology, and he directed him to get trained in one of the big institutes in the world. Today, the senior guy who I'm talking about is Dr. S.S. Badrinath, the father of Shankar Netralaya. And the junior guy which I'm talking about is Dr. Jyotirmoy Biswas, the father of UVIA in India. So regarding training or regarding mentorship, I just have 3 things. I think a vision has to be there. You need to know what you're looking down 5 years, 10 years down the lane. The second is identification. So I think we have lovely people in the panel who I personally know. Dr. Simmer, he's good at ROP. So his mentor channelized him to develop an ROP center. And that is the reason he's doing so good nationally and internationally. As Dr. Pooja said, Dr. Rohit Shetty found her being good in research and refractory practice. So he just picked her and channelized, and he showed her the way. And then I think we are skilled enough that we would be at par with the people or the doctors in the world. So I think vision, identification, which person is good at what thing. So you need, and the third is channelizing. So I feel if you put these 3 things into practice, I feel you can be a very good mentor. And personally speaking, I have been blessed to have amazing mentors in my life. And that is where I've learned these things from.
I think that is one thing that an institutional practice offers. We have had mentors, but this is our time now to mentor the young ophthalmologists, the present ones as well as the future ones. And that is something I think it's not exactly missing in solo private practitioners, but then the focus actually is something else. The focus is personal brand building, maybe your own financial growth, or I'm not discouraging anybody, but in a government or in a private institutional practice, a key focus is teaching and bringing the young leaders forward. Okay,
Absolutely.
So last but not the least, something that discourages a lot of people, a lot of budding ophthalmologists to join a practice like a government or an institution is the interdepartmental politics, and your seniors not letting you come up forwards or not letting you grow. So how do you overcome such challenges? So I would like to have a take by Dr. Samendra as well as Dr. Tarjini, who are in government as well as private setups. So what are the tips to keeping sane when you're an employee and not your own boss? So Dr. Samendra. Please unmute yourself, Dr. Samendra.
Yeah. So like, we are social beings, and politics is going to be a part of our lives, whether we live social lives, professional lives, or actually real politics. Now, the thing is, which politics do we want to be a part of? Politics is going to be there, negative or positive. Okay, so there are both kind of politics which run in an institution, and it will be there. It doesn't matter how big that institution is. You can have 4 people, and you can have 4 types of political games going on all the time, right? So I think the most important thing is, first of all, what is your identity in that institution? One, how do people see you as? Okay, so if you side with the positive things, with the positive politics, people know that you are the kind of person who will have this opinion on any kind of topic, because that's what you are. So they already know what you will side, which opinion you will support, even before you have given out your opinion. One. Second thing is, and we often say, but we end up getting sucked into it, is not to be part of a gossip, because gossip is something which is actually a good time pass. Probably some sort of a benign gossip once in a while is okay, but sometimes these take a very serious turn, and it has the ability to spiral into something which is much more detrimental for you as a person, your colleagues, and even the interpersonal relationships and the department on the whole. And third important thing is, sometimes we attach too much importance to some things which are not that important in the long run. So there we need to look at the bigger picture, because we all belong to the similar age group. We have joined most of the places. We have just joined as either assistant professors or junior consultants. So we have a long way to go. And right now, squabbling over things that, probably a little bigger office space or a nicer chair or an assistant and things like that. So I think we can just let go of these things and focus on one and the most important thing, which is patient care. So when your patients are happy with you, of course, we are all in institutions, whether government or the tertiary centers. So we have been given that freedom, that liberty to manage your own patient independently. Nobody is going to be interfering in all that. You can make your decisions, and also you have the financial freedom if your patient is able to because the government gives so many resources to design and operate the patient the way you like. Okay, there's nobody's going to tell you don't do this surgery or don't do that investigation unnecessarily or do it unnecessarily. Okay, so if that much of liberties has been given to you, then I think it is best to focus on your patients, your academics, and do keep your residents happy, your PGs happy. And the only way you can keep them happy is by teaching them, by learning. If they learn from you, they're going to sing songs about you, and that is the best thing at the end of the day. And one last thing, just to sum up, is align yourself with the philosophy of the institution, which is often similar to aligning yourself with the head, because the vision of the head is what is the philosophy of the institution. So if you should identify that whether your philosophy aligns with that or not. If it doesn't, then probably you are in the wrong place, because if you align with that philosophy, then everything else falls in place, because rest of the crowd will have to align with that philosophy one day or the other.
That's very nicely expressed, Dr. Samendra. A short and brief take, Dr. Tarjini, before we wrap up.
Yeah, thanks. Samendra really brought out all the points, and probably if I just had to reword some of them, it would be, the first thing would be to align with the institute policies, because when the management knows that you are, put up those policies with some sort of a goal in mind, and when you align yourself to those, you're immediately putting away the unnecessary trouble that might come your way, so you are more focused on your work. The second thing would be, choose your battles. There are 10 things you could fight about, but are they going to make a difference? Versus that, if you're quieter on those things, if you accept seeing a little more patience, putting in a little more hours compared to somebody else, but in the long run that will help you, because then you're in a position to demand for things, because you've already set a record for things. The third thing would be to be absolutely ethical. There are no shortcuts to patient care. You would have to work out things in the ethical way in which it is done. And when you are ethical, there isn't much that people can really point out in you as a mistake. And the final thing would be that you have to be very clear in what you want. So you need to have expressed that the day you have joined, that this is my 3-year or 5-year plan, and then everybody knows that the way you are working in a particular fashion is because you want to achieve that, and they would all help you in reaching that target. So those would be the points from my end.
Thank you for your inputs, Dr. Tajani, and I thank all the panelists for such a wonderful discussion. Just to summarize, I think being your own boss is the best thing, but it's all about priorities, what you want in life that will help you decide whether to go into a government or an institution or a private or any other practice. Over to you, Devakant.
Thank you, Anu, and the panel for that wonderful session. So the next session is on the corporate sector, and I would introduce the moderator for today's evening, Dr. Avanish Upadhyay, who is a VR consultant at IQ Hospitals in Gurgaon. He is also the treasurer of YOSI, and he is the brainchild behind the YOSI flash notes and the late night retina, the very successful program of YOSI. Over to you, Avanish, to take over the program.
Thank you, Dr. Karan, for this nice intro. I'll just start sharing my screen. Just 1 second. I'll just get to it. 1 second, Karan. Is my slides visible, Dr. Karan?
Yes. Yeah.
So we can start on this.
Your slides.
Yeah. So my topic for discussion today is career in ophthalmology roundtable corporate sector. Actually, what we discussed we had this discussion in the previous session of institutional practice, and when we actually thought about going into this corporate sector, we had a discussion whether there is a blur or whether institutional practice and corporate sector practice is more or less the same. So, or is it a boundary which is like the difference between these two is blurring? So let's get down to it. For us, we have this esteemed panel today. We have Dr. Sharath Hegde. He's a consultant at Retina Services at Prasad Netralaya, Udupi and Mangalore. He has done his fellowship in Retina and Uvea at LVPI. Then we have Dr. Divya Kishore. She's an associate consultant at Center for Sight Group of Hospitals, New Delhi. She has done her post-graduation and senior residency at MAMC, Delhi. We have Dr. Ashray Nayak. He is a faculty VR services in Eye Foundation, Coimbatore. And he's also a consultant at Medical Legal Services at CLAMP, that is Center for Legal Awareness and Medical Policy. We have Dr. Kaushik Tripathi. He's a consultant retina, uvea, and cataract, and consultant in charge at ASGI Hospital, BT Road, Kolkata. We have Dr. Ankit Vinaya. He's the medical director of specialty hospitals all over India. He has done his training from AIOS Kolkata and specializes in anterior segment and oculoplasty. We have Dr. Prashobh Mohan. He is a consultant cornea and refractive surgery, Chaitanya Eye Hospital Research Institute, Trivandrum, and he has done his fellowship in cornea and external eye disease from RIO Bangalore. And finally, we have Dr. Amit Pandey. He's a senior consultant at Center for Sight Hospitals at Gujarat, and he has done his fellowship in glaucoma from Shankar Netralaya, Chennai. So coming to the concept of corporate hospitals, and we have actually subdivided this topic into 4 different things as to why. First topic would be why we have to choose corporate jobs and how to go into it, and then how to sustain into a corporate sort of a job, and when do you actually find a time, or when it is actually a time for you to switch, you have to get into your private practice, and finally we'll just have the job portals which we kind of have it here. So coming to the first question which we have as to why to join a corporate practice and what are the advantages and perks. I would like to ask this question to Dr. Amit Pandey, Dr. Ashray, Dr. Ashray, and Dr. Ankit and Dr. Divya, if you can answer these questions, please.
Yeah, am I audible?
Yeah, Dr. Divya, you can.
Yeah, so thank you for the question and thank you for this opportunity, Yosai. So I feel that a corporate practice gives you the best work-life balance. You will probably be one of the only people of your specialty in the hospital. So there will be a referral system in place and all the patients will come to you. And you have the ability to, really rise in your field. Also, most of these corporate hospitals give you conference aids to go and present your work, so that is an advantage. And private practice, if you have a private practice and you need to take leaves, then that means, like closing shop. And in government practice, there is so much of red tapeism. So I feel that corporate practice gives you the freedom to work as you feel, choose your own work hours, and also gives you a cushion to fall back upon. Like we have seen in this pandemic, many people who had their own private practices had to, really suffer during this time. So I feel that corporate sector gives you a cushion from all of that.
Dr. Ankit, if you can give us.
Yeah, good afternoon. Thank you, Dr. Avnish and Dr. Devakant for the invitation. Just building on the previous speaker's point, you get good facilities, good equipments, you get cashless facilities, which is a very, very important, hindrance in bigger towns and cities, when it comes to practice. You get good remunerations, I feel somehow, since childhood, we've been taught that this is a noble profession, and speaking about it, remuneration is a big sin. I think it's time, we get over it and put this on table. So, you get good opportunities, good remuneration. It occupies lesser mind space, and I have experienced it myself since I have been into private practice for almost 2 years. So it's much lesser mind space, which translates into more time for your life, more time for your hobbies, for your interest and family at large. Lesser energies are put into the smaller roles like housekeeping, OT maintenance, procuring stuff which are taken care by biomedical and other departments in a corporate hospital. So this again translates into more time for your surgeries, more time for your patients, more time for academics. So these are a few of the points. And most importantly, if utilized correctly, this opportunity could be a good stepping stone for someone who is looking at eventually landing into private practice, because he would get acquainted to the systems in a corporate hospital, systems like EMR, electronic medical records, the HR policies, and the other policies, the various departments, which work together, to kind of make the bigger machinery, a well-oiled machinery. So this could be a good learning opportunity for individuals, who plan to take on private practice later on in their career, later on in their life, if it is utilized properly. So this would be from my end. I think these are the advantages or perks maybe of getting into a into a corporate practice.
Dr. Ashray, if you can put in, since you have been working for a long time in corporate sort of a setup. Yeah. Dr. Ashray? Is Dr. Ashray here? Dr. Ashray, you need to unmute yourself. Dr. Ashray? Okay, we'll go on to the next question. I think we'll come back again. We'll go on to the next question, where we actually want to know what are those pointers which you look forward when you want to join a corporate setup, and can someone actually join in straight into a corporate straight out of from some training or from fellowships. So for this, I want to ask Dr. Amit if he can give us some insights into this question. Dr. Amit?
Good afternoon. Am I audible?
Yeah. Yes.
Thank you, Dr. Avnish and YOSI for the invitation. For the first part of the question, pointers one should look for before joining a corporate setup is to do a little bit of market research in terms of you can speak to the doctors who are working there, as well as doctors who have recently left from the place that you are planning to work. That will give you an insight of what it would be like to work in that corporate sector. Try to understand the condition, the financial condition of the corporate, because ultimately it's a company and it's a corporate setup. So who are the investors like? What is the backup of the corporate setup, the financial condition of the setup? Which centers are doing well, because most of the corporate setup would have multiple centers even in a single city. So which centers are doing well, and Also try to look at centers if they have closed down a few centers recently. So these are the pointers that you need to first see before joining a center, a corporate setup. Coming on to the second part of the question, can someone join immediately after their training or their fellowship? Yes, of course they can. I did. 5 years back when I joined a corporate setup, I had just finished off my fellowship from Shankar Nethralaya. But yes, if it absolutely depends upon what kind of skill sets you are having, what has been your training in the past, and if you are confident enough to do what is expected of you independently, yeah, you can join a corporate setup immediately after your training. But we need to keep one thing in mind is that you will be your first impression would be very, very important. I remember the first FACO that I did days into my job. I did it in 12 minutes, and that was communicated to the director of the institute. So your first impression would be very important for you to grow in that corporate setup, because of course it in a corporate setup things are a little more cutthroat than the other types of practice. So it's very important to make a good impression, a first impression, and that will make you stand out from the crowd.
Thank you. Thank you, Dr. Amit. Dr. Kaushik, can you put in some insight since you are a practicing retina person? So what do you actually look in for a corporate setup? How do you actually go about looking for a corporate sort of a setup for your practice, for your subspecialty?
Thanks, Dr. Avnish and Dr. Divakan for having me. Actually, when you are joining a new setup, I think the first thing which I ask is what the salary would be. Like, is it a competitive salary? And obviously, the person who is joining should do some research about what should be a good salary for his experience and his expertise. And also look at the history and profile of the corporate, how they have behaved in times of stress specifically, and how is their financial stability. That is very important. Also look at the surgical OPD and investigation setup and whether you are comfortable with that. When a new joiner is joining, then he must ask who will operate. That is very important because this is a surgical specialty. When you are joining, you have to ask your employer who the patients who you see, you advise surgery, who will ultimately operate that patient. And if you are not given the chance, when probably you will be getting a chance to operate the patients whom you are seeing. That is very important, and that is one of the most common cause of dissatisfaction, and then you may have to leave the job for that. And also you have to look at what is the work environment. People are very important. The place where you are joining, how are the people, like how are they good, are they positive, are they encouraging? And also you should ask the employer about the leave policy, how many leaves are available and how you can take an emergency leave, and also about Sunday duties, whether you have to work on Sundays or this is very important. And most of the corporate setups have multiple setups in a single city. Then if they tell you that you have to go to multiple setups, then you have to clarify which centers you have to go and when. That is very important because sometimes you may feel like you have to go to this center in the morning and then to another center in the evening. That may become very tiresome for any surgeon. And also appraisal, how frequently they'll increase your salary and how much do they usually increase the salary. That is actually an important thing which you have to ask. And many centers, they tell the salary is less, but you will get high incentives on this and that. But you have to ask your mentors or the seniors who are already there and get an idea how much is the actual incentive looks like. Also, mostly important thing.
We'll come to this question in the next set of question, where we are actually looking at what are the corporates actually looking into their employees and what are the preparations required for the interview, and how do you negotiate about going with the salary. Do we have Dr. Ashray here? Is Dr. Ashray here?
Yeah, I'm here.
Yeah. So can you tell us about this question, please? because a lot of questions would definitely be asked about this. So can you tell us, and how do you go about with this?
See, basically, corporates, like for most of us, the majority of the employment is generated by the corporate sector as of now, and a lot of investment is flowing into the ophthalmology. So now for the investors, ophthalmology is the darling, and a lot of investment is flowing. So corporates are generating a lot of opportunities for ophthalmologists. So the like most of us will have more openings in corporate setup than in institutional setup or in a government setup. So we have to be open to this idea. So in fact, the corporates like Vasan and Agarwal have contributed a lot to improving the general remuneration level of ophthalmologists. So we have to be very thankful for that. But again, like they are looking specific things. One is before an interview, before they employ you, and one after they employ you. So before they employing you in interview, there is hardly anything they can assess. Based on maybe they can look at your qualification, from which institute you are coming from, or which what kind of academic career you had. That is all they can assess. Maybe a little bit of attitude towards the ophthalmology and your body language, and little bit of aptitude can be assessed. But the real assessment actually happens after they employ you. So a lot of these corporate setups have like a week to 1 month observation kind of a session where they try to assess you based on your skill and your attitude towards ophthalmology. And basically they are looking at whether they are in sync with the philosophy of the overall institute or not. But ultimately, this is what they are looking at, because they want you to be individual practitioner who can execute all the skills. Like whereas in institute, for example, premier institutes, some people leave their candidates to operate macular only after 3-4 years after they start doing VR services. But in corporate, if you are good enough and if you are confident enough to execute that skill, corporates don't want to hinder you. So that is what they will try and push you to even train you also to give you that skill so that they can execute that procedure. So there is like that is what they want you to be, whether they are you are trainable or not, whether your attitude towards the business of ophthalmology is good enough or not. And of course you have to be very skilled. That is the most important prerequisite for any employment, and that is what they are looking for.
Thank you, Dr. Ashay. Just a quick from Dr. Ankit, if you can give us a couple of more pointers on this point, and then we can move on to the next question.
Yeah, so just building on what Dr. Ashray has just mentioned, as he correctly mentioned, your basic skills, your surgical skills are of paramount importance when it comes to your interview or when it comes to getting an employment into a corporate hospital. But apart from that, there are finer aspects like your soft skills. They try to look into your confidence. They try to look at your body language. They try to look at how flexible you would be. Whether you are a team player or you are an individual player, that is very important to a corporate setup because there are a certain set of policies which they would want you to adopt. So it's very important that you are flexible enough to kind of adopt to those policies because you're joining an organization. So it is up to you to kind of be flexible enough to be a team player, to adopt the policies. And also one very important point that they try to assess is when it comes to soft skills, that how would be your patient compliance? How would your patients take up to the advice that you give to them? Suppose, for example, if I'm advising a patient for a surgery, whether the patient feels confident about getting his surgery done by me or not. So this is one of the most paramount, value that they're looking at. So that is what add values to the organization, overall organization. So these are some points in addition to what Dr. Ashray has just mentioned, previously, which I feel are very important and which are very closely, keenly looked at by the corporate hospitals while employing an individual as a consultant.
Dr. Sharath, can you give us some pointers for negotiating a salary during the interviews?
Thanks,
Very
Amish,
happy to
Yosi, for this opportunity. Yeah, as other people said, yes, corporate is a setup where it's like most of them, if we finished our all our fellowships are from a premium institutes and we want to come out. And sometimes we have to see whether we are going to the metro cities or to the second tier or third tier cities where we have a corporate setup, and we are still not confident to do our private setup. But we need a setup where we can show our skills, because now we are confident of coming out where we have our skills and we are confident of doing our surgeries or what our skills, what we are expertise in. And we require the setup also where all the equipments are there and these things are there for
Dr.
this.
Sharat, just to the point of negotiating a
Yeah,
salary,
yes,
I
sir.
think the other points have been covered
So
somehow.
when you are negotiating a salary,
Running
these
out
things
of time,
become
we need to
important.
finish it, and so kindly stick to the pointers which we are actually asking. Yeah,
Yeah,
please.
sure. This thing. So when you are negotiating a salary, these things becomes important, and you should be confident in your part of it, where you are. They will see what is your digital skills are. So when negotiating the salary, you always think that you can able to generate how much percentage above this what they are paying you. So that if you show that thing, then you have to negotiate on that point. And second thing, you should also show that how much the patients you can get back. So whether you're a localite or whether you're some other places and all, which will help you to negotiate a salary. But always don't negotiate to the minimum amount. Be confident how much you are getting.
Thank you, Dr. Sharath. Now, coming to the part now, we have actually got into a corporate job, and now the problems comes with sustaining a corporate sort of a job. So the first question which actually comes is, what are the skills required or the prerequisites to excel in a corporate sort of a job? And is there anything like human relationships or marketing skills or networking skills that are actually required? I would want to ask this question to Dr. Prashobh if he can give us some ideas about this. Dr. Prashobh?
Yeah. First of all, thank you, Yosi, for having me here. Thank you, Avanish and Divankar. And regarding the skills that are required for, I think the most important skill is the communication skill. How you communicate to the patient and how clearly and lucidly you can put your points across to the patient, and not just to the patient, to your colleagues and to your co-workers and to those who work under you. So that is, I think, very important because I know many people who may not be very great clinicians or surgeons, but have a roaring practice because they have good communication skills. I think that is the number one thing. Interpersonal skills and communication skills are the number one thing. All the rest comes after that. Of course, your surgical and clinical skills are important, but the number one skill, I think, is communication skill. Nowadays, with the advent of EMR and all, we have seen that there is a problem that when the patient enters your room, you're most of the time, if you have a lot of patients, most of the time you're looking at the screen and not looking at the patient. So I think those kind of soft skills that are very important. I mean, it makes a big difference. Just imagine that you are the patient and you see someone who's looking at the computer screen and talking to the screen rather than looking into your eyes and talking to you. So those kind of small things, I think, make a big difference. The patient will feel much more, that the patient will feel that the doctor is more in tune with their problems if you actually look at their face and talk to them directly. So those kind of skills, I think, are very important. Then the second thing is, if your practice is mostly dependent upon reference, if you are working in a sort of a corporate institute where you need a lot of referrals from other doctors, it is important that you also project yourself. You present in conferences, present in CMEs, and you have to blow your own trumpet to some extent, because people who refer to you should know that you are skilled enough and you can handle such kind of cases. So I think that kind of soft marketing is also required. You need not go shouting from the rooftops that you are the best, but people do come across. People do get the word spreads quite easily. You do have the reels, and again, I think word of mouth publicity is the best publicity that you can get, rather than any advertisements or anything.
Thank you, Dr. Prashobh. Dr. Divya, if you can add some points to this, couple of
Yeah,
points.
Dr. Prashobh has brought forward very good points. Something which I would like to add is, like, in today's era, marketing yourself is very important. So maybe you can have something like a website of your work, or where you can have reviews from your own patients, So that helps to project yourself better. And obviously, like Google reviews and these things help the patient to, like really know you before they even come to you. Because nowadays, before going to the doctor, patient has already Googled you before they've come. So if you have a website of your work or if you have reviews, so that helps for the patient to have more confidence. Ultimately, how you talk to the patient, how you can have the patient have more faith in you, that is how you can have good human relations with them.
Thank you, Dr. Divya. We are running short of time. I will go to the next question. So now, since one other aspect of sustaining your corporate job is how to ask for promotions and remunerations in these setups. So can we have Dr. Amit, if you can talk about this, please. Dr. Amit, give us
Yeah,
a...
see, a good thing about corporate or a bad thing based on what situation you are in is that they have data for everything. They have people working day in and day out on working on data. What each center is, the amount of revenue that each center is generating, or in fact each doctor is generating. If you can get a hold of that data during the time of your appraisal, you can reflect on that, and based on that, if you feel that the appraisal that you're not getting is if you're the appraisal that you're getting is not good enough, you have to speak up. You have to talk to the authorities. You have to speak up. Just suffering in silence is not going to make things good for you. And from the initial point, yeah, you have to have some patience. But yeah, once you have developed your practice into such a way, in such a manner that you are in a position to demand things, yeah, you have to speak up, and only then you will be getting good appraisals and all. So that's one thing I would suggest. But yeah, you should not be very aggressive also. That could lead you into trouble. Like I told, you should have that kind of a work behind you, that you are in a position to demand things from the corporate sector.
Thank you, Dr. Amit. Dr. Sharath, if you can put a couple of things into this.
So as Amit said, yeah, they'll be having all the data of what we are doing and all. So we should always, while asking for remuneration, we should speak up that we have generated this much of income. Yes, because the corporate people require that. So always for promotion, we should show that we have done so many surgeries and we are getting the patients, and we should always speak up, and we should say that this much of salary we should get, or else like, because what they will try to do is they will try to negotiate with you, or if you want to speak up.
Okay, Dr. Sharath, thank you. Now, coming to one of the other points, which is most important, how when during the corporate job, can someone continue with their academics and research work? I think the best person to answer would be Dr. Kaushik here. Dr. Kaushik, if you can give us some pointers on this.
No, point is, like common people think that if you are going into a corporate setup, you will have to stop academics and you will be only doing clinics, but that's not true. In USA also, most of the established public authors are doing private practice and they are also attached to the institute. So you have to keep your mind open, document cases, and also, though the patient load is low, you can report, definitely see rare cases and try to report them. Also, there are multiple online opportunities there. I'll invite all of you to please look into the IVQ website of American Academy of Ophthalmology, which gives a fair chance for all of us to represent, and you can actually write and contribute there. So that is a good start for all ophthalmologists, and also online classes, programs, and involvement in journals will definitely help. Thank you.
Thank you,
I
Dr.
would just like to say here, to this point, Dr. Avnish and Dr. Devakant, both of you are very keenly involved into academics and at the same time part of corporate hospitals. So, you are standing examples for the question that you asked, So I think anyone attending this conference would not have any kind of doubts when it comes to that.
Thank you, Dr. Ankit, for this kind words. We'll move on to the next question. I think, what are the long-term perspectives of actually in corporate setup? Do you actually want to continue, and how to go about with it? Dr. Prashov, if you can answer in just couple of points, and then we'll have to, because we are running short of time, please.
I think the long-term perspective is corporate. I mean, finally, the way everything is moving towards in India, you will have the few, in the end, few corporates that are going to take over almost everything. So that I may be wrong, but that's my view, that you have to be ready for the corporate setup. The other thing is, when you're entering a corporate setup, you're leaving your comfort zone, and which means that you cannot rest on your laurels. Like, you will not get automatic promotions or anything. So you will have to keep reinventing yourself, keep adding value to yourself if you want to get promoted, or if you want to rise up in the ladder. There will not be any automatic promotions, no free lunch corporate setup. But I think most of the people will end up in a corporate setup, so they have to get prepared. As we discussed before, they are the highest employer. They employ the most number of people. So we have to get ready, get geared ourselves towards living in this corporate setup. I think that's the future.
Thank you, Dr. Prashub. Dr. Ankit, do you want to add something to this, or we'll move on?
Yeah, I would like to just add a few points here. I think, I've always said this, that, our medical education system is, kind of does not completely makes a person ready for life and success in life. I would just say that it contributes to 10%. Remaining 90% acquiring all the other skills are very important to be successful, in life. When it comes to corporate, moving ahead in ladder, in corporate ladder, I feel for looking at a long-term perspective, you could look at contributing more than your clinical work, get involved in managerial works, create value for yourself, and be open to kind of creating value by taking up tasks like, maybe, for example, training of counseling, clinical counselors, training of optometrists and other staff. So that is how you add value to the entire organization. Moving ahead, you could look yourself as owning a department in a corporate hospital, by being a medical director, reaching to that position where you can make more difference, you can add more value, and eventually, being one of the partner doctors. So these are the ways ahead, so I don't see an end point there. I see a continuous growth and progress for everyone in corporate hospitals. And as rightly said by my previous speaker, moving ahead with the corporatization of entire medical field, this is the way to go. With all the accreditations, which is going to be very, very difficult for an individual to achieve, with health insurances and cashless becoming a norm, which again would be a very steep task for individuals. So it's very important that, we are open to this idea of getting into corporate and moving up the corporate ladder. So that's from my side.
Thank you, Dr. Ankit. Now, just moving on to another question. What are the cons of corporate practice? Dr. Asha, if you can give us a couple of pointers, and then we'll move.
Yeah, just that there is a lot of negativity about corporate setup initially when you are finishing your fellowship or anything. So we are not very accustomed to this concept of profit. Profit is a good word, but unfortunately in our education and upbringing, profit in healthcare is seen in a very negative manner. So we are not well versed with lot of details in ophthalmology. So like as a VR surgeon, you should know the cost of every consumable which you are using. And you should know the entire gamut of profit. Like, for example, something known as EBITDA, you should know that, because that is very, very essential. EBITDA of 35% and profit after tax of 25% is what the corporate sector is looking at. And if you are not able to deliver that, they will move on. There is already enough talent in the market. If you are not delivering, someone else will deliver for them. So it is very, very important. You need to understand these concepts, but you need to also be aware that no one can hold your hand and make you do unethical things. You still have to do it yourself. So it is very, very important to have a very high ethical standard and be entirely updated, because in retina there are so many things which people miss on clinical diagnosis, and so the treatment goes, the patient doesn't get treated. So if you use your clinical acumen and if you do things normally only, you'll be able to deliver a lot of things. And in the background of the knowledge of all these terminologies, cost of consumables and all, you will be able to make a very good career out of ophthalmology. But if you don't understand and if you are behind remuneration, so my previous speakers talked about remuneration. Actually, we should move away from remuneration, fixed remuneration. There should be pay for fees, and you should have some percentage out of everything which you do. Otherwise, there will be no justice served at all. Because
we are moving, we are losing time. This last question: when can one switch to? When can one switch jobs, or when one feels ready to do private practice? Dr. Divya, just one line from you, please.
Yeah, so there can be two scenarios. One in which you're really happy at your position and you feel that you have risen high enough. So now you have a good client base and you can have your own practice. So in that case, you can shift. Or either you're unhappy with your situation and the line of the institute is not in which you want to grow with. So in both these scenarios, I feel that you are ready to switch your job.
Thank you, Dr. Divya. I think we'll sum up this session, and we just that wanted to add that we have a couple of job portals. Which one is the AIOS has it on its webpage. You can directly link it, and then we have this YOSI job portal where you have one form where we can actually put in the vacancies in the hospitals which are present. And the second thing is we can actually put in our CVs to this portal, and we will try to get you a job, or possibly we'll try to send your details to someone else. Thank you so much. I think that is it from my side. Dr. Karan, Dr. Devakant, if you can take it from here. Thank you, the panel. Thank you.
Thank you, Avanish and the panel for that excellent session. So the next session is on international opportunities, and I'll introduce our moderator for the session is the legendary Dr. Akshay Nair. You know, he's very famous and he's an excellent orator himself. He is also an executive member of YOSI and is currently practicing at Aditya Jyot Eye Hospital, Mumbai. And he is also the recipient of the annual YO Award or the YOSI Award 2021. Over to you, Dr. Akshay, and please take over the session.
Thank you, Karan. Thanks, Karan. So I have a very illustrious panel over here. But at the outset, just to give you a clearer idea of what international opportunities is. So our panel here is widely experienced across different geographical areas. And the aim of this session for me as a moderator is trying to highlight and bring out the pros and cons of international training opportunities as well as employment opportunities abroad. We're going to look at what things need to be done from the point of view of an observer or a trainee to be able to go abroad, what their experience was, the panelists' experience was, and just possibly in case you had that small seed in your mind, maybe I think I should think of going abroad either for training or for practice. This session should add a little more clarity to that. Our first panelist is Dr. Aarti Heda. She's a fellowship-trained cataract refractive surgeon. She worked in Pune and then went on to work in Africa, in Ghana and Uganda. Incidentally, she's also a fellow of the College of Ophthalmology of Eastern, Central, and Southern Africa, and a fellow of the Ghana College of Physicians and Surgeons. She's been a pioneer of glaucoma shunt and keratoprosthesis surgeries in Africa. Our next panelist is Dr. Apurva Gore, who completed his training from Guru Nanak Eye Center in Delhi, and following senior residency in retina, he's been working in the UK as a specialty doctor in medical and surgical retina with the NHS, and currently is on a year-long sabbatical to do a fellowship in retina and uveitis at Bristol University. Joining us also is Dr. Preeti Patil Chablani. She is a gold medalist resident during a DNB at Shankar Nethralaya, where she also completed her fellowship training in pediatric ophthalmology and strabismus. She did a fellowship again at the Shailya Institute in San Diego, then came back to work as a faculty at LV Prasad, Hyderabad, and now has gone back to the US, where she's now working as an associate professor with the University of Pittsburgh UPMC Children's Hospital. Our next panelist is Dr. Manju Meena, who's an oculoplasty and oncology surgeon. She's currently working at CMER Dennis Lam Hospital in Shenzhen. She was trained at LV Prasad and Maulana Azad Medical College. Following that, she's done an international fellowship at Sydney Eye Hospital as well, and then came back to Jaipur to work for a while before moving on to China. If these stars weren't enough, we have Dr. Sumit Grover, who is who has a master's in public health from the London School of Hygiene and Tropical Medicine. He's an outstanding ophthalmologist, academician, and a public health professional, and has recently been awarded with the prestigious Eye Health Hero 2020 Future Leader Award by IAPB, and also the Hooper Prize for the best research from International Center for Eye Health in London. And he'll be telling us about his experience of taking a slightly different path after ophthalmology abroad. Also joining us is Dr. Shrikant. Dr. R. Shrikant graduated from Madras Medical College, and he was trained at Shankar Nethralaya in Chennai, where he also worked as a consultant till 2017. He then moved abroad and worked at CMER Hospital in Hong Kong and Shenzhen as a pediatric ophthalmology expert for 3 years. And now he's come back to Chennai, where he works as a senior ophthalmologist at Apollo Hospital. And the crown jewel of our panel is Dr. Anirudh Agarwal, who is I mean, probably everybody knows enough about him. I asked him for his CV and I requested send me the short one. His short CV was 30 pages long. He's trained in vitreoretinal fellowship from the Stanley Trulson Eye Institute in Nebraska. He did his post-graduation training and currently is at PGI Chandigarh. He's been a co-investigator in 5 studies and trials. He's been the principal analyst and investigator and principal reader in 7 studies. He has 241 publications, and he is not sitting with, or he's not happy with all of that. And he's currently enrolled as a PhD scholar, and he'll be adding a doctor in front of his doctor already. Is that right? Okay, so the panelists, please unmute yourselves. And my first question is to Preeti. Preeti, you've had a training experience in India, a training experience abroad, employment in India, and employment abroad. What do you think is the biggest change in terms of both as a trainee and as a practicing ophthalmologist? And firstly, thank you so much for staying up at 3 a.m. in Pittsburgh on a weekend. I apologize.
You'll pay for this in some way, actually, at some point. But honestly, thank you for the chance to speak here today. So the question is quite interesting. You look at it with very different perspectives as a trainee, and then very different perspectives when you're actually practicing. As a trainee, I think it's a great idea to get some international exposure under your belt, especially after you have trained in India in what's considered sort of our prime institutes. It gives you an idea about where the world is going, where you stand, what you want to do in terms of your research. It basically opens your eyes to a lot of things, not just ophthalmology, but outside ophthalmology as well. You see how you conduct yourself. You go to a couple of international meetings. You really see how the world is sort of performing on that stage, and that gives you targets you can set for yourself. So as a trainee, I think it's a great opportunity if you do get that chance to go abroad for even a few months. It really helps. As later in your life, there are usually specific reasons you choose to leave the country and go back or to go abroad. They could be related to your research, or you're just feeling sort of stagnant where you were. It could be remuneration. So again, that perspective is very different. So it would be a very personal decision based on, at what stage of life you are in, if you were to move your practice abroad.
Yeah, but say, for example, work-life balance here versus there. And, small things like that. Those things obviously play a role in, switching. So do you think there's a better scope for work-life balance there and things are more sorted out and compartmentalized, or do you think you had better work-life balance here?
So again, that's not something you think of as a trainee at all, because you know that this is my fellowship. It's a 1 year thing, and I have to work, give it my whole. You really don't think of those aspects when you're training. But when this is a long-term sort of a plan, then that becomes really important, especially if you have a family, young children. Most of us are at that stage in life where you are trying to get ahead in your career, but at the same time have family responsibilities. And I do feel that there are challenges both places. So, for example, in India, I feel we have a better support system. You're likely to have your family, you're likely to have other help, which may not be available to you in a foreign country. So, it depends where you are and what it is. But I do feel, and I may be wrong, and I'd be interested to hear what everybody else feels. I do feel that it's more compartmentalized, to use your term here. They are in terms of there is more respect for your personal space and time, and you can choose to say that this is my family time, and by and large, people will respect it. So I think if that is something important to you, you can make it a priority and stick to it.
Right. Now I'm going to pick your brains, Manju and Srikanth. Both of y'all have had experience in China. A couple of things, for someone who's looking for an employment opportunity, Dr. Manju, what does China require some additional qualifications? Are your medical degrees valid? How is the surgical practice there? Are you in a private practice or a government-run hospital? Things about China are not really that clear. So how is China as an option for people to explore for employment? And how has your experience been?
Thanks, Akshay, and thanks AIOS and USC for having me here. So the question is, see, first thing I would like to say that the good thing about it is that you don't have to give any exam or sit in for any work permit exam or something like that. No language exam is needed. But since I'm working in it's a private hospital, which is a leading hospital in China. And but I think in other government setup till now, Indian doctors and foreign doctors are not allowed to work or something. In fact, the employer, our employer, he has made some arrangements for us to, to recruit. It depends on your CV and how you apply. All those things also matter. So it's more of, very few people have explored this area, and there are very few Indian doctors are working, especially in ophthalmology, only in this hospital. But rest of the China, most of the doctors are Chinese, and Chinese national are preferred here.
And what about the language barrier? Srikanth, did you also have, since you were also in China, do you have translators all around? Do you have some app? Is that like a barrier when it comes to patient communication or surgeries?
Yeah, absolutely. When I landed, thank you, Akshay. First of all, I would like to thank you for having me over. Basically, when I landed 3 years back in China, it was like I had been to a completely different planet or something, because the food was different, the language was a barrier, the culture was completely different. So it was a total mismatch between how I've been living all my life and to where I landed up. So as far as personal adjustment itself is concerned, it took me some time to get used to the place. Apart from that, the place where I was working as is Dr. Manju, it's a private setup, as she rightly pointed out, and they do provide translators or interpreters for you. So that is something which is taken care of. So you don't have to interact with the patient directly. A few of them know English, but most of them, about 90% of them, even if they know English, they would not be speaking in English. So as I practice pediatric ophthalmology, most of the times I wouldn't require to directly talk to the child unless they are maybe more than 5 years of age. Most of the times I would just require to show them actions or something and then get their attention. Treatment wise, or when I'm counseling them for the surgery or something, I actually train my interpreter in such a way that whatever each and every word that I speak to has to be translated, and nothing should be deleted or added to what I say. because we don't know what exactly they say. But by the end of 1 year or 1.5 years, I kind of knew what they were saying. Each sentence of mine was being translated as the way I wanted to. And that is the time I kind of realized what they're saying. So you need maybe a year or so to get used to the whole setup. But after that, you should be fine.
Speaking about different places and different cuisines, yeah, for a vegetarian from Chennai to go into Shenzhen can be a little bit of culture shock. I'm going to come back to you about what made you decide to come back. But before that, I want to go to Aarti. Dr. Aarti, your choice of workplace was unusual. Any reason? Can you give us a background on what took you there? Africa is not some place that is explored by many. What took you there? How was your experience? And again, for the average viewer, if they want to explore that place, say Central Africa and Western Africa as employment places, what are our degrees valid? Is our training sufficient?
So thank you, Dr. Akshay, for that question. So I have 2-3 questions to answer. So let me start one by one. What made me to go to Africa was I did my fellowship from Narayan Netralaya, and I had very few options that time. Either I could have joined NN or I could have joined any other organization. So my fellowship guide gave me a very good tip. He said, if you join here, you will still be a fellow. Once a fellow, always a fellow. You may not get to do tough cases. You'll be always called as junior consultant, and you will definitely be referring all tough cases to me. So I realized that NN is not my option. And I wanted to find out really that am I trained enough to handle all complication of my own? So I was working with Dr. Agarwal's Eye Hospital. I joined them, and within a month they asked me if I know all these surgeries, then why am I sitting in India? I should go and work somewhere else where I can explore more. So going to Africa was a very tough decision. I'm a vegetarian, a Marwadi girl, a single female. So many questions in mind. How will I survive and all? So my father was a great motivation at that time. He said, what will happen? Maximum you'll come back. So I did my homework. I realized that a country of 3 crore population, handful of ophthalmologists, let's say 60, 70 ophthalmologists. So of course the competition is going to be very less. And there was lot many things to be done in that country in terms of surgical work. And so I decided, okay, fine, let me just go for 6 months and see how it goes. So I went to Ghana and I had to go through a process. Since we are already an ophthalmologist trained in India, they accept our degrees. So I was in Ghana for 3 years and I was in Uganda for 6 months. So I had to give an interview, and after interview, they asked me to do attachment in a teaching hospital. So the teaching hospital was actually very well equipped, but there was no surgeon to operate. So they were not even doing SICS, and that was the second biggest teaching institute in the country. So I was there for 6 months, let's say a few hours in a day, but I got good opportunity to show my skills there. I made good friends, and they were actually a very big referral source for me for rest 3 years. So it was like I used to get reference for even a cataract surgery. Phacoemulsification was very rare thing that time. So and nobody had done multifocal trifocals over there. So it was like I had so many things to do there. And beside that, I was asked to head a branch and managing the administration and the business aspect of it. So there were so many things which I got at one go. So it was as if I'm starting my own practice, but with somebody else's support in terms of finances. So it was actually a very good opportunity for me.
That's wonderful. I want to switch to Dr. Sumit. You after ophthalmology, I know you've been involved in a lot of non-governmental organization projects as well. Manthan is your child. What made you choose a branch that is not seen as a natural progression of what you do after post-graduation? And how was your experience there?
Yeah. Thank you, Dr. Akshay, for having me here. Thank you, Devakan and Team YOSI. It's a very good question, and I think it's the most frequently asked question for me, that why you choose community ophthalmology, which, as you said, that it's not most sought after thing, but I think it's I made like that. It's like a manufacturing thing in my brain, that I was always inclined towards the community ophthalmology, and in fact I joined Opthal because I found that this is the only specialty in medicine which has the perfect blend of medicine, surgery, and the maximum community involvement or interaction, you will say. You will not find that there are camps for stents, there are camps for neurosurgery, there are camps for things like that. But I think the blend of this medical, surgical thing with community involvement and in a very technical environment was the thing which I pursued. And so far, my experience in community is very good. And there are like the people think that it's like the old school thing. The community ophthalmology is like taking the Jola and like the leftist in the politics. It's not like that. The things are evolving. The things are evolving now. Technology is supporting community ophthalmology, and it's far beyond just the cataract marketing camps.
Sumit,
Community
I just to
ophthalmology.
interrupt you,
Yeah.
I want to bring you back towards your masters in public health in London.
Okay.
More
Sure.
specifically about that.
Sure. If you want me to tell you about that, the foundation of that like decision to go to London School of Hygiene was again the community ophthalmology. After my senior residency, I had no option. There are fellowships in retina, cornea, and things like that, but there is no structured and well-structured course or fellowship of the community ophthalmology, which I wanted to do. I was doing many things like camps or the community outreach extension, but they were not systematic. I was not collecting the data. I didn't knew anything about epidemiology or statistics. So I found that the London School of Hygiene, this offers a public health, masters in public health, and they have a choice-based, like a choice-based credit system. They have the modules. So in my masters in public health, there were the core modules like statistics, health economics, etc. But the eye care specific modules like global eye healthcare, foundations of global eye healthcare programs, epidemiological principles applied to eye healthcare, things like that. And the most good thing was that you got to learn in the eye specific arena. You get to know the things about health policy, planning, financing, things like that. And our program directors and in UK the things are very integrated. The NHS, our program directors and teachers who used to come to teach the eye modules were from NHS. I think that's the reason why I went for this course, to make things more systematic. And there's a subtle difference. Before I went to LSHTM, for me there was diabetic retinopathy screening and glaucoma screening. But when I came back from there, learning the principles and practice of community ophthalmology in detail, I could vouch that it's not glaucoma screening. There could be no glaucoma screening, but a case detection. So from screening to case detection things, the small things I learned at LSHTM. And I think for me, that was a very good decision.
Great. So you mentioned the NHS, which is why I'm now going to jump to Dr. Apurva. Three specific questions. You've worked here and then gone to the NHS. For a person who's still training, what is the process of trying to migrate to the UK? How easy or how difficult it is? And how has your experience been working there?
So thank you for having me here, firstly. Am I audible?
Yes.
Yes. So in the UK, there's a centralized body called the General Medical Council. So that's the body responsible for giving you your medical registration and sort of supervising if you can work in the UK or not. So our primary medical qualification is accepted by the UK. So our MBBS degree is accepted by the UK, but not our MS or our DNB degrees. So the first step is to get registered with the General Medical Council as a doctor. So to register your MBBS degree with the General Medical Council, and it's a very structured process and approach. If you go on the website for the General Medical Council, they'll give you ways to register. specifically for ophthalmologists, if you have an FRCS Glasgow, so if you've completed an FRCS Glasgow, that allows you direct registration to the GMC. The second option is to give your ICO exams, the ICO part 1, 2, and the advanced exam. This is the recent one that's come on. So if you complete your ICO exams, you can apply for a qualification called MRCS, and then you just have to apply for MRCS after completing your ICO exams, and then you can apply for GMC registration. The path which I chose, because I wanted to sort of minimize the time there, is to give the PLAB exams. So the PLAB exam is the sort of exit level MBBS exam that people here give. So it's a very basic exam. It requires about a month of preparation. It's a part 1, and then it's got a practical component to it. So these are the 3 ways in which you can register as a doctor in the General Medical Council. Once you're registered as a doctor, there is a centralized website called NHS Jobs. So every job that is there in the UK in the NHS is advertised on this website. So you don't have to look at multiple places for opportunities. You just have to go on that website, type in your search for ophthalmology, retina, whatever your specifics are, and they will give you the jobs that are available. You can look through what their job requirements are. So what we can go there as after finishing our training or after doing some SRships is for a middle grade job. So which is like a registrar post, or which is because I had about 6 years of experience, 7 years in ophthalmology before I went there, I could apply for a post called specialty doctor, which is slightly above a middle grade post. So you don't need any other qualifications for that job. What you need is your work experience. So it's very, you look at a job on the website, you apply for the job, you can get called for an interview. Depending on that, you just land up the job and you go there. So that process is fairly well structured. And if anyone wants details, any of the audience wants details, I think my email address is my last name dot my first name. So it's goray.apurva@gmail.com. And I would be happy to help anyone, any trainee interested in doing that for further details, because I think it's just a topic which might just take too much time. So I think anyone is free to.
I agree. But I think that's the very, very concise and specific overview. Please.
About the second part about working here, it's really good. You get the concept of the NHS is that every patient should get the best available care. So you are always giving, the best care. So in terms of intravitreal injections, you'll be giving aflibercept. In terms of, you'll be doing the top end surgeries. There's no compromise on that. So as a person, as someone who's wanting to learn these techniques, it's a really good opportunity for you to come and learn these techniques. And because it's all in a government public health domain, there's no stringency. Like, no one is saying that, oh, let's not give this surgery to this person, or let's not give this to this person. If you're able to do it, you get to do everything. So luckily, there is a bit of luck as well. Luckily, I got placed in a place where my consultant was also from an Indian origin. I got to do VR surgeries here right from the first month that I was in UK. That may not necessarily be everyone's experience, but you will get good work here if your experience is good. And even if you're coming at a more junior level, you will sort of be trained here. That's the approach. So it's a very structured approach, and it's a good sort of way to either learn new skills or to work with the skills that you've already learned in India, but with better machines and with better organizations. That's it.
Right. Dr. Anirudh, I want to ask a question. So you've done a fellowship in the US, and then of course you came back. How is the process of applying for a fellowship abroad, especially a long-term fellowship? The ICO fellowships are definitely one stepping stone to getting into at least some sort of an exposure for say 3 to 6 months. What is the, how are there a lot of places that accept fellows from India or other countries, and what is the scope after that?
Thank you, Yosi. Thank you, Akshay, for having me. So if you talk about long-term fellowships, my experience has been that there are few countries which offer you long-term perspectives. And the first question you need to ask yourself is, are you going there for settling down in that particular country? Because that will govern your choice of doing a long-term fellowship. if you would like a long-term fellowship, let's say if it is US, then definitely you need to go through the correct or the proper pathway, which will be to complete the US MLE and however long it takes. So if it takes 3 exams, you should do it and be in the system, and then you get the long-term fellowship. For example, if it's UK, Apurva has already said that you need to clear their examinations and then be a part of the system. So if you are being, planning to go to any country for long term, it will be a time consuming process, and it will take easily anywhere between 1 to 2 years for you to be able to go to that country. So in such a situation, if you are in the final years of your training or residency, you should start planning right away, and you should have planning for at least the next 4 to 5 years, okay, if not less, if you plan to do a long term fellowship.
All right. So I mean, do you think, say for someone who's a little like, if you see in our panel, Dr. Manju, Preeti, all of them worked here, and even Srikanth for a while and then went out. So, do you think it's a good idea to probably work for some time here and then go abroad, or plan early and, start building up early? I mean, planning and executing your plans earlier itself.
I mean, it depends. There's no common final pathway. Each one has its own path. But I think if you have it in mind that you want to go out and you want to settle in that particular country, then there is no point working here and then going there. So let's say if you want to settle in the US permanently, or in any other country, then the working here and going there doesn't give you any additional advantage. So if you're confident enough after your residency or after your fellowships, then you can directly choose to go to a foreign country, and then you can take the call. Often what happens is that once you have completed your fellowship and you start working here, um, once you're in the system, working here in corporates or other places, you are very busy in the system itself, and then it becomes very challenging to go out, is how I would put it, because you will have a family, you would already know the systems here, you would be comfortable here. So if you have to make a move, then I think you should have that in mind, as early as possible, because the other considerations like family and those things also become really important at some point. So working here doesn't give you an advantage, but as I said, each one has its own path, and you may have awakening, or you may realize that your call is in a particular country at a certain point in your career, and that should not limit yourself. So if you're working here in India for, let's say, a couple of years, and that should not be a hindrance for you to go out. So I think you can make a move anytime, but it just depends on your personal situation.
Right. Preeti, I wanted to ask you a question. A lot of things in terms of how you deal with a patient is different when you're abroad, especially in the US. You don't have to think of things like, oh, this is an unaffording patient, I can't do an MRI, or I'll have to give a note saying please give discount and things like that. Those things are taken care of. But the actual science of what you do and how you diagnose and how you treat, is that on the same level, on the same page as you were there? And in a way, it would be like a validation of yourself that thank God I'm doing the same thing that I'm doing there. Or do you see an actual different way in the way they practice itself?
So my practice in India was in LV Prasad Eye Institute, which is a tertiary center, and we had access to subspecialty care. We had access to all possible investigations. So in that form, I don't think it's been a big difference. There are certain aspects, for example, genetics. So there are so many diseases where at some point in India we would suspect, that this is probably a OPA related optic atrophy, but there was no way to get that genetic testing just because A, the access, or B, the affordability. Here, for example, that would be much more accessible to me to get neuroimaging without having to think of whether the patient can pay. But having said that, it isn't as simple. That there are a lot of things which are insurance run. So while you may not think that the patient can't pay, you do structure some of your investigations and your billing based on what insurance the patient has. And that's something I'm learning with time here. So yeah, while some things are easier, there is greater access. So I would say certain higher end investigations, specifically genetic testing and some of the higher end blood investigations and things like that, are easier and more routinely available than in India. But the actual practice, coming back to your question, is largely unchanged. So I still do the same surgery. I still use the same parameters to treat and not treat someone.
Anirudh, you wanted to chip in, add something
Yeah.
to this?
Yeah, I think as far as the technology tools and the care that we give in India, I think it's at par. No other center across the world they are doing something which is superior technologically, or something which we don't practice. You definitely, like my previous speaker said, you have access to a lot of options in as far as investigations are concerned outside, but they have their set of limitations. It could be insurance, it could be the societal pattern, the behavioral pattern. So an American patient may have many more questions for you and may not be easy to handle compared to an Indian patient. So you have those issues as well. So I think it's not everything is the best outside. What we are doing in India is no less than in many countries.
I would just like to chip in, Akshay, if that's okay, for very quickly.
Sure,
I think
please.
what Anirudh and Preeti have said is really right. But just my experience has been from MAMC. It was a great institute to learn ophthalmology, and so for me there wasn't much difference in the practice in the two countries. But the problem with India is that not all institutions are uniform. You see, and we do know this, that there are institutes where you have all subspecialties, but there are some in which you only have one unit for ophthalmology, and so the difference here would be that everything is standardized. So no matter which place you are, say in the I can speak for the UK, and I'm sure for the US as well, that no matter which place you are, the everything is very standardized in terms of your learning and your outcome. So that is one difference.
So yeah, Apurva, we come from the same place as Akshay, so we know this very well, that you may not have all the standard in all places.
Yeah, and I think
Dr. Manju, I needed Preeti. I just want to bring one unique point out, and then I'll come back to you. For us, you now are operating primarily on patients in China, in a branch that is oculoplasty and aesthetic surgery. Learning, you're dealing with a new face, a new eyelid. See, the retina, the cornea remains the same, but not the eyelid, the face. How was that different? And that is something only you can answer here. So how did you train yourself? Did you have to specifically go through some courses, watch a lot of videos, or trial and error?
That's a very interesting question. Actually, when I was in Sydney Hospital, there were many Asian patients, so I had a idea that how their anatomy, especially in ptosis surgery, because it's totally different. The eyelid anatomy, even the DCR. If you look for if you do DCR in these cases, they're very shallow lacrimal fossa. The sac is too small. Sometimes it's so difficult to identify that. So anatomically, yeah, it was quite challenging. And since I had some experience before, so I could operate here. But still I feel that still there are a lot of things to learn. And if you look at the healing response, that is quite unpredictable here. In Caucasian, the good part is that if you operate them, you don't see any swelling next day post-op. But here it's like, so it's such a excessive swelling, inflammation is seen in these patients that you can't predict. You just think, oh, I might have done something wrong. I might have used some cautery, excessive cautery or excessive handling. But even if the surgery is uneventful, everything is fine. You're happy with your surgery, was next day suddenly you'll see, oh, it's the patient has so much edema. Then how will I predict the results of my ptosis surgery? So it's quite unpredictable. Yeah, but as so far it's like I'm here for about 1.5 years now, so I'm learning. It's like it's a constant process of learning. So yeah, and I'm doing these double eyelid surgery.
How long do you plan to stay back? Yeah. No, I want to know, how long do you plan to stay there, and what are you going to think of that is going to make you come back?
See, right, that opportunity is always there. I mean, we can always plan to return, since the training and everything is now
I don't know if Corona didn't bring you from China, I don't think anything can bring you back from China.
In fact, actually we planned a trip back to China when it was like in February, when it was everybody was scared of Corona. That time we traveled back to China. So now we are thinking we should stay for some time. Let's see, since we took that chance. So yeah, things are good as well. I mean, the practice is good, the hospital's setting is good, and all the facilities are available. So that way it's quite good for us. And both of us are working in the same hospital. That is added advantage. And obviously facilities are there, and obviously if you talk about the salary, that is also quite decent. So that way it's good. But yeah, the cultural background and all those things matters, and maybe in future we'll think about it. Haven't decided.
All right. So Anirudh, Preeti, and Apurva mentioned about how US and UK, you and even Manju said about China, how facilities, equipment is usually never a problem. Aarti, from your side, you went to rather, place, countries that are not so well equipped financially. I understand you were in a corporate chain hospitals, but is that representative of the condition in Africa where hospitals are understaffed and under-equipped, and or there are now things are changing and there are better opportunities?
So let me tell you what the situation is in that country, Ghana, where I worked. So there were lot many cornea patients, and organ donation is not allowed in that country. So the unavailability of cornea was biggest challenge. To get cornea is not an easy thing. So I had to get corneas either from Sri Lanka or USA. That involved huge cost. The cost of cornea from USA was $500, and the shipment charges were $200, so making it total of $700 for a patient. And other than that, the added cost which the hospital will charge. So I had to collect 10 patients, and I had to order 10 or 7 or 10 corneas in a day. And I used to start surgery in the morning, finish till 12 o'clock in the night. So it was not an easy thing to do with no other help, no other corneal surgeon in the country. So even if I'm tired, I don't want to operate, I can't give up. I had to do the surgeries. Getting even viscoat was a challenge. So I had to either order it from India and keep it in stock, or manage without viscoat. So availability of resources is very difficult thing in Ghana. Beside that, you don't have any experienced seniors over there. So I don't doubt the skills of Ghanaians doctors there, but it was just that you are trained in India, you have seen how your seniors, how your teachers deal with the complications, and then I used to get reference or even persistent epithelial defect. So it was like I don't have anybody to send my patient to. So it was like I have to do myself or just give up. So I had no option, but that was a big thing I learned there. So if I've advised MRI to a patient might not come back to me for 8 days. It's not that he can't afford. It is just that the MRI machine is not available in the particular hospital, or the waiting period is of 10 days. I sent a patient of microadenoma to a neurosurgeon, and patient said, "Can you refer me to India? Because the doctor can't see me for a month." So it's like there are too many things to be done in that country, not only in ophthalmology, but in other specialties as well.
Right. Thanks. Dr. Srikanth, you're the only one here who worked abroad and has come back here. So what were the things that you liked about working there? And why did, eventually what made you decide I have to come back, or you felt that this gig is done and have had my share of fun?
Yeah, so work-wise, I was pretty happy with working there because, as Dr. Manju had mentioned, it's a high-end hospital, private hospital, with every possible facility available. You don't need to go around asking for little things. And as the working days were only 5 days a week, that again was something which was new for me, and it was also the quality of life was much better because 2 days of rest is, again, I felt very important for your personal life. Apart from that, the only issue which I had was, it was quite personal for me, because in the sense that I was staying alone there. My wife is an oncopathologist, and initially we thought of moving there completely and getting a job for her there as well. But it so happened that she would require to know Chinese, and for her to get a job in any of those public hospitals, or because there weren't many international hospitals that were offering jobs at that point of time. But over a period of time, there are many international hospitals which are coming up there. and they do require a lot of international specialists and doctors as well. So I feel over a period of time, the requirement for many Indian doctors will also increase there. The demand for the Indian doctors will also increase there over a period of time. But for me to come back, the main reason was more of a personal reason rather than any professional, because the work which I was doing here was the same as I was doing there as well.
Right. I think we'll wind up. Dr. Sumit, I just wanted to know, do you think more people should be taking public health and epidemiology? And you mentioned how it has transformed your way of thinking in terms of moving away from camps to focusing on case detections. So what message do you think you want to give people to think about community ophthalmology and more specifically public health as a very viable career option?
I think, Dr. Akshay, it's a very good question. And as far as I basic knowledge of the statistics, health economics, and epidemiology, and I've seen at LSHTM, they offer many short courses of 3 months. And I've seen myself many experienced doctors from LV Prasad, Shankara Nethralaya, and very prestigious institutes. They come over there and have their short courses. So these are very little things, but if you have interest, passion to the research and academics, I think these are basic minimum essentials, and we all should have that aspect. That humanity, it also adds to humanitarian aspects to our overall, and it increases our networking and connect with the patients. So I think yes, we all should have that small chunk of public health in our any type of practice we have.
Right. I think that is time for us, and I really appreciate all you people from different time zones, Far East and North America, for having come. Preeti, I know it's really late now; it's almost early morning, so you might as well stay awake now. Thank you, Shrikant, Anirudh, Aarti, Apurva, and Sumit, and Manju for your time. I think it was really fruitful, and I'm glad it was the last session, so we didn't have anyone telling us to wrap up soon.
Thank you, Akshay. Yeah.
Thank you, Dr. Akshay.
Thank you.
Devakant and Karan, the stage is yours.
Maybe we can have a couple of words from Namrata ma'am regarding the experience of the conference.
Dr. Namrata ma'am, are you there?
Okay, so we can also have Digvijay sir. Maybe you can say a couple of words to conclude the conference.
Yes, indeed. I think it has been a wonderful session. Lots of viewers, and I think probably something very useful to all the young ophthalmologists, to all of us, me especially. A lot of things I've learned in this process, and I thank Dr. Namrata. She's been joined with us throughout, but I think she has other engagements in between as well, and AIOS for the opportunity, and the entire team YOSI for working so hard. Devakant, Karan, and everybody else in getting this program together. And it has indeed been wonderful. And I do want to hear from Devakant his experience of putting this entire thing together before we close.
Yes, as you have mentioned, it has been a learning experience for all of us, and everything has been so smooth. And I thank all the panelists, moderators, and speakers. So, apart from this last half an hour, I think we have been dot on time, and we let this flow because the discussion was so good, and all of us wanted to hear it. So, we'll not hold anybody more because it's a Sunday afternoon. So, Karan, any words from you before we will just wrap it up?
That's fine. Thank you, everybody.
Thank you.
And we would, of course, like to thank Omnicuris and Kripal from the AIOS and the AIOS team for taking out the time and putting this whole thing together, and for the sponsorship for that. Thank you.
Thank you.
Bye, guys.